Madras Medical College and Diabetes Association of India, Southern Chapter. I gladly welcome you all for our third National GDM Awareness Day program.
Hello.
We will be now starting our very informative CME program, which has been divided into 4 sessions, and we will have the inaugural function from 11:30 or as soon as our health secretary joins us. So, to begin with the first session, I request our chairpersons, Dr. R.S. Hariharan and Dr. Cynthia Alexander, Madam, to kindly take over from here. Thank you, sir. Thank you, Madam.
Thank you, Dr. Pushpa, for the invite. And so on behalf of my co-chairperson, I wish, sir, the organizers and the participants a very happy Sunday morning. And as we celebrate GDM Awareness Day, we salute our mentor, Sir Professor V. Seshaya, and the August team for having brought about a revolution, thereby cutting down the onward transmission of DM to the coming generations. We look forward to a day of learning and retrospection. So I invite the first speaker of the day, Dr. Vijaya, to speak to us on COVID-19 and GDM. Over to Dr. Vijaya and for introduction. Dr. Vijaya?
Good morning, Madam.
Vijaya, your introduction,
you know me, Madam, just introduce, not a problem at all.
She's the director of the Institute of Obstetrics and Gynaecology. And during this COVID, a real frontline warrior she was, looking after all the pregnant ladies, sending both mothers and babies home safely. So over to Vijaya.
Yes, ma'am.
Very first
is my screen visible to everyone?
Yes.
Yeah.
Madam.
Yes, sir. Good morning, Seshaya, sir.
Morning.
Yeah. I'm extremely honored to open the talk on GDM and COVID-19. I'm extremely privileged to have associated with Madras Medical College, we the Institute of Obstetrics and Gynaecology and the Institute of Diabetology, Madras Medical College have great pleasure in conducting the CME. And coming to my talk, this is the need of the hour and how we struggled with the GDM patients and COVID-19 together. Let me start this topic. You all know the hyperglycemia in pregnancy, according to 2019 statistics, is 20.4 million, the prevalence. And GDM, it is a crucial role because it leads to adult onset diabetes and obesity. And the COVID-19 pandemic has adversely affected the medical community. We can even say it become an epidemic of diabetes because of the sedentary lifestyle and increased rate of consumption because of work from home and quarantine and a reduced ability for screening. So coming to the statistics of IOG in 2012, during the COVID times, we had around 379 GDM positive mothers, and the prevalence was roughly around 379 by 14996, it is around 2.8. And of the 379 women admitted, 31% required medical nutrition therapy, and 6% were treated with OHA, and 62% needed insulin therapy. The prevalence is perhaps seems to be less, maybe because of the zoning, and patients have started going to RSRM, KMC, and it has been diverted according to the zoning. That is why maybe the prevalence of GDM at IOG has come down in 2020. And compared to the 2019 where it was 2015. 1 second, sir. Your screen. Coming to the screen, OGCT screening, because we have started getting our case only from April, though we were expecting it from the COVID pandemic started in November 19, but we started getting our first case only from April. At that time, the screening percentage was 12.2% in January, and in February it was 12.6%. And post like when it was a peak, and then from October 2020 slowly the COVID cases started coming down. The prevalence has comparatively increased to 17%, and in November it was 11, and in December 2020 it has come to 15%. Actually a rise of OGCT screening positive observed after COVID pandemic. And coming to the admissions of GDM and COVID, we have done the COVID positive pregnant mothers are around 715. Those were in the early trimesters, and those were referred from private hospital after the delivery. But actual COVID cases we delivered is 576. Still, it is the number one in whole of Tamil Nadu. We had around 4% of GDM and 1.5% of pre-gestational diabetes mellitus. And the number of GDM deliveries, as you can obviously see, there was a slight increase in cesarean section rate because of the transmission due to normal labor. We were a little scared. And then the birth weight is, of course, very good birth weight between 2.5 to 3.5 kg. And actually, coming to the pathophysiology, as per the recent data, though pregnant women do not appear to contract the infection, pregnant women and children, but pregnancy-related physiological changes definitely influence our immune system, leading to severe symptoms, particularly in the third trimester. And the fear of vertical transmission still exists. We have conducted a study of vertical transmission, taking the samples of amniotic fluid and placental swab and cord blood, and the day zero nasal swab of the baby, and also on day 3 the breast milk, and again the nasal swab of the baby. And we have taken around 500 samples, but the risk of vertical transmission is very, very negligible, maybe less than 0.01%. We are yet to publish our study. And coming to the pathophysiology, because of the dysregulation in the glucose metabolism, there is a lot of endothelial damage and tissue hypoxia, and more of oxidative stress and increased cytokine production, leading to multi-organ dysfunction, increased thromboembolic risk, and there is a lot of interstitial lung damage, leading to increased mortality. And because the dysregulation of glucose metabolism definitely play a role in COVID morbidity and mortality. And because of the beta cell damage, even at admission, there is more chances of hyperglycemia, leading to worsening of metabolic control. And there are also new onset of diabetes during COVID times, and leading to invariably coagulation defects and renal disease and obesity. So everything points towards hyperinsulinemia, leading to dysfunctional immune response and hyperinflammatory state, and leading to multi-organ failure. The problems we encountered about screening during COVID times is the waiting time. Nobody wants to wait, neither the doctor nor the pregnant woman, because of the fear of transmission of the COVID. And also after the diagnosis, need to come often to the hospital. That also has some fear for the pregnant mothers. All this carry exposure risk during a pandemic. So what we did was prioritize the women of high risk, and we have restricted the antenatal visits at 12 weeks, 20 weeks, 28 weeks under delivery, and we have concentrated more on specificity than on sensitivity. So comparing to the screening in UK, Canada, and Australia, they've all done the glucose measurement at 12 weeks only by hemoglobin A1C or fasting blood sugar, and again at 28 weeks by fasting blood sugar random blood sampling. And again for the postpartum testing, they have delayed by 6 to 12 months instead of doing at 6 weeks postpartum. So the national recommendations for Australia, Canada, and New Zealand, the screening strategy they use hemoglobin A1C, RBS, and FBS during the routine antenatal booking, and also at 28 weeks. But these lack the evidence based and the sensitivity of our OGTT. So what RCOG recommends is at 18 to 14 weeks, when the patient comes for the first booking, do either the hemoglobin A1C or random plasma glucose. And if it is more than 6 or the RPG is more than 200, you consider them as diabetes in pregnancy. Or if they are in between, the values are between 5.9 to 6.4 or between 162 to 200, you label them as early GDM. And again, you retest at 28 weeks when they are coming for their routine checkup, and you segregate the patient based on their hemoglobin A1C value and fasting blood sugar or random blood glucose. You label them either as GDM or no GDM. So the problem with the DIPSI test, what we do here is taking the 75 grams and after 2 hours 140. What we have channelized is we ask the patient to take the glucose at home and do the self-monitoring of the blood glucose, number 1. Number 2, she can come to the OPD and go home and do the test in the nearby facility. Or some people are given as glucose sachet and ask them to drink at home and come exactly after 2 hours. So these were the things that were followed. But actually in IOG, what we were doing is during COVID times, we were doing only the random blood sugar sample. And if it is more than 140, then we label them as diabetic and started further screening. So the diet, there's not much difference between GDM during COVID times and the other times. But the main important thing is the protein, which is the booster for immunity. So we advise a little increase of protein intake and as usual, avoiding the high fat diet, and vitamin C, zinc, vitamin A, D, E, and selenium. These rich foods are especially preferred and advised to the patient. And of course, the ginger, garlic, and citrus and spinach, they support the immune system. Garlic especially was taken much about the reducing the inflammation and stimulating the immune response. And monitoring, patients are advised to have a self-monitoring of the blood glucose periodically. But according to WHO, at GDM, hemoglobin A1C is not much recommended. So they have to follow the every 2 weeks self-monitoring of blood glucose between 24 to 28 weeks, and after 28 weeks every week till delivery. So how the RCOG recommends is do the at diagnosis, you do the blood sugar value and also the ultrasound, and always the remote consultation was more favored during COVID times. In COVID times, if the patient is of low risk and if the blood sugar is well controlled, we can do a remote consultation, and even at 36 weeks only remote consultation, or whenever the patient goes for the antenatal checkups in the community, and then you plan for the delivery. Whereas in the high risk case, the patient with a comorbid, or if the patient is already on anti-diabetic or on insulin, we have to do the facility-based and opportunity-based checkup of the blood sugar level whenever the patient comes for antenatal checkups. And then you have to, at 36, we have to have a face-to-face obstetric review at 36 weeks and then plan for the delivery. So this is the nutshell. The glycemic targets are reached, and if there are no additional risk factors, we can have an obstetric review at 36 weeks and plan for delivery. And if the glycemic controls and the growth parameters are not met, or if there are additional risk factors, the face-to-face obstetric review is much more needed. And you all know that COVID-19 infection has severe maternal morbidity because the rate of cesarean delivery is also high. Higher dose of insulin is needed because the infection has a more effect on the beta cells. And metformin it should be continued in GDM mothers who are already on metformin because it definitely has a palliative effect against infection. And steroids are used. We all know the insulin dose needs to be adjusted. The telediabetology and the online OPD service definitely played a major role during COVID times, especially the e-Sanjeevani, where we started, and there are a tremendous response of people coming on online and asking us the doubts. And this is a one case where we had during COVID times, the patient conceived a 29-year-old primey, and she was diagnosed at GDM in June 2020, where the COVID peak was very high, and her fasting blood sugar was 95 and postprandial was little high. So she was advised medical nutrition therapy, and she was not able to come for the visit due to lockdown. And we treated her via telecommunication, and we motivated her for self-monitoring. And 2 weeks later, fasting and postprandial has come down, and we have always advised her pre-meal and post-meal monitoring, and all the pre-meal and the post-meals are maintained within the normal limits. And this is a chart she has maintained, and she used to send through WhatsApp. And then she was started on metformin, and good glycemic control was achieved. And she came to us for a face-to-face checkup at 32 weeks, and growths were normal. And again, the patient was asked to come at 37 weeks, and she delivered an alive girl baby. Just to show you the effect of teleconsultation during COVID times, not only the antenatal checkup, also the lactation checkup, the postpartum visits, the postpartum control, everything was done through online. So the telecommunication has the pros of alleviates the need for face-to-face visit, and the GDM responds well to lifestyle changes and medication. But the cons is there is no human touch. The patient would like to come to us and talk to us at least for a few minutes before taking the medicines, either the insulin or the metformin. So that is the one. And you cannot. There may be related errors in measurement of blood pressure or blood glucose. So all these factors could deter the physician from aggressively escalating the therapies to reach the glycemic targets. So the National GDM Awareness Day is a single blood sugar test. It saves multiple generations from diabetes and celebrated on 10th March. Thank you for the wonderful opportunity.
Thank you, Vijaya, for that very informative and very empathetic way of approaching our patients.
Thank you, ma'am.
Thank you very much. Now I request my co-chairperson to take over, Dr. Hariharan, sir.
Thank you, Professor Scindia.
Yes, sir.
Respected Professor Viseshaya, the father figure of diabetes and pregnancy in India. My co-chair, Dr. Cindy Alexander. Members of the organizing committee and office bearers of the Institute of Diabetology, Madras Medical College, Institute of Obstetrics and Gynaecology, Madras Medical College, and Southern Chapter of Diabetic Association of India. Ladies and gentlemen, at the outset, I would like to thank the organizers for giving me this opportunity to chair this session along with Professor Cindy Alexander. I'm indeed privileged to be associated with today's CME program, got up to commemorate the National GDM Awareness Day on 10th March to coincide with the birthday of our beloved Chief, Professor Viseshaya. I wish to make a few observations briefly before proceeding with the session. One, Professor Viseshaya has a unique honor in that his birthday has been declared by the Government of India as the National GDM Awareness Day in recognition of his contribution to diabetes and pregnancy. I am not aware of any other individual in this country who has been so honored. Secondly, he recently was also honored by the Tamil Nadu Dr. MGR Medical University with the award of Distinguished Professor for Lifetime. We are indeed proud of you, sir. At this juncture, I wish to recall what late Professor A.S. Tambaya used to say. A medical institution is either solvent or insolvent, depending upon the priorities. A solvent institution is one which has its priorities right, namely patient care first, medical education next, and research later, in that order. An institution that has its priorities in the reverse order would be insolvent. Professor Viseshaya brought to bear these priorities right in the Department of Diabetology, Madras Medical College, and Institute of Obstetrics at Timor. After providing patient care first, followed by education, culminating in research. And that research for is now internationally recognized and acclaimed. I wish Professor Dante Maduranayagam was alive today to see all this, because he often used to say that no worthwhile discoveries have ever been made from Madras Medical College after Donovan discovered the Leishman-Donovan bodies from the Madras Medical College. It is to our fortune that most of us have been able to rub shoulders with him over the past 4 decades. We pray for your continued good health, long life, and continued guidance in the years ahead. Now, moving on to the next talk in the session, I invite Dr. Charles Bronson, Assistant Professor of Diabetology at Stanley Medical College, to go ahead with the talk on metabolic parameters in children born to GDM mothers. Dr. Charles Bronson.
Is my screen visible to everyone, sir? Am I audible, sir?
Yes.
Yeah.
Am I audible, sir?
Yes, audible.
Yes.
Audible.
நம்மளுக்கு கேட்கலையே மீட் பண்ணிக்கணுமா பேச கேட்கலையே
Good morning to everyone. Respected Professor Seshia sir, respected chairpersons Professor Hariharan sir, Professor Cynthia ma'am, and honorable members of the implementation committee of GDM Awareness Day, Dr. Rajendran sir, Dr. Paneerselvam sir, Dr. Bhavdharani ma'am, all of the senior colleagues and friends. Today, I've been given the topic on metabolic parameters in children born to GDM mothers. So, moving on to the topic, and as we know, the diabetes is a non-communicable disease pandemic that is sweeping throughout the world. And in 2019, the International Diabetes Federation estimated that 1 in 11 adults throughout the world, they live with diabetes. And surprisingly, 1 in 2 adults with diabetes are undiagnosed. And with pre-diabetes, 1 in 13 adults over the world are living. And as we see, 1 in 6 live births are complicated by hyperglycemia in pregnancy. So if you see the number of people who are affected by diabetes throughout the world, it is progressively increasing, and there is no reprise from that. It is gradually going on in millions of numbers. And if you see the burden of diabetes throughout the world, in 2019, it's estimated to be about 463 million people. In 2030, it's projected to increase to 578 million, and to 700 million people in 2045. It's almost 51% increase in the number of people. And coming to our country, India, in the Southeast Asian region, India is a very important country for the IDF. And in India, 1 in 11 adults have been estimated to have diabetes. And 1 in 6 adults with diabetes in the world have come from India. And if you see the arrow mark there, down there, 1 in 4 live births in India are affected by hyperglycemia in pregnancy. So with this introduction about the epidemiology, I move on to the topic of metabolic parameters in children born to gestational diabetes mothers. We will discuss it as an immediate effect on the child and the long-term effect on the child. So hyperglycemia in pregnancy, to make some terminology is clear. Now the FIGO, that is the Obstetrics Federation, as well as the WHO, classify the hyperglycemia in pregnancy as follows. They have introduced a broad term called hyperglycemia in pregnancy, under which they have put forward a gestational diabetes mellitus, a typical gestational diabetes, that is a newly detected new onset diabetes in the setting of pregnancy that takes place around 4 to 5 months or 6 months, like that. And the second thing is the diabetes in pregnancy. Diabetes in pregnancy, that is DIP, could be either a pregnant woman who got a previously known diabetes, that is was called as pre-GDM, or diabetes complicating pregnancy, or hyperglycemia that was first diagnosed during pregnancy, but it meets the WHO criteria for diabetes in the non-pregnant state, that is an overt DM detected in pregnancy. So with this terminology, we will now see the issue in the infants born to GDM and the diabetes in pregnancy mothers. And these problems include respiratory distress, growth abnormalities like macrosomia, growth restriction, hyperviscosity due to polycythemia and erythrocytosis, and especially the congenital malformations, including neural tube defects, anencephaly, the specific caudal regression, subtle defects, renal agenesis, etc. And finally, the metabolic alterations, especially hypoglycemia, hyperbilirubinemia, hypocalcemia, and hypomagnesemia. And we'll talk specifically about the metabolic alteration in the short term as well as the long term. And we should note that the overall perinatal mortality hyperglycemia in pregnancy is increased by about 2 to 3 times in the infant of the diabetic mother. And these neonatal deaths are mainly due to hypoglycemia, respiratory distress, polycythemia, and jaundice. Coming to hypoglycemia, neonatal hypoglycemia occurs in almost half of all diabetic pregnancies. It's initially a transient phenomenon occurring in the first 16 to 24 hours of life. It also occurs in preterm births in small for gestational and large for gestational age babies. And in macrosomic infants of mothers with diabetes, what happens is, because of the hyperglycemia, the beta cell of the fetus undergoes hyperplasia, and it causes postpartum hyperinsulinemia, And this hyperinsulinemia shut down the hepatic glucose production in the fetus. And as after delivery, the continuous supply of glucose which the fetus has been getting from its mother it gets stopped. So the newborn develops hypoglycemia. And the most cases occur in the first 24 hours. The infant could be asymptomatic, or it can show some symptoms like jitteriness, irritability, poor feeding, a weak cry, hypotonia, or even a frank seizure activity. And in case the hypoglycemia requires an intervention, it may persist even as long as 1 week. And we should note that if the maternal blood glucose concentration remains high during labor, the risk of hypoglycemia increases when the child is born. So it could be minimized by keeping the maternal glucose of less than 144 during labor. And there is also a debate about the definition of which constitutes neonatal hypoglycemia, whether it's around 40 milligram or 45 milligram. Both are accepted and both are being treated accordingly. And we should note that the CBG readings, sometimes they have a poor precision values at low values. In case the hypoglycemia suspected in a neonate, better to go with an urgent plasma glucose determination in a lab accredited method. And the neonatal hypoglycemia affects about 5 to 15% of otherwise healthy babies. It is widespread in resource-poor countries where immediate resuscitation measures were not available. And it's very important to see that the early feeding by the mother to the baby reduces the risk of hypoglycemia. So as far as possible, mothers with diabetes should be encouraged to breastfeed the newborn within 30 minutes after birth, then every 4 hours, till a pattern of feeding is established between the mother and the child. And in persistently low blood glucose despite the oral feeding, or the blood glucose is very low even at the initiation, or in especially clinical signs are present, even IV glucose could be considered. And wherever suppose if a glucose gel is available, it could be applied to the buccal mucosa in an at-risk infant, and it may reduce the risk of hypoglycemia by half. So going to the next thing, the neonatal erythrocytosis. And the infant of diabetes mother commonly have an increased hematocrit. This hematocrit is recently called as neonatal erythrocytosis. Previously, and many times it's also called as polycythemia, though the earlier, former term of neonatal erythrocytosis is preferable. And this phenomenon is attributed to fetal hyperinsulinemia as well as to chronic fetal hypoxia. And the child may have a ruddy appearance and a sluggish capillary refill. The point here is because of the erythrocytosis, there is a hyperviscosity that can develop, and it may increase the risk of the neonate for stroke, seizures, and other complications like necrotizing enterocolitis and vein thrombosis. And coming on to the next thing, the hyperbilirubinemia. It's a common effect, and especially it occurs with erythrocytosis. Because of the erythrocytosis, there is an increased red cell mass, increased turnover, and there's an increased bilirubin burden as it's presented to the fetal liver. The fetal liver is already immature, so it cannot handle the increased bilirubin burden. Other factors like birth trauma, hemolysis, and immature hepatic uptake, etc., can also precipitate. And here the unconjugated bilirubin is increased. In this condition is termed as hyperbilirubinemia of the newborn when the levels are typically more than 10. And in macrosomic babies, such jaundice is common. And this treatment includes phototherapy, pharmacological therapy, and exchange transfusion in high-risk babies to prevent the formation of kernicterus. And other electrolyte abnormalities like hypocalcemia and hypomagnesemia. Hypocalcemia or hypomagnesemia may also be apparent in the first few hours after birth. Symptoms might include jitteriness or even seizure activity. And in infants born to diabetes mother, calcium and magnesium levels, especially when suspected, should be measured within the first few hours after birth. And the true symptomatic hypocalcemia, clinical hypocalcemia, is very rare. However, sometimes the hypoglycemia itself, when it's associated with some asphyxia and other CNS problems, it may present like a hypocalcemia picture. And in severe cases, calcium gluconate might be considered. And the research says that about 65% of all infants of diabetic mothers have some abnormalities in iron metabolism because of the redistribution of iron. And this iron deficiency increases the infant's risk for neurodevelopmental abnormalities. So having seen the acute effects, as if these acute effects of diabetes is not enough in an infant, there are also certain long-term metabolic impacts on the infant or the child born to a mother with diabetes. So as we move along with this, to understand these metabolic implications, we'll go with the theories and the hypotheses that are well known and also under formulation. So the first hypothesis is Pedersen's hypothesis. It was proposed by Jorgen Pedersen from Copenhagen, Denmark. What Dr. Pedersen said was that whenever there is a maternal hyperglycemia that occurs because of insulin deficiency and insulin resistance, This hyperglycemia crosses over the placenta to the fetus and it becomes fetal hyperglycemia. This fetal hyperglycemia stimulates the beta cells of the fetus. It causes beta cell hypertrophy as well as hyperplasia. And this hyperinsulinemia, it results in hyperinsulinemia. This hyperinsulinemia results in increased lipid accumulation, and it causes adiposity, increased birth weight, macrosomia, and ultimately it may even lead to diabetes in the offspring. So this is Frankel's hypothesis. The next hypothesis, Frankel's hypothesis. Dr. Norbert Frankel from America, he proposed this hypothesis in his Banting lecture in 1980. It was termed as of pregnancy and progeny. Frankel's hypothesis is further development of Peterson's hypothesis. Frankel was among the first to introduce the concept of the vicious cycle. Dr. Frankel said that the excess pregnancy fuel substrates, including plasma glucose, amino acids, lipids, etc., they alter the homeostasis and they cross over to the placenta and they have the potential to cause adverse effects. For example, in this figure, we see that whenever the mother has got an insulin resistance or an insulin deficiency, there is an increase in the substrates. That is, the plasma glucose, the amino acids, and the lipids, they are increased in quantity. They cross over the placenta. There is an excess of mixed nutrients. There is an hyperinsulinemia. And in the fetus, it causes macrosomia. In the neonate, it causes hypoglycemia. And in the child that grows up beyond the neonatal period, it causes insulin resistance, obesity, impaired glucose tolerance, and even DM. That is, when the child becomes an adult, he is likely to become a diabetic. So Frankel hypothesis that among the women with GDM, the effect of pregnancy hyperglycemia on the fetal beta cell might have intergenerational effects. It not just affects the mother, it not just affects the child, it may even pass on to the future generations. That is what Norbert Frankel put forward. And in 1992, Barker and Hales, Barker, he formulated the fetal origins of adult disease hypothesis. And in 1992, David Barker and Charles Hales, they put forward thrifty phenotype hypothesis. According to this, whenever there's an intrauterine maternal malnutrition, the child becomes small. That is the intrauterine growth restriction. In that altered or malnutrition metabolic milieu, the child gets adapted to that intrauterine milieu. So what happens is the child, when it comes out of the womb, it gets adapted as the child grows up, and when the environment changes, whenever there's plenty of food, the child gets maladapted to the environment, and the child tries to gains weight and becomes obese. It develops insulin resistance, and ultimately it develops IgD and diabetes. So what we see, let's see on the left side, there is a pregnant woman. What happens here? That is, in pregnancy and inside the womb, it affects the newborn, it affects the toddler, it affects the infant, it affects the child, the man, the elderly man, and even up to the end of life. So low birth weight can be taken as a surrogate marker of poor fetal growth and nutrition. It's linked to coronary artery disease, hypertension, obesity, insulin resistance, and diabetes. So there was another hypothesis that was put forward in 1999 by Hattersley and Took. It was called the fetal insulin hypothesis. The thrifty phenotype says that there's a poor maternal nutrition, there's a decreased supply of nutrients, leading to a restricted fetal growth and lower birth weight, and intrauterine programming of metabolism, leading to a higher onset of adult onset of type 2 diabetes. On the other hand, on the right side, we see the fetal insulin hypothesis put forward by Hattersley and Took. They said that there are some genes, there are epigenetic modifications that influence or decrease the insulin secretion as well as the insulin action intrauterine. So it causes a decreased fetal insulin mediated growth of the baby, and it also decreases the capacity of the baby to secrete insulin. Both cause low birth weight. When the baby comes out of the womb and gets exposed to the environment, the baby is unable to compensate for the nutritional supply and develops diabetes. So ultimately, gestational diabetes serves a harbinger, that like a herald for the vicious cycle of diabetes. So, for example, if you start from the left end, there is a young woman with the diabetes or who is at a high risk of developing diabetes. When she becomes pregnant, she becomes a woman with a GDM. There is an insulin resistance, pancreatic beta cell dysfunction, and this woman has a higher 5-year increased risk of developing frank diabetes in the future. The child whom the woman is carrying also has a higher risk of developing diabetes when the child is born and he becomes an adult, an adolescent, then an adult, and he goes on in the life. So this is a vicious cycle. So one generation is affected, it affects the other generation, it further affects the next generation. So the This diagram beautifully illustrates. Here we see a pregnant woman. The pregnant woman carries a child in the womb. That is probably a daughter. What they are saying is, when you are pregnant, you are also pregnant with your grandchild. What they mean to say is, the mother has got a child, the child has got her ovaries, and the ovaries has got the gametes, that is ova, which is nothing but a grandchild. What they mean to say is that the health of the mother affects not only the health of the child, but it also affects the health of the grandchild. That is the future generation. Every future generation is affected by the health of one single mother, what we see today. That is what they are putting forward. So, recapitulating what we saw in the earlier slide, in the world, the 463 million now of diabetes patients might become 700 million in probably around 25 years. That's 51% increase. This 51% increase, if you see superficially, it might appear it is because the IGT people develop diabetes, or because of improved improved techniques with more sensitivity to catch people with diabetes, etc. But if we analyze closely, we will see that this 51% increase will also occur because of the GDM mothers becoming frank diabetes in the future, and also because of the children what the GDM mother might be having in her womb. When the child becomes, after 25 years, he becomes a 25-year-old man or a 25-year-old woman, and the next 10 years he becomes a 35-year-old man or woman, he will develop diabetes in the future. So this extrapolation of 2019 and 2045 is the major chunk will be contributed by the GDM and the pre-GDM mothers. So this should be taken into account. So as we see this, for this reason, as I conclude, I would put forward something said by our Professor Seshia. Having seen the importance of the intergenerational transmission of metabolic adverse effects, Professor Dr. Seshia says that focus on the fetus for the future, for the betterment of the future. If we focus on the health of the mother at the outset, at the immediate point of care, and it directly impacts the fetus. So that is, we are focusing on the fetus for the betterment of the future. So I take this chance to introduce this terminology called Seshia's dictum. I propose this terminology, and I hope that this terminology will be used in the future in medical communication, as well as will be adapted in the medical parlance. Thank you very much.
Thank you, Dr. Charles, for that very lovely talk. And thank you for creating the awareness of breaking that vicious cycle. And that dictum will now come into place. And for that, it was all the forethought of our Professor, Dr. Seshia, to whom we are all very grateful. And many mothers in future generations also will be grateful. So thank you very much.
Thank you, ma'am.
Sir, Dr. Hariharan, sir.
Yeah, I should congratulate both the speakers and also Dr. Charles Bronson for very, very figuratively bringing out the effect of intergenerational transfer of diabetes. Yeah, should I say, a subject very, very dear to Professor Seshia. He has been emphasizing on this for the past over a decade. Now it has borne fruit. We want to emphasize that the thing should start in utero, the in uterine environment, in future prevention of diabetes. I think that is where the prevention should start in vitro. At this juncture, I would like to recall one usual statement that Professor Moses used to make: the child is not a miniature adult. That applies very much to an infant of the diabetic mother, because ordinarily in our days, we used to say prematurity is based on the birth weight of the child. A child born less than 2.5 kilos is premature. A child of normal weight is mature. We know from infant of the diabetic mother and infant of the gestational diabetic mother that even though the child is large, macrosomic, it is premature. That is where exactly your immediate biochemical abnormalities that occur soon after delivery take place. So even though the child is large, it is premature. I think that one point we have to emphasize, that size of the child or the weight of the child is no criterion to define prematurity or otherwise. Next is about, he emphasized on early feeding to ward off the neonatal hypoglycemia. I think one point what is important is early breastfeeding, because you know the value of colostrum. the first milk has so much of not only a nutritional support, but also the immunological support to the child. So the value of early breastfeeding and continued breastfeeding for the prescribed time. I think with that, any question from the floor?
Hari,
Yeah.
as you said, both the lectures were excellent.
Yes.
And being in institutes, I just suggest them to have statistics
Yes.
of how many deliveries of GDM has taken place every year, and what was the birth weight of the babies, and during COVID, how many COVID cases they have managed, and what are the factors that affected the infant at birth. You said hypoglycemia, hypomagnesemia, so many things. I think it is only a suggestion,
yes,
not finding faults.
Right.
Next year, we should hear that. It's only, both the speakers have spoken extremely well.
Quite right.
Congratulations, Charles. And more you have brought out this time. Congratulations to you and Madam Vijaya.
Thank you.
That's all. That's only a suggestion.
Yeah.
Yes, sir.
Thank you, sir.
So if there are no other comments or questions forthcoming, I would like to hand over to Dr. Sundaram for the next session. Dr. Sundaram, you can take over the next session.
Yes, yes.
Yeah.
Want the list of speakers.
Pushpa.
Paneer.
Yes, sir.
First speaker.
Dr. Bhavadani will introduce you, sir.
Okay, sir.
Dr. Sundaram is a former professor and HOD, retired government Hill Park Medical College, and he is now the professor and HOD, Department of Medicine, Tagore Medical College, and he has
retired.
Things about Professor Sundaram is he has given the free insulin for juvenile diabetics in Tamil Nadu. The GO has been passed in 98, and he is the first one to start the nurse education course. Throughout the country, he is the first one to start at Hill Park Medical College. This training course is for nurses in the first of its kind in the government sector in India, and he is had the first preventive foot care clinic at a cost about 15 lakhs, established with the help of World Diabetes Foundation, declared open by Her Highness the Princess of Denmark at Hill Park Medical College in Chennai in 2004. And he has a Lifetime Achievement Award from MGR Medical University, and above all, he is the great teacher of all of us. Over to you, sir.
Thank you very much. First speaker name and first
Sir,
So
speaker.
Dr. Anjalakshi and
I
then
want
Dr.
to introduce
Vijayan Balaji.
the coach.
Okay.
Madam
Dr. Pushpa, Dr. Kalevani also to be called in.
Yes, sir. No, sir was asking the speaker's
For the
name.
past 22 years,
Next chairperson.
he
Madam
is
installed.
member of Foxy, Saucy and the Indian Menopausal Society. She has delivered lectures for adolescents regarding anemia and menstrual hygiene in various schools. And she conducts regular workshops on basic and emergency obstetric skills for UG and PGs. And she is the chairman board of studies for PG curriculum in OG, Tamil Nadu MGR Medical University. And she has the best doctor award by the Tamil Nadu MGR Medical University in 2008. Very aptly, she is catching the adolescent girls, the UG and PG girls, to prevent GDM in future. Over to you both, sirs.
Thank you. Thank you, madam, for that introduction. Good morning to one and all. At the outset, I thank the organizers, Professor Seshaya sir, Dr. Anjalakshi madam, and Dr. Dharmarajan, and all other eminent diabetologists who are conducting this wonderful program to impart knowledge to most of the women, and also giving me an opportunity to chair this wonderful session. As we all know, preconception counseling has gained momentum in recent years. The knowledge that each woman should be medically fit to have a healthy baby is already in the minds of most of our women. They feel that everything should be okay for them before they impart on a pregnancy. More so in women if they are hyperglycemic. These hyperglycemic women are more worried in getting pregnant, and they feel that they should have a good control over their glycemic status before they go in for a pregnancy. This knowledge they have gained mainly because of their previous obstetric outcomes like repeated abortions or obstetric failures, and also the knowledge imparted by these conferences, and they feel that they should be fit and in good glycemic status. As we all focused on the previous dictum of Dr. Seshaya, focus on the fetus for future. I think the opening batsman must be our madam to talk and focus on preconceptional counseling. The topic is preconception management of hyperglycemic women in the eager to conceive women and to translate the benefits to the offspring. So how we are going to translate this is what Dr. Anjalakshmi Madam is going to tell us. And to talk about Dr. Anjalakshmi Madam, she has been my teacher and our mentor. She had been the past president of OXY and the present president of Gynaecology, and almost in all conferences. We know conferences without our madam. And she has great interest in this field. And for the past 20 years, she had been interested in research work as well as starting new projects in most of all the government hospitals, and has been in contact with most of our hospitals, and the research work which we are doing today in most of our hospitals are being by instrumental and being taught by my mentors, Dr. Anjalakshmi Madam and Dr. Seshaya sir. As Dr. Sundaram said, we do have an account of all the GDM mothers who are delivering at present in our government hospitals. And we really managed well all the GDM mothers in our COVID period, and we did have a good outcome. So to talk on this topic, it's my pleasure to invite Dr. Anjalakshmi Madam. Madam, please.
Thank you, Dr. Kalaivani. Good morning to everyone. At the outset, let me thank Professor Seshaya, my mentor, and the Tamil Nadu chapters of DIPSI organizers for giving me this opportunity to talk on the preconceptional counseling. Are you able to see my slides?
No, madam.
Now?
Not yet, madam.
Madam, the green share slide. Come
That I did actually.
You can able to see the screen, madam. Open the PowerPoint, madam. Open the PowerPoint, madam.
Madam, the PowerPoint is down. Open.
Yes, madam. Correct. Shanmugam. Open the madam. This one.
Slideshow, madam. Slideshow.
Slideshow is not coming.
No, madam. It is seen for us.
It is downside, madam. Here and there. Or F5, madam. Yes, sir.
Come this side, madam. Come
this side, madam.
Madam, key right side, fourth column, madam.
Next to 49%. Next to 49%. Right side, ma'am.
49% just முன்னாடி
left side, ma'am.
இந்த பக்கம் மேடம் 49
Yes,
thank you. My topic is the preconception management of hyperglycemia in eager to conceive women, translating the benefit to the offspring. See, all of us know so there is a societal burden of diabetes mellitus in pregnancy. It is growing, and women with diabetes in pregnancy, they have high rate of complications for themselves and their babies, and these complications, they impose a significant cost to the individual and to the society, which may be reduced by the preconceptional counseling and the intervention. And preconception period is a crucial and sensitive time to improve the birth outcome. Where all we see the hyperglycemia. ADA describes 3 types of gestational glucose intolerance in pregnancy. One is type 1 DM, type 2 diabetes, and gestational diabetes mellitus. If it is diagnosed during pregnancy, but may include some undiagnosed pre-GDM also. And once a subject is diagnosed with GDM, they have a 7 to 9.6 times increased risk of developing type 2 diabetes in later life. And the other situations, we have the elevated blood glucose levels are present in case of pre-diabetics, impaired glucose tolerance, patients with obesity, and individuals with poor nutrition. And the research has shown, importantly, the BMI is correlated with increased glucose level in the follicular fluid in humans. That is by Robker 2009. So what happens with hyperglycemia and the female reproduction? The environment of the oocyte during periconceptional period, they have a significant impact on the oocyte development competence and also the long-term health of the resulting offspring. This is particularly true for the maternal hyperglycemia. The maternal hyperglycemia is associated with multitude of pregnancy complications both in type 1, type 2 and GDM. Even when the glycemic control is stable during the first few weeks of pregnancy, there is still significant risk of pregnancy complications, including congenital anomalies. In human studies, even if the optimal glucose control is achieved within the first few weeks of pregnancy, there remain a 35 times higher risk of spontaneous abortion, congenital anomalies for babies born to women with DM. If a pre-conception treatment program is undertaken, this risk is significantly reduced. Animal studies by Kelly and Malloy, they have demonstrated hyperglycemia may lead to increased fertility complications even prior to conception by high levels of apoptosis and smaller size of oocytes by the decreased glucose uptake. Similar changes are seen in the human and also in the not only in the oocyte but also in the cumulus, in the granulosa cells, the mitochondria, and the endoplasmic reticulum present inside the cell. All this could be the cause for the transgenerational transmission. And what are these effects of hyperglycemia? So all of us know about that, the effects of hyperglycemia on the mother, like the increased PIH, hydramnios, shoulder dystocia, and in pre-GDM, macro and microvascular complications get exaggerated. And on the fetus, you have fetal loss, macrosomia, and neonatal problems. So this has been told by many people, and obese women, they have increased risk of preeclampsia and spontaneous abortions, and macrosomic babies have increased risk of metabolic syndrome, including the insulin resistance in childhood. Coming on to the congenital anomalies. The congenital anomalies occurs in 6 to 10% of the diabetic pregnancy, and the degree of risk correlates with the degree of glycemic control. The fetal anomalies doubles to 5% when the maternal fasting blood glucose level is 6.6 millimole, that is 118 milligram percent, just below the threshold for the diagnosis of diabetes mellitus, which is 7. This anomalies increase to 30% when the maternal fasting blood glucose is 14.3 millimole, that is 257 milligram percent. And the occurrence of the neural tube defects, skeletal anomalies, cardiovascular malformations in particular, they are 18 times more common in babies born to mothers with diabetes or obesity. So a hyperglycemic insult must occur within the first 6 weeks of gestation to produce an increased likelihood of congenital anomalies. The earlier the glycemic control can be achieved, the lesser is the risk of malformation. And there is evidence to suggest that even a very brief exposure to hyperglycemia is enough to cause malformation in the offspring. A very brief exposure preconceptionally is enough for the malformation. Thus, the effect of hyperglycemia timing tends to be the preconceptional period as well. So optimum embryo development is achieved during a relatively low concentration. For example, 1 millimole for the mouse. If it is there, there's optimal embryo development. And for buffalo, it is 5.6 millimole. I think humans close to that. And this is an interesting slide to show you when the anomalies occurs. So if you take the ovulation and fertilization as a 0 week, the caudal regression syndrome occurs when there is hyperglycemia at 3rd week, at post-fertilization, and spina bifida anencephaly at the 4th week, and transposition of the great vessels and renal abnormalities in the 5th week, and by 6th post-fertilization week for the ventricular septal defect and anal atresia. So most of these anomalies are seen before the 6th post-fertilization week, that is within 8 weeks. And it has been found this hyperglycemia is teratogenic for the developing embryo, as I was telling you, and the other factors being myoinositol, arachidonic acid deficiency, hyperketonemia, and excess of the free oxygen radicals. So how to reduce this congenital malformation? We should have an intensified glycemic control during periconception and first trimester of pregnancy. And various studies have shown that periconceptional care and strict glycemic control, that is keeping the blood sugar between 60 to 130 milligrams and low hemoglobin A1C in the first trimester, it lowers the congenital anomalies from 1.4 to, that is from 10.5 to 1.4%. Thus, what is a preconceptional health? It is a set of interventions that aim to identify and modify the biomedical, behavioral, and social risk to women's health or pregnancy outcome through prevention and management. That is the preconceptional health or the preconception care. And we have one interconceptional health, that is interconceptional care, which includes the comprehensive preconceptional care plus additional intervention for the women who have had adverse outcomes. So for women with diabetes, all women of reproductive age between 15 to 44 years with type 1 or type 2 diabetes should receive a risk assessment and counseling before pregnancy occurs. This counseling should include information and effect of diabetes on pregnancy, potential diabetes progression, and how to optimize their glycemic control before conception so that the congenital anomaly chances can be minimized. See, most of the malformations, as I told you, it occurs before the 7th week of gestation. So to prevent these anomalies, there should be an effective intervention to be made even before the conception. In view of this, the time necessary for the adjustment in the diet, insulin dosage, exercise, and blood sugar control must begin prior to conception. So those who plan pregnancy, enter the prenatal care earlier, have a low hemoglobin A1C, they are less likely to have major congenital malformation. So the pre-pregnancy counseling is very important to reduce the congenital malformation. But of course, in the literature, there is no RCT or the RCT is available for the preconceptional counseling. Anyhow, Dr. Pedersen, he has analyzed the data from the systemic review, and he has found the various adverse birth effects of pre-gestation diabetes who did not receive the preconceptional care are 41.4% preterm deliveries, 7.3% birth defects, and 4.4% of the babies died in the infant and the neonatal period. And he also found when there was a preconceptional care, there is an improved pregnancy outcome, like reduced risk of adverse pregnancy outcome, decrease in the hemoglobin A1C during the first trimester, and decrease in the incidence of preterm delivery, birth defect, and perinatal mortality. So coming on to the preconceptional counseling, first thing is the folic acid administration. Second is you should have adequate blood sugar control to reduce the major congenital malformation and maintain the hemoglobin A1C and monitor monthly till it becomes stable at less than 1% above the upper limit of the normal. So during that time, use contraception. I will be elaborating on the contraception later. And this is the ladder of to depict how the diabetes mellitus when it comes and what should have the pre-pregnancy counseling. First, when you make a diagnosis, you give that disease information and medical management to the patient. Once the disease is established, highlight the importance of the preconceptional care to the patient, and advise about contraception. In the preconceptional care, you have to educate about the planned metabolic control, folic acid administration, and also elaborate on the complications like nephropathy, hypertension, retinopathy, cardiovascular disease, neuropathy, and hypothyroidism. Counsel them how the pregnancy will impact on diabetes and how the diabetes will impact on the pregnancy, and treat the complications, and have a concern when there is a severe gastroparesis and the coronary artery disease. When the early pregnancy comes, have a good metabolic control and treat the complications. So that is in nutshell, that is the ladder. I'll just elaborate on the pre-pregnancy counseling. First thing is the history. In the history, the age of onset and the duration of the diabetes is important, and assess whether it is type 1 or type 2 or a GDM or a condition with a increased insulin resistance, and history of ketoacidosis and the precipitating the circumstances for ketoacidosis, and history of hypoglycemia and hypoglycemic seizures, and the ability to recognize hypoglycemia, and the retinopathy, whether she had undergone any photocoagulation earlier, and occurrence of proteinuria and the presence of nephropathy, hypertension, and neuropathy, especially symptoms of gastroparesis and cardiovascular disease. So all this history has to be elicited. Then in the examination, record the height, weight, BMI, blood pressure, and thyroid, and look for the look for the retinal problem, retinopathy, and lab evaluation, hemoglobin A1C, hemoglobin, thyroid stimulating hormone, urea and creatinine, and 24 hours urine protein or spot microalbumin to creatinine ratio to rule out an nephropathy, and serum albumin. ADA recommends, in addition, screening for depression, anxiety, stress, and eating disorders, and recommends discontinuing of all oral agents and initiation of insulin to optimize the metabolic control prior to conception. Counsel and discuss all potential fetal and neonatal complications, and women, the family members should be prepared that there should be more frequent prenatal visits, meticulous metabolic control, multiple capillary blood glucose estimation, and also learning about the self-monitoring of blood glucose and surveillance for the fetal well-being. The women should be advised, if the retinopathy present, sometimes retinopathy may develop during pregnancy, or it can progress during pregnancy, and proteinuria may increase during pregnancy, and there is chances for increased preeclampsia. And the most important intervention to minimize the risk of the progression of retinopathy and nephropathy is to control blood glucose and blood pressure. Coming on to the contraception, the diabetic women should plan their pregnancy in good metabolic control to minimize the risk for the complications. All contraceptive methods that are available to non-diabetic can be used during this period. And the natural family planning method and the barrier method, they are very safe, but the failure rate is very high. Both copper and LNG are equally safe and effective. And modern low-dose combined pills, they have negligible effect on the when there is a good control, good glucose control, and they have a negligible effect on the glucose control and atherogenic profile in diabetic women with good metabolic control. And ACOG reserves a hormonal contraception for young diabetics less than 35 years without any complications. And for contraceptive patch and ring, there is insufficient data is available. And these contraceptives are, it applies to the postpartum diabetic women also. So in preparation, next is the diet. In preparation of the pregnancy, diet should provide all necessary micro and macronutrients, minimize the cholesterol and the saturated fat and trans fat, promote the euglycemia and the attainment of appropriate BMI, that is between 20 to 24.9, by the appropriate diet to encourage weight gain in an underweight and in an overweight person to lose the weight. And appropriately daily distribution of the dietary calories should be there, like 40 to 50% of calories should come from carbohydrates, 15 to 20% from protein, and the remainder from fat. And the women should be encouraged to consume carbohydrate as complex carbohydrate and maintain the fiber intake as 28 grams per day, by consuming whole grains, fruits, and vegetables. And look for retinopathy. When the disease is more than of 20 years duration, that is the diabetes more than 20 years duration, 100% of the type 1 and 50% of the type 2 diabetic will have some form of retinopathy. So in the absence of effective treatment, the proliferative retinopathy can give rise to severe visual loss. So the important intervention is strict blood sugar control and laser coagulation if a retinopathy is present. Generally, diabetic women, they suffer no net loss of visual acuity because of pregnancy. That we have to counsel. And nephropathy and hypertension. Diabetic nephropathy is a chronic disease when there is an albuminuria of more than 300 milligrams per day present. And there is a decrease in creatinine clearance, development of hypertension, and ultimately renal failure. These are the features in the nephropathy. The lifetime risk for this complication can be minimized and delayed with strict metabolic control and control of hypertension. Outside pregnancy, to reduce the progression of the disease, AC inhibitors and ARB blockers are recommended. They are contraindicated in pregnancy because of teratogenicity. So before planning pregnancy, these drugs has to be stopped, and the calcium channel blockers and beta blockers can be used. And prophylactic low dose aspirin, they did not improve the perinatal outcome. So what is the preconceptional counseling for a GDM, previous GDM patients? The GDM, if they have it under, it indicates an underlying insulin resistance. So the disease signals an increased risk for maternal type 2 diabetes and also childhood obesity and metabolic syndrome for the child. And up to 30% of women with GDM, they develop type 2 diabetes in 5 to 10 years period postpartum. And BMI affect the risk of developing the postpartum diabetes after GDM. So in postpartum care of GDM, women would include screen for type 2 diabetes at 6 to 12 weeks postpartum with OGTT. And if the 2-hour post-glucose value is more than 200 milligram, it indicates the type 2 diabetes. If negative, the OGTT should be repeated every year. And women should be aware that maintaining the BMI, healthy eating, and exercise pattern will delay the type 2 DM and minimize the risk for the adverse outcome in the future pregnancy. So in the preconceptional care, we have to stress on the eating habits and the exercise pattern and maintaining an ideal weight. And this slide is an interesting slide. It will show you how the breastfeeding will protect both the mother and the baby. The breastfeeding will prevent the mother from getting obese and developing GDM in the subsequent pregnancy, and also development of metabolic syndrome and type 2 diabetes. For the baby, it will prevent the infant macrosomia, childhood obesity, and later metabolic syndrome. So in the preconceptional counseling, the recommendations are the individual should have a responsibility. Patient herself, the subject herself, should have her responsibility across the lifespan. The second, the consumer awareness we have to increase. And third is we have to find out the risk factors and try to prevent it. And fourth is if there are any risk factors, intervention of the risk factors. And fifth is interconceptional care to provide additional intensive intervention to women who had adverse pregnancy outcome. And sixth is pre-pregnancy checkup. It should become a component of the maternity care. So every hospital should start having a preconceptional counseling, and they should have a preconceptional clinic. And the seventh point is to have an health coverage to the low-income women, especially the insurance coverage can be given by the government. And eighth is a public health program strategies. So this preconceptional counseling can be incorporated into the public health programs and the strategies. And third is the ninth is the research. As Dr. Hariharan was telling, the research should be there. So that will increase the evidence and promote the evidence to improve the pre-pregnancy health. And then, of course, monitoring is very important. To summarize, the aim is to reduce the number of unintended pregnancies and to maximize the health before conception to improve the pregnancy outcome. For patients with diabetes, it involves a risk assessment and counseling before pregnancy, and the counseling should be in the form of information about fetal and maternal effects of diabetes in pregnancy, impact of pregnancy on glycemic control, potential diabetic progression, and women should be encouraged to plan pregnancy carefully and optimize their glycemic control before conception to minimize the chances for congenital anomalies. And a collaborative approach is most effective with support from multidisciplinary professionals, including dietitians, nurses, diabetes educators, psychologists, specialty providers. And preconceptional care is associated with improved pregnancy preparation and reduced risk for adverse pregnancy outcome in all types of hyperglycemia. And it is associated with a significant reduction in the A1C and lowest incidence of preterm delivery, birth defect, perinatal mortality, and women with diabetes mellitus. So to conclude, there is no single medical or obstetric intervention that has been as important in improving the outcome for the diabetic women and their offspring as the improved metabolic control. So the metabolic control is the key for the best outcome. Thank you. Thank you very much.
Thank you, madam. Thank you, madam, for that wonderful lecture, emphasizing on preconceptional counseling and enlightening us. And in future, I think preconceptional counseling should not be a priority. It should be a duty to impart this knowledge to our women. And the particular people who we have to target is these adolescent girls. As we go to these adolescent checkups in many colleges, we do feel that most of them are anemic and are obese, and their BMI is increasing every year. So the importance of obesity landing up in metabolic syndrome and later on leading to diabetes mellitus should be taught to these women. And preferably, every woman should have a medical health checkup before imparting or getting pregnant. That way, it definitely reduce the incidence. And as you said, the congenital anomalies are starting at the oocyte level. By the time she comes at 45 days of amenorrhea to a health checkup, the damage is already been done. So to help them to overcome all these problems at the adolescent age and see to that they are fit. And this generation begets the next two generation has to be instilled in their mind. And you also gave a very good reproductive life plan where what are all the methods by which we can do this. The government hospitals having a health coverage for all these women and a medical checkup before getting pregnant is more important. Thank you, madam. And
thank you, Kalaivani. So in addition to the adolescent clinic, you should have a pre-pregnancy clinic.
Yeah, slowly they are coming, madam. After an adolescent checkup, they come for anemia, metabolic syndrome, and how to reduce their weight and all that. They are interested a little bit. So this public awareness, as you said, public awareness should be imparted at all levels, at school, by school teachers, by doctors, by social workers, so that at least awareness will help them say through this problem.
Madam, there is one question in the chat box. HbA1c monthly, is it rational?
Good. What is the question, please?
HbA1c.
HbA1c monthly, is it rational?
Yeah, when they are planning for pregnancy, they have to bring down the hemoglobin A1c. If it is high, okay, they have to reduce it. They have to repeat every month till it becomes normal.
What is normal?
What is normal, madam?
Normal is below 5.5.
5.5 or 5.7,
yes.
Right, madam. So every month you are advising.
Yeah, see, it has to become normal. That if it becomes normal, that means there is a hyperglycemia. Is under control.
Another question: fructosamine and its role in monitoring.
Yeah.
Paneer.
Sir,
one small suggestion.
Yes,
repetition of HbA1c within 1 month is possible if you have only intensive insulin control.
Yes.
Otherwise, it is not possible. Okay, there will be a decrease in HbA1c even within 1 month, only if you follow. So this applies to people. No, this applies to people, person who have higher blood sugar, higher HbA1c.
HbA1c.
Yeah.
Right, sir.
Sir
Sam
wants to
wants to say.
answer.
So please tell me,
Sir.
hospital, Madras, in government hospital, does A1C? Tell me one in government hospital in Chennai doing A1C.
MMC doing.
No,
Right, sir.
don't say A1C. A1C is not possible
to do.
Monthly.
No, it is not possible, but that's what professor says.
So regarding that, I am Dr. Sampath Kumari, sir. Seshaya, sir. Good morning. Preconceptional diabetes and oral anti in the chat box. I don't think oral drugs itself is enough. Rather than going further, we can get the Seshaya sir's report or Paniselvam sir. That is, oral itself is enough during the preconception. I don't think we have to go for insulin in preconception.
No, the question is not for
No,
insulin. It is about HbA1c. That's
No,
what
sir, next
we are not
question is
routinely
that-
doing HbA1c, but now all are doing outside. What
Yes,
professor wants is which any government hospital is doing. That's all.
Sir,
Not
if
the
it is, sir, excuse me, sir. Sir, excuse me, sir. If it is going to give us more prediction of sugar control, we don't mind asking our NHM to include in the CMONG thing.
Good, madam. Please
Yeah.
add it on. Please
Yeah.
add it on.
But
We'll
we
be
need to
grateful to
have
you.
evidence. We need to have evidence. HbA1c is really mandatory for monitoring the sugar control.
Is it essential monthly? That is the question. Now.
Madam,
It is
time is
essential.
up. We'll go to the next session.
Yes, madam.
Okay.
I request Sundaram sir to introduce the next speaker, sir.
Okay. It's my pleasure to introduce Professor Dr. V. Balaji, Chairman and Managing Director, Senior Consultant Diabetologist of Dr. V. Balaji, Dr. V. Sheshaya Diabetes Care and Research Institute. I know him from the beginning. He is the founder, Secretary General for Diabetes in Pregnancy Study Group in India. That's DIPSI. He has been a member of many organizations, both national and international, on diabetes and pregnancy study group. Recipients of many awards. To mention a few, Dr. J.C. Patel, Dr. Mehta, Dr. Samjit Moses Varation in RSSDI, Dr. B.R. Sengupta Varation and Srinivasa Murthy Golden Varation, and above all, Times of India Achievers Award, and received a legendary award from Healthcare Achievers Award. That is the Times of India Award. He is a member of Expert Group Committee on Gestational Diabetes and a member of Ministry of Health of Government of India on Diabetes and Pregnancy, particularly Gestational Diabetes mellitus. His contributions are over 200 papers. That itself shows his volume of research that he has done. And I request Professor Balaji to talk on glycemic target during pregnancy. Thank you.
Respected senior professors, respected Professor Seshaya, I first thank the organizers for giving me this opportunity, and I would like to wish and congratulate Professor Seshaya for GDM Day. So today I shall divide my topic into two parts. The first will be on screening and diagnosis a little bit, since the topic has not been covered, and the second part will be on target glycemic control. So GDM, most of you know, as diagnosis during pregnancy. The concern being it represents a detection of chronic beta cell function, and it's a stage in the evolution of type 2 diabetes. And it plays a crucial role, as mentioned by early speakers, in increasing prevalence of diabetes and obesity. And when we talk about ethnicity, Indian women are very high, 11-fold increase developing a glucose intolerance. Among ethnic groups, South Asians, we have very high frequency of GDM, so diagnosis becomes very, very essential. So universal screening now being accepted all over, and early screening is where we have DIPSI as one of the RCTs, and you can see here GDM in the first trimester, and rest, in other words, 100% diagnosed during the first and second trimesters in the Asian countries is from Japan, and it shows, and also some studies from Bangkok and Thailand have shown the same. So the importance of early screening. The implications is Does severe macrosomia manifest as 11 to 14 weeks? Because normally GDM means we screen at 20, 24, 28 weeks. So yes, studies have shown that macrosomia can manifest 11 to 14 weeks of gestation. The pathophysiology being that each islet cell functions as an endocrine organ and recognize and responds to maternal glycemia as early as 11 to 15 weeks of gestation. So fetuses are exposed to increased amniotic fluid before 15 weeks, suggesting that metabolic alterations under the way and diagnose and earlier screening and intervention may be warranted. So let's see our studies. A GDM manifests in India according to the DIPSI criteria at all trimesters. So you can see the numbers around 4,000 odd women. When you divide them into 3 trimesters, you can see the red 16 weeks and the yellow 17 to 23 and 24 weeks will be in the green. And to cut the long story short, if you see 38% of GDM women were diagnosed before the recommended weeks of screening. So that is why even WHO's endorsed testing for early screening. Also, another study has shown the same thing. If you see, almost 1/3 of all our GDM cases were diagnosed during testing in the first trimester itself. So this shows importance. So there are studies from across the globe which have shown if you screen them early, you can have a better control over the hydramnios. Complications are less with preterm deliveries, premature rupture of membrane, and fetal anomalies. And studies have shown early glucose tolerance can prevent most of these complications. So early metabolic imprinting may affect fetal growth. This is what happens. The human studies have shown that increase in pancreatic beta cell mass and insulin secretion in poorly controlled diabetic women by 16th weeks of gestation increases throughout until 26 weeks. And the priming of beta cell mass in mid-gestation may account for the persistent of fetal hyperinsulinemia throughout pregnancy and the risk of accelerated fetal growth, even when the mother enjoys good metabolic control in later pregnancy. That is what is the sugar-steal syndrome. And the implications being early metabolic imprinting may affect the fetal growth. So you have to screen them early. Repeat screening, as studies of DIPSI criteria have shown 28% of women were detected to have GDM on repeat screening. And now we go to the DIPSI criteria for diagnosis and guidelines. So this is the study by Professor Anjalachi in the DIPSI group, which shows which is the DIPSI criteria followed today, a 2-hour post-glucose of 140 milligram with 75 gram oral glucose administered with pregnant women in the fasting or non-fasting, fasting without regarding timing of the last meal, is able to identify women with gestational diabetes. This is exactly what is the DIPSI criteria being followed, and I go on to the details, validating the criteria and so on. So the DIPSI criteria, as I also mentioned, universal early testing in population with high prevalence of gestational diabetes. So all women to be screened even if they have no symptoms according to the new recommendations, and more than 90% cases of hyperglycemia in pregnancy estimated to occur in low or middle income countries. Now we go on, why one-step procedure, why the DIPSI and Professor Sesha, we all insist on this one-step procedure. See, there are a lot of practical problems which we have come across, especially when we do the field work in a DIPAC project, as well as if you see the people who have done the IAD PhD, they have all shown that it's very difficult to ask the pregnant women to come in the fasting state and they drop out and they do not come back. So this is exactly what they say. The IAD PhD also says attending the first prenatal visit in the fasting state is impractical in many settings. So if you take the DIPSI criteria, a single test value of 140 with or without fasting, the pregnant women need not be fasting. It causes least disturbance in pregnant women's routine activities and serves both as screening and diagnostic procedure. So now we come, why this 2 hours? Why 2 hour pass? Everything what we say needs to be validated with an outcome. The proof of the pudding is only when you eat it. We can always keep saying some numbers. Whether these numbers actually gives us benefit or the outcome is good, then only the numbers can be accepted. So now we see the different criteria across the globe. You see the WHO, which says 2 hours of 140, which is now as considered as the DIPSI criteria, which makes sense in sense when the WHO can say 75 gram OGTT performed pregnancy outside the pregnancy can be IGT. Why can't it be also the same in pregnancy? and the NICE guidelines, which says 126 or 140, and the ACOG, which says, again, you see the values there, and the ADA, which is not followed now, the IAD PSG, which says 3 values, and you have to do all 3 values. If you talk of the HAPO or the IAD PSG criteria, the fasting is not appropriate option to diagnose GCM in Indian because of our insulin resistance. Our own studies have shown if you are taking fasting alone as a diagnostic criteria, we are missing 76% of people if you do only the fasting for diagnosis of GDM. And if you see both 2-hour OGTT and estimation of fasting, that is 3 tests are necessary to get the diagnosis, and the cost utility is found that screening based on IAD-PST criteria was not cost effective. And if you talk about HAPO, it did not include most of the Asian countries. And also if you see the center to center difference was there because of the population, and this may be important, they may impact the strategies using the diagnosis of gestational diabetes. And if you see the IABC criteria, frequencies of GDM show substantial variability within regions of the world. And this again has an effect on the outcome. So according to the WHO, if you say rate the quality of evidence in IAD-PST is very low and strength of recommendation was very weak. Whereas you take the DIPSI criteria, which again endorsed, I'll come to it later, and WHO definition of IGT and non-pregnant state, which is about 140, is considered abnormal and requires lifestyle approach. And why can't it be considered abnormal during pregnancy also? This is exactly a common sense, what the basis of which the DIPSI has gone in. And there is no high quality evidence that women and the fetuses benefit from treatment with only the fasting values normal. So RCT shows benefit of treating GDM women identified primarily by the post-glucose values. Very, very convenient for countries like India and other countries. So definitely the 2-hour 140 has a very good significant and scientific evidence. So now validation again, what does it show? The DIPSI criteria, is there any benefit when you treat DIPSI criteria? We see the study now which we published, which says diagnosis. This you can see the bars here. If you see the green bars are normal glucose tolerant women. And if you see the red bars which are going to overlap them are the GDM women after intervention when they were picked up during the DIPSI criteria. And once you intervene them, you can see their blood glucose values and similar, and macrosomia was not associated with macrosomia. So this is exactly what you mean when you treat them for 140 and then pick them at 140 and treat them, definitely you get a better outcome. So advantages: requires only 1 blood sample drawn at 2 hours after 75 grams of oral glucose and estimation of plasma glucose. Even if the test is performed in each trimester, it is 66% less than the cost of performing IAD-PST procedure. So the DIPSI procedure is feasible, sustainable, cost-effective, which is very, very important, high impact, especially in a country where the economic status is almost burdened. So diagnosis can decrease macrosomia rate, fewer emergency cesarean section, serious perinatal morbidity, improve the woman's health-related quality of life based on DIPSI criteria. Also, the State Health Society has already been approved, and this is what they do: screening at 12, 16, 24, 32 weeks, and also approved by the Government of India, already 1-step procedure. And supply of glucometers, and National Health Program is approved the DIPSI criteria, and also glucometers. Our study has showed point of care testing that glucometers can also be used for diagnosing GDM, and use glucometers, which mean standardized for measuring plasma glucose. And the WHO also has endorsed a view saying that you can use glucometers. And also WHO, the last meeting, has said that just in countries where feasibility and non-fasting testing may be the only practical option, and WHO recommended single-step procedure to diagnose gestational diabetes in the last recommendation of 2013. Also in the future strategies, they had mentioned the DIPSI guidelines to be evaluated for better strengthening the outcome. So the FIGO has also approached to our values and booking at the first trimester. IDF is also approved. Technical and operation guidelines in February has approved it. So now we go on to the target blood glucose in pregnancy. So I'm mentioning some values here, and I am going to validate these values to tell you whether these values are right. Why should she follow these values? The DIPSI criteria says fasting of 90 and a 2-hour post-glucose of 120 milligrams per. At the bottom, you can see all our studies which validate these criteria. So let's go on to the first slide, which I already mentioned to you about the normal glucose tolerance and the gestational DM, where the macrosomia rate was similar. What I want to mention here was these interventions. We said intervention. The intervention was made for fasting of 90 and a 2-hour of 120. This I want to emphasize here as how we got the GDM patients to be similar to that of normal glucose tolerance in terms of macrosomia was the intervention, and the intervention has a fasting of 90 and a 2-hour of 120. And this is the DIPAP project, what we did, and then what happened here after, before and after. The National Family Health Survey, which did before we did the DIPAP project, you can find the small gestational age was 17%, and then it was reduced to 10.45%. The large LGA is 19% and reduced to 7.63%, 7.26. Here, what I want to mention is not that we went around using insulin. It was only a manipulation of these people with diet. 95% of people were only given diet manipulations, and less than 5% required insulin. And the intervention we maintained again as 90 and 120, and you can see the benefits. So a small initiative bring about a major benefit in the community. And this is another study which has come from Professor Jitendra Singh. What they did, they had controls and they had GDM with treatment and GDM which did not want treatment. So you can see the difference in terms of preterm respiratory distress syndrome and macrosomia with controls, GDM with treatment and GDM without treatment. So you can see statistically significant difference in terms of problems when you're not treating the GDM, and especially when you're not treating for the DIPSI criteria of 140 milligrams. So the birth weight in terms, you can see here, this is the study which we said when the birth weight is a continuum. And if you see the birth weight when it starts from 80 to 99, when it crosses 120 itself, you can see the macrosomia birth weight going much higher, statistical significant. You can see the occurrence of macrosomia's continuum as a 2-hour glucose increase from 120 and then so forth goes high. So during fasting also we had published that occurrence of birth weight of newborn over 19 percentile was continuum as the fasting increased from 80 and was significant above 90. So the values, what I am saying matches. Now, the glycemic control, you see the ADA says 95, the ACOG 90, and the 2 hours value of 120 is matching, and DIPSI again 90 and 120. So if you talk about DIPSI and IAD, PSG, HAPO, don't think the values are totally different. See, the HAPO has made it as 1.75 odds ratio. DIPSI has made the same 1.5 odds ratio. So we get 140. So the values are almost the same. It's only the odds ratio which changes, giving the values a little different. Especially being high ethnic group, definitely we should have a smaller cutoffs. So now what does this say? You can see here the diagnostic criteria for IAD PSG is 92, whereas the glycemic target of IAD PSG is 95. So how can we have 95 as target glycemic control when the diagnostic criteria is 92? There is some mismatch which needs to go for a better understanding. So what the study tells you is even that 5 millimoles decrease prevents macrosomia as well as other adverse outcomes such as preeclampsia and neonatal hypoglycemia in women with gestational diabetes. So 90 to 95 also plays a major role. So the pattern of glycemia in normal pregnancy, what happens if you see the study here, the pattern fasting, if you take, it is about 71 plus or minus. The 1 hour you take is close to 109 and the 2 hours is 99.1. And then you should always know the fetal renal threshold is 110 milligrams, whereas the maternal threshold is more. So here you can see here the fasting 2 hours and the 2 hour postprandial targets is about less than 110 what to be maintained, whereas the fetal renal threshold is 110. So roughly we should be as close to normal. We cannot have absolute normal because anyway we should have a little plus standard mean deviation to make sure we don't have a public health problem. So the normal matches the abnormal, what the DIPSI criteria has done. So the target range should be to that of non-diabetic pregnancy, the fasting between 80 to 90. You can see the postprandial 110 to 120 and a mean of 105, which is 90, but a fasting of 90 and 120. And a birth weight, if you can see the goal, obtain a birth weight between 2.5 and 3.5 kgs. And an hemoglobin A1C, if you ask me, a study which we have published in Diabetes Care, to obtain a normal which matches 90 and 120 is 5.3 milligrams, and to diagnose the cutoff HbA1c should be 6 to diagnose GDM. And there was a lot of controversy regarding HbA1c. So HbA1c in GDM has more of a diagnostic value than a prognostic value. If they have more than 6, you know they have already been diabetic outside pregnancy and come into pregnancy. And again, monitoring HbA1c again depends on the individual centers and facilities. It may be beneficial if you have the facilities. And this birth weight is very, very important because if you take the birth weight, it's a U-shaped curve where less than 2.5 and more than 3.5 again can predispose you to diabetes in future. So it's a U-shaped curve. So if you maintain the birth weight between 2.5 to 3.5, you can prevent future intergenerational transmission of diabetes. So classification here I want to say is if you see pregnancy, 2-hour pregnancy more than 200, in pregnancy diabetes, outside pregnancy diabetes, 140 to 199, gestational diabetes, outside pregnancy, IGT, and this between 120 to 139 is the what we call as the GGI or gestational glucose intolerance. So this now gains a lot of momentum. As I said, our studies are already shown that's a continuum starting from 90 and a postprandial above 120. There's a linear increase in the level of macrosomia. So the occurrence of macrosomia was continuum as 2-hour plasma glucose increased from 120. So we need a lot of studies, less than 120 is normal. So this area is where we need a lot of focus to know what happens at that level of GGI. So the since the renal threshold for glucose in the fetus is less than 110 milligrams per deciliter. So let me summarize the whole thing from start. So ethnically Indian women are prone to develop gestational diabetes. Universal screening is necessary in the Indian context. You can have the customized screening of community of the single DIPSI criteria, GDM diagnose the 2-hour of 140. Single test that is cost effective and reliable. And the clinic, if you have all the facilities, you can perform the routine procedure and screening for the glucose intolerance at the earliest opportunity during pregnancy. Repeat screening when negative, and intervention to maintain a target glycemic level of 90 and a 2-hour of 120. So I thank you for the patient listening.
Good, thank you.
Doctor, will you please stop sharing? Dr. Balaji, please stop sharing.
Yeah, stop sharing.
Am I audible?
Yes, sir.
Please, sir.
Yes, sir.
Dr. Balaji,
Yes,
this
sir.
is an excellent, crystal clear presentation on diagnostic criteria, monitoring control of diabetes, prevention of macrosomia, and prevention of future generation developing diabetes. Hats off to you. This is the best presentation I have heard from you. And you made all the doubts to go away. So, ladies and gentlemen, particularly my request, what I have seen over the last 45 to 50 years of practicing diabetes, obstetrician and gynecologist. My sincere request is, please follow Indian guidelines. We are in India. We are not outside.
No, Sandeep.
And many times I am pained to
what shall I
see.
do? Going by morning flight, that 11:35 reaching by 2 o'clock. And coming back, our program.
What is this? Hello?
Then I cannot take the 5 o'clock.
Can you mute, sir?
We have to reach 2 hours before the airport, even though we are very close to airport.
Please mute that.
Could you mute, sir?
Please, see, that is the interruption of thought. I sincerely appeal to all the OGCNs, please avoid this 3-hour OGTT, 2-hour OGTT, even if it is done outside. Even if we refer to you for management, you do one more OGTT, which is unnecessary. You are taxing the mother and unwarranted for our country where we are living. That is the crystal clear message Dr. Balaji has given to us. And Dr. Balaji, when we did in MMC, the fasting blood sugar was somewhere 59 to 65, 1 hour 80 to 85, and the 2-hour value 95 to 105. This has been in 10,000 women, not 1 or 2. Now you have presented more than 70. Is it not more than 80 in the normal? See how the generation has increased the fasting blood sugar level. Please remember this. We are facing more than diabetes in general population. The future population, if you want to avoid, follow this criteria, please. All the youngsters, roughly around 100 participants are there. I request you all, if you are teachers, please spread the message. That's only my request. Kindly follow for diagnosis or for normal below 90, fasting below 120 pp, pre-pregnancy, during every trimester of pregnancy. And then if you want to diagnose, if it is more than that, a single test procedure, 140 milligram, irrespective of the woman that comes to the pregnant for your consultation. Don't ask her to come again. A 2-hour value, this is a glucose challenge test. If there is abnormality, it's going to bring out the abnormality. If there is no abnormality, this test will not bring out the abnormality. Please be sure on that. And follow the guideline. He has clearly told 95% of persons could be managed with meal plan only. Insulin is only if it is required. And HbA1c need not be done routinely, because that is confusing in your management. That gives you, in pregnant women, it will not operate properly. Because when blood sugar levels above 180 only, HbA1c will be positive. Please remember that also. I think hats off to you.
Thank you.
Balaji, thank you very much for your nice presentation. Clear cut on diagnostic criteria, clear cut on management, clear cut on future prevention of diabetes. Thank you very much.
Thank you.
Thank you, sir. We'll move on to the next session. Since the health secretary has not come to the field, we'll move on to the next session. I request Dr. Anand Moses and Dr. Shantakumari to take over. Dr. Anand Moses is a senior consultant diabetologist, Professor Emeritus, Tamil Nadu MGR Medical University. He is the former director and HOD Institute of Diabetology, Madras Medical College, and he is the organizing secretary, RSSDA 2012, and past chairman, RSSDA Tamil Nadu chapter, and he is the EZ member, National RSSDA, and former member of the Senate, the Tamil Nadu MGR Medical University. Coming to Dr. Shantakumari, Madam is Chief and HOD, Muthukumaran Medical College and Research Institute, Chennai, and Foxy Vice President-elect 2022, Chairperson, Foxy Arasalan Health Committee. Sorry.
Yes, Bavadarani, no problem, madam. I am Sampath Kumari, not Shantakumari.
Sorry, madam. I know you very well. Extremely sorry. The health secretary has come, so we are again coming to the inaugural session. Okay, one sir. Okay. Pushpa, start from today. Sorry, madam. I'll again introduce you. Now the health secretary has come. Okay,
no
madam.
problem. No problem.
Okay, madam.
Right. Thank you. Sir, secretary has come, I think, sir.
Right, welcome. Thank him.
So shall I start?
And madam, whether she has joined or not.
So just confirm so that I can start.
Yeah.
ஜாயின் பண்ணிட்டாரா சாரு?
மேடம்
சரிங்க சார், சரிங்க. வெரி குட் சார், வெரி குட் சார்.
இல்ல ஜாயின் பண்ணிட்டாரா விஜயா மேடம்?
சார் தெரியலையே சார், அதுல இருக்கா அந்த லிங்க்ல
இல்ல லிங்க்ல
சார் இந்த பார்ட்டிசிபென்ட்ல இல்ல சார். இல்ல மேடம், பார்ட்டிசிபென்ட் லிஸ்ட்ல இல்ல.
இல்ல பவானி யார் சொன்னாங்க உங்களுக்கு?
பெரியாண்டவர் சார் சொன்னாருங்க சார்.
ஓஹோ.
அவர் வந்துட்டு போறாராம்.
சார் வந்துட்டு போறாரு. நம்ம வெயிட் பண்ணுவோம். அவரை கால் பண்ணுங்க சார். சார் கால் பண்ணுங்க.
இல்ல பண்ணனே சார், அப்பதான் ஸ்டக் இன் தி ஃபீல்ட்னு போட்டிருந்தாரு.
நீங்க திரும்ப பண்ணி பாருங்க மேடம்.
இல்ல இப்ப he has logged in and then he has gone out.
அதனால தான் I stopped.
Let us try.
மேடம் இது அவங்க நம்பர் இருக்கா மேடம்? சார் கால் பண்றீங்களா?
இல்ல சார், இப்ப பண்ணேன் சார், கொஞ்சம் கட் பண்ணாரு, பண்ணிட்டு ஸ்டக் இன் தி ஃபீல்ட்னு போட்டிருந்தாரு. சோ I thought I is not going to join தான் நினைச்சிட்டு இருந்தேன்.
இல்ல மேடம், இல்ல இப்பதான் just now ஜாயின் பண்ணாரு. போன்ல கூட வந்தாரு.
எப்படிங்களா சார்?
உங்களுக்கு வந்தாரா?
தெரியலங்க, எப்படி சார் தெரிஞ்சது?
இல்ல it came மேடம். அவரோட இது போன் பேசினார். இடையில சவுண்ட் கூட வந்துச்சு இல்லையா? அது அவரோட வாய்ஸ்.
Dr. Paneer, you can just call him and he will even from the field he can join for a few minutes. Just call him or Rajendran can call him. One of the people who know him well can call him. Just call him.
Vijay madam only calling him, sir.
சரிங்க சார், கால் பண்ணி பார்க்கறேன் சார்.
Yes sir. And also give her apologies for while he came we were just waiting or something you say.
If he says little later we can start session. Okay madam.
We will adjust to whatever time he is joining, sir.
Hello madam. அப்படி இல்ல மேடம்.
கண்ட்ரோல் கொடுத்துருக்காங்களா?
என்ன பெரியவர்? Hello.
Sir, we will wait for 2 minutes, sir.
Right. You have called. Madam is calling.
And as per schedule, now this is the time for starting a function. So he will be coming in.
சார் கால் பண்ணேன், போன் பிக் பண்ணல. பட் ஒரு 5 minutes வெயிட் பண்ணலாம் சார். அப்படி இல்லைன்னா நம்ம நெக்ஸ்ட் செஷன் போலாமா?
நெக்ஸ்ட் செஷன் போயிட்டு இருக்கலாம் மேடம். வந்தா கூட ஜாயின் பண்ணிடலாம்.
என்னன்னா அவர் ஜாயின் பண்றாரு, செஷன் நடக்குதுன்னு சொன்னே வெளிய போயிடுறாரு. He is coming and going. அதனால தான் we will wait and watch. I think he will be watching now.
Yeah, we can wait for 5 minutes, Dr. Periander.
Yeah. Because originally this is the time we are going to inaugurate.
Because that's the time for inauguration. So
he may come again.
Yeah. If not 5 minutes, we'll start, sir. And then whenever he comes, we'll stop.
Or we'll discuss in the previous topic.
We will wait 5 minutes. Now we can discuss something. Not a talk. Yeah.
Yeah. That also can be done.
Sir, Sundaram sir.
I think Dr. Sundaram sir is there.
Sundaram made a very good comment. Let him come and let him continue. So far, he is one of the best chairperson now.
Yeah,
Yes,
Dr. Sundaram.
Yeah.
I just want to ask you one thing, and through you to Professor B. Balaji, is that how the fasting values are very erratic, and what was the rationale, if he knows, of the IADPG? I don't discuss IADPG. What is the rationale of anybody to accept fasting values as a diagnostic criteria? What is the rationale? I don't think any rationality of accepting fasting value in pregnancy diagnostic criteria. Sir.
Ashok, I'll tell you. I'll tell you.
Yes, sir.
The problem was IADPs had the same problem when they were doing the study in Asian population in Bangkok and Hong Kong.
Yes, sir.
Been there as a vice president and IABDPG. So I know in and out what was happening. When Boyd Metzer was writing the article in the diabetes care, he was puzzled what to do with this.
Yes, sir.
Honestly, they accepted what they tell him, what they told. It's honest. They said we are not able to find why the reason is like that. The only thing is they have found out Asian population got high insulin resistance. That has been proved by a number of studies, including our own fellow Siddharth Das from Orissa, published data. So that is why they said probably Hong Kong and Bangkok, that was two cities they have taken for the study in the IADPG.
Yes, sir.
When they compared IADPG along with the Bangkok and Hong Kong, 20% only they are able to pick up the fasting blood sugar level compared to our post glucose value. Similarly, India also like that, 24% only we are able to vote in Chennai. So that's all. But what American studies showed is 41% of the people can be picked up by fasting blood glucose. That is, they go on telling do fasting because it's easy for them. Easy for them, but as Balaji was telling, difficult for them because they don't come to fasting.
Yeah, and number two, sir, they overdiagnose. Am I correct? They overdiagnose. Overdiagnose. Because 41. 41. Sir, the second question I want to not comment. I want to make, sir. I think I wrote to many people, Dr. N. Rajendran, sir. I attended the Asians Diabetes Study Group meeting, and I must tell you from the core of my heart, the entire session of GDM, people from all the countries of Asia, they are following the DIPSI criteria. It was very gratifying to see one after the other of all the Asian countries. It happened about a month back, virtual meeting. I was there, and it was absolutely fabulous to see that all the Asian countries have accepted GDM criteria. It was great, sir. I want to tell everybody that the Diabetes in Asian Study Group is called DAST, Panir, has accepted entirely DIPSI criteria.
Happy to hear, sir.
Yes, sir. Yes.
And now, Ashok, now we have invaded Africa. We are in Asia, Middle East. Now we have gone to Egypt.
Africa. Yes, sir.
So Egypt people also now they accept, they will try to follow this single cell procedure because they say it is very easy to follow.
Yes.
At the same time, evidence based. Then the problem is not simple. Unless it is evidence, they won't do that. They compared all the studies, they come to conclusion that it is evidence based, we will follow it.
And also there is another proof of the pudding, sir. During the lockdown period, I think Madam will touch. We will talking on the GDM during COVID-19. They all got back to our criteria. Panir sir, Dr. N. Rajendran sir, they all got back to our criteria. They said DIPSI criteria alone. They did not take the name. Sometimes they took the name. They said only at fed, non-fed, 2 hour, post 75 glucose is the only test we diagnose. So that also we must document. We must document in this meeting that during lockdown, even the European and the American guidelines only accepted DIPSI.
Good.
So the audience wanted definite guidelines for CDM diagnosis.
Clear-cut guidelines given to NHM for diagnosis and management in pregnancy need clear follow-up guidelines of GDM mothers in forthcoming years. Can you emphasize on this? One Dr. Sumati is asking that.
So NHM has given clear guidelines, sir. For all the 3 trimesters, we have to do the 75 grams glucose test. So that is what we are following.
Yeah.
And as Dr.
Madam,
we do have cases in the first trimester itself, sir.
Sir, Health Secretary Master just have called and he said that to excuse today and he said he will call me later, sir. So I think we have to proceed with the program, sir.
Oh.
So he's not coming.
Shall we?
He's busy with that vaccination drive, ma'am.
Shall we proceed?
Yeah, that's what he said. Excuse me today. I will call you later. Message put, sir.
Should we wait, madam, or finish the inauguration?
No, I think we should start the inauguration, sir. You won't be joining.
Right.
Okay, sir.
Master.
So I'll, yes, sir, we'll start the inauguration function. So shall I start? Sir, you are mute.
1 minute. The organizers are making the
Things ready. Sir, sure, sir. So as soon as you give me a thumbs up, I will start.
Start பண்ணுங்க நாதஸ்வரம் ஸ்டார்ட் பண்ணுங்க
லைட்னிங் குத்துவிளக்கு
லைட்னிங் சீக்
அதுக்கப்புறம்
சார் அதுக்கப்புறம்
let them keep ready
இல்ல போட சொல்றாங்க போடு
Dr. Pushpa, you can start.
Okay, sir. So good morning, everyone, once again. Today we have gathered virtually, trying to put our small effort in realizing the dream of our beloved Professor Seshaya in spreading the awareness of gestational diabetes mellitus. So again, on behalf of Institute of Diabetology, Institute of Obstetrics Gynaecology, Madras Medical College, and Diabetes Association of India Southern Chapter, I welcome all our dignitaries and delegates to participate in the inaugural function. Sadly, the Health Secretary, Dr. Radhakrishnan, is not able to join us because of his prior commitments. As penned by the great poet Thiruvalluvar, Agara Mudal Eluthellam, Adi Bhagavan Mudatre Ulagu. Let us start by seeking the blessings of Almighty. I call upon Dr. Bhavadharni, who's an energetic diabetologist from Erode and an avid speaker, and has done a lot of work on gestational diabetes mellitus with Professor Seshaya. I request Madam to kindly recite the prayer.
Thank you. Sri Chakraraj Simhasaneshwari Sri Lalita Bigaye Bhuvaneshwari Sri Chakraraj Simhasaneshwari Sri Lalita Bigaye Agama Veda Kalamaya Rupini Agila Charachara Janani Narayani Nadagankana Nadarajamanogari Nadagankana Nadarajamanogari Jnana Vigneshwari Rajarajeshwari Sri Chakraraja Simhasaneshwari Sri Lalita Bigaye. Thank you.
Now we will have the virtual lighting of Kuttuvilakku. So I think we can go ahead. So before we go ahead, on behalf of everyone present here, I wish our Professor Seshaya a very happy birthday and seek his blessings. Happy birthday, sir.
Okay. Pre-birthday.
Yes, sir. 1 day in advance. Yes, sir.
10th March.
10th, yes.
So today we will wish him his birthday so that so many are here. We can bless, sir. Blessings, Wanglam, sir. for his blessings. So now I request Dr. N. Rajendran to kindly deliver the welcome address.
Good morning, ladies and gentlemen.
Morning.
At the outset, I must offer my birthday wishes to my mentor, guru, teachers for teachers, Professor V. Seshia, who is also the doyen of gestational diabetes in India. On behalf of the members and office bearers of Diabetes Association of India, Tamil Nadu chapter, and on behalf of the faculty of the Institute of Diabetology and the Institute of Obstetrics and Gynaecology, Madras Medical College, and in the capacity of President Implementation Committee, Tamil Nadu chapter of National GDM Awareness Day, I welcome you all for the inauguration of this wonderful scientific meet. A few words about that, the Diabetic Association of India, Tamil Nadu chapter. Recently, we have rechristened the name as a Tamil Nadu chapter instead of the southern region, which has grown up from a humble beginning with the 10 members at the time of inception in the year 1986 to more than 300 members as on date today. The Diabetic Association of India Tamil Nadu chapter maintains an active and cordial relationship and license with its parent body, namely the Diabetic Association of India, till today. The Diabetic Association of India Tamil Nadu chapter has been in the forefront for initiating many welfare measures implemented by the government of Tamil Nadu for the poor diabetic patients, especially in the decisions making of government to provide free insulin supply for all poor type 2 diabetic patients. And recently it has been extended to even the pregnant GDM patients and diabetic foot syndrome patients also. The association has been actively conducting conferences, webinars, and CMEs throughout the state. The National Gestational Mellitus Awareness Day function is specially held to honor our Professor beloved Seshia, former Professor of Diabetology, Madras Medical College, whose tremendous work in the field of gestational diabetes is widely recognized worldwide. The Diabetic Association of India is happy to honor him for all his efforts and achievements in the field of diabetology. Professor V. Seshia, he was instrumental in establishing the Department of Diabetology, the first of its kind in India at Madras Medical College and Government General Hospital. The Diploma in Diabetology course at Madras Medical College, recognized by the MCA, was his brainchild. It was started in the year 1986, and till date, numerous students have joined this course and come out in flying colors. The Association of MMC Diabetologists is also patronized by our beloved Professor V. Seshia. So I welcome the chief guest, of course, because of his commitments, he could not make it up, and Professor V. Seshia and Professor A.K. Das, who have come all the way from Pondicherry. Is a very busy person, so probably in another few hours he may be at Delhi. And my teachers, Professor R.S. Hariharan, Professor A. Sundaram, and that the luminaries from the obstetric and gynecologist for having come over to attend this webinar. So once again, welcome all, especially all the delegates for this illustrious academic program on gestational mellitus. Thank you very much.
Thank you so much, sir. Now moving ahead, I request Dr. Panir Selvam, who needs no introduction, a very, very busy diabetologist, who's the organizing secretary of this program. Kindly, sir, come and enlighten us on the purpose of GDM awareness program. Thank you, sir.
Thank you, Dr. Pushpa. Our Professor Dr. Seshia, and our birthday wishes to him on March 10th, his real birthday. We are advancing today to conduct the CME. My best respects to our teachers, Dr. Sundaram, Dr. Hariharan, Dr. A.K. Das, and all other senior colleagues, and Anjalakshmi Madam, Sindhya Madam, and other gynecologists who are all participating in the webinar, and all participants all over nation, not only from Tamil Nadu, all over nation, they are listening. So for everybody, warm welcome and good afternoon. So Dr. Sheshaya has started this project after his retirement in 2004, after doing some work in the Stanley Medical College. Then he started observing the percentage of GDM is at higher side. Subsequently, he started proceeding to epidemiology at Tiruvallur district near Chennai. About 5,000 pregnant women and 5,000 pregnant women in Chennai, 10,000 pregnant women he screened. Of course, some of us are part of it. After going through that only, he has come out with a large number of rural women and urban women are affected by GDM. For example, in Tiruvallur, 10%, in urban area, about 20%. Now the percentage is getting increased. On top of it, we again approached the government. Government lucky enough to issue the order of universal screening in 2007 itself. But of course, now 14 years over. So his dream is we have to prevent GDM in the pre-conceptional age, as we discussed now, a few topics, and we have to identify GDM very early and control it. So we should not metabolic diseases or NCDs to the younger generations. That is the aim. For that purpose only, he is projecting this as a separate project. Along with the maternal and child health program in the central government as well as state government, gynecologists and diabetologists should sensitize our government to take up this screening of diabetes also in first trimester, second trimester, and third trimester. Like we are giving tetanus toxoid, like we are screening for hemoglobin, HIV, etc. Diabetes screening must be there for all pregnant women during all three trimesters with a single test procedure. So by which we can definitely prevent the incidence of metabolic diseases in India. That is his goal. For that purpose only, he is sensitizing all of us. So to start with, he is sensitizing medical professionals, experts in this area. Then subsequently sensitizing all the gynecologists, diabetologists, etc. And in pregnant women and their caregivers and in the community. Otherwise, we should take this as a project along with the maternal and child health project. Then only we can succeed. So whatever we talk, whatever we do research, whatever we discuss, it should get translated to the patient benefit. For that purpose only this annual event of GDM, National GDM Day. That is the purpose of meet, and in subsequent years also we are going to further strengthen it, further improve it, further give the benefit for the society. Thank you. Pushpa?
Sir, Bhavadani madam is going to introduce Vijaya madam.
Right.
Bhavadani ma'am. Bhavadani ma'am, irkingla?
Audible?
Yes, ma'am. Yes, ma'am.
I request Dr. Vijaya, the Professor of Obstetrics Gynaecology, MMC, and she has 20 years teaching experience for both UG and PG, and she has been an examiner both in Tamil Nadu, Kerala, and Karnataka. She is the member board of Institute Tamil Nadu and India, board of studies for undergraduates and postgraduates, and national level master trainer of MCST, and she is the executive member of papers published in various national and international journals, and she got the best paper award. And above all, a field of interest is mainly in pregnancy, diabetes, infertility, and laparoscopic surgeries, and she has done a lot in improving the medium. Over to you, madam, for the felicitation.
Yeah, good morning, everybody.
Good morning.
Hello, am I audible?
Yes, madam. Okay.
Yeah. The Institute of Obstetrics and Gynaecology, you all know it is more than 177 years old, and it is one of the biggest institutes in Southeast Asia, catering to about 16,000 to 18,000 deliveries per annum. And we, the Institute of Obstetrics and Gynaecology, along with the Institute of Diabetology, have started working in unison towards screening, monitoring the GDM mothers for the past 4 We have celebrated our Ruby Jubilee celebration in 2018, and because of COVID, we are not able to do it in 2019. 20 we didn't do it, and now we are going to work out towards framing policies about as Anjalakshi Madam said, about pre-pregnancy counseling, and also monitoring the GDM pregnant mothers, and more importantly, the concentrate on the postpartum follow-up of the mothers on a long term, which is very much lacking. The statistics is very much lacking in IOG, and also we are focusing on having a perfect statistics as Dr. Sundaram suggested, to have GDM not only for our institute but throughout Tamil Nadu, if possible, with Dr. Sesha's help and all your diabetic association's help. We definitely need that, sir. And also, I am concentrating and coordinating with our neonatology department to follow up the children of the diabetic mother on a long-term basis, at least for 5 years at least. That is the strategy I'm going to follow for this coming 1.5 years, which I have the service, sir. I always ask for your cooperation and help and guidance, sir. Thank you so much.
Very good, madam. Very good.
I call upon Professor A.K. Das, who is the former Director HOD in JIPMER, now the HOD of Medicine, Pondicherry Institute of Medical Sciences, and to give us felicitations. He is well known to India and also abroad.
My dear members of the National GDM Awareness Implementation Committee, Professor N. Rajendran, Dr. Panirselvam, Sundaram, Hari, my close Dr. Periander, Sanmugam, I will not take all the names, and my colleagues from the Institute of Obstetrics Gynaecology and the Institute of Diabetology, and the entire country's people who have assembled for this particular day. Dear friends, it's a great occasion for all of us to celebrate Professor Sesha's birthday as the GDM Awareness Day for the entire country. And dear friends, it needless to mention that it's our greatest pleasure, and sir, Professor B. Sesha, sir, our sincere reverence on behalf of all of us who have assembled here, the participants, the faculty, the members of Institute of Diabetology, Institute of Gynaecology, Professor N. Rajendran and his team, Panir, and all of us to offer our sincerest pranams and seek your blessings on this very auspicious day. Dear friends, I must tell you that Professor Sesha is an iconic figure. He is an institution by himself. You will see as I describe in next 5 minutes, I will not take more time. You will see how he is an inspiration for all of us. And this candle, which has enkindled many lamps in Tamil Nadu, in the entire country, we will glow bigger, glow faster, and will enlighten many more candles. He is the distinguished professor of the Dr. MGR Medical University. He has been the teacher par excellence. He is now termed, adored, and revered as the father of diabetology in India, a great honor. Dear friends, on this auspicious day, I'd like to capture few glimpses of his life just for the purpose. It will be embarrassing for you, sir, but it's my great pleasure to present these facts to the younger generation, to inspire them, to see what they can achieve in their life. Dear friends, he was the proverbial captain in the Indian Army, fought the Chinese War, the Indo-Pak War, and won many medals. I'll mention 2 medals. The Samar means Juddha, Samar means war. The Samar Seva medal and the Sainya Seva medal, the soldiers' service medal from the army. From the day he joined as assistant professor, I cannot complete my felicitation without remembering the professor of Professor Sesha. On the birthday of Professor Sam J.P. Moses on the 1st of June, Professor Sesha will be there at his footsteps, at his door to take him out. We cannot complete the felicitation without remembering SGPM. Dear friends, joined him as the assistant professor and became professor at very young age of 38, 39. Dear friends, he is instrumental for many things in our country. I'll recount one after the other, which I consider very important for me. And there are many more which Dr. Rajendran and others have said. I will not repeat them. Number one, he established for the first time in the country diabetology as a specialty, a single digit specialty for the first time in the country, and you see the status of diabetes today, it is only because of him it got the recognition. He established the first department diabetology in the MMC, and also he started the first course of post-graduation in diabetology, which is recognized by the MCI. Dear friends, I was listening to Professor Vijaya. He was the instrumental in starting the first feto-placental maternal unit in the Institute of Obstetrics Gynaecology. I have visited that. Dear friends, I must tell you that diabetes is a big problem in India. The contribution of Professor Seshia in preventing diabetes, preventing this transgenerational transmission by preventing and proper care for monitoring, screening, monitoring, and proper care of diabetes will go a long way in changing the scenario of the country. Dear friends, because of his untiring effort of developing diabetology specialty, not only in Chennai, but the entire country, he was bestowed on the Dr. Bishroy Award, one of the highest awards for the medical personnel in 1988. I remember R. Venkatraman, the president, conferred the award on him. Dear friends, he has won many awards. I'm just telling them to inspire you, my dear friends. One is the Distinguished Member Award from API, Master Teacher Award from the ICP, the Lifetime Achievement Award from the Dr. MGR Medical University, DSC from Dr. MGR Medical University, and the most important to my mind is the Lifetime Achievement Award from the IDF, from the International Diabetic Federation. Author of many books. The books which I like most are two: the Handbook of Diabetology, which has gone into 8th edition, book on the diabetes and pregnancy, and a contemporary topics in GDM published by our own JP, a very much demanded book. Dear friend, because of his contribution to women health, he was invited to UN as the Indian Lord representative, only representative to the Alliance of the Women Health to the United Nations. He was a member there. Many positions he has held: Vice President of the IADPG, the founder of the DIPSI, the founder president of DIPSI, the patron of the RSSDI, the organizing secretary of EPICON at least twice in Chennai. You know, his contribution is great, and far we cannot recount all of them. Now he has been termed the legendary diabetologist for two important contributions. One is the one-step procedure, dear friends, which is in the scenario of the country. This one-step procedure is adopted by the Ministry of Health, and N. Rajendran sir, for the first time, we are going to have the new edition of the book. For the first time, the country published a book called the Handbook of the GDM. Sundaram sir, it was possible only because of him. We call it the Yellow Book, and is going to new edition, which gave for the first time in the country a diabetes guideline on any aspect. And that is the book which has become our Bible today. He was the author of that book, and the only book published by ministry. And I must also tell you that he has also given to the world the concept, this single-step procedure can change the scenario of the country. Today, apart from Tamil Nadu, and my close friend, Mr. Radhakrishnan sir, IAS, is not here, but I will tell him, I'll write to him that this is called Tamil Nadu model, and it is accepted all over the country. I'll tell you the country, states, because as you know, I travel a bit, not a bit, travel quite. So, you know, in Bihar, in Delhi, in Odisha, in UP, in many other states of the country, this single-step procedure is accepted. And as I told a few minutes back, in the Asian study group, we have accepted this. And I was delighted to see the country after country in the DASG, Diabetes Study Group, presented last month this particular study. So it has become now in Egypt and Africa. Dear friends, I will say a few things before I close. Beyond all this, Professor Seshia is an embodiment of love. He is a Ajata Shatru. He does not have any enemy. His smile dispels gloom. His smile disarms the enemies. And he is loved by everybody. I tell you, tell me, have you seen the professor so bright? And he'll call you by first name, spend time with you, call you for a cup of coffee, call you to his house to have a good South Indian vegetarian. You know, he is beyond expectation. Dear friends, before I close, my time is coming to an end, 30 seconds left. he has taught us few things. Number one, he has taught us to be focused and to be enthusiastic. Sir, I have learned it from you, to be focused and enthusiastic. I knew a writer who won the Gyanapit Award and is a Padma Bhushan. He is Manoj Das in Pondicherry. He once said he learned from his teacher, not a single day go without writing a line. The guiding principle of Professor Sheshaya, which he has taught us, that not there be a single day on which you are not focused on the professional region. Today also, last week also, his papers have come. He is focused on the professional region. And last but not the least, he says your workplace is your temple. You work as you worship. You are the priest in the temple. Work with that sincerity as you worship in a temple. Dear friends, his life is an inspiration. His life is a beacon light. And his birthday, we call it, I'm from Pondicherry, we call it Bon Faith. And when we celebrate 1 or 2 days earlier, we call it Avua Bon Faith. Avua Bon Faith means advanced Bon Faith. Sir, on behalf of all of us, Avua Bon Faith, we seek your blessings that we can emulate you. We can, most important, we can put your dream into practice. Who is the person who can change the scenario of the country except your finding, your gift to the country, the one-stage procedure? Who can change the scenario of NCD when you announce from the rooftop that GDM is the mother of all NCDs, taking the cue from the fetal origin of adult disease? Who said to the country that if you want to change to prevent diabetes, your DIPAP study, there is no end to speak about him. He did with the World Diabetes Foundation, government of Tamil Nadu, all of you were there, Panir was there. He gave to the country DIPAP, Diabetes in Pregnancy Prevention and Awareness Program, DIPAP program. It is endless. I must tell you, dear friends, we have made a good beginning. But what is your best way of showing our respect, regard, love, and pranams to him is to emulate him, carry out his dream of saying that India becomes diabetes free to control of GDM. India becomes NCD controlled, NCD free through GDM. Our sincere pranams and reverence to you, sir, once again. Thank you for giving me the opportunity.
Panir,
sir,
only 1 minute I need.
Oh.
I will not go beyond that. Yes. Okay?
Yes, sir. Yes, sir.
Please, sir.
Sir, every one of you know the better side of Dr. Sheshaya. The beginning, when he came up after passing his MD, when he came to KMC and then to GH, like out of 1 million sperms, one get impregnated. One worm gets impregnated. 17 people competed with him, went to the court. No one could win. It is a sincere desire that has won. Number two, he was senior to me by 8 years. He has helped me in giving books for reading in MD. I think neurology books are still I remember. And then he became assistant to Professor Sheshaya, where I was a PG. And the time from when he joined, his aim was to start a department of diabetology. Nearly 1 year. Morning he was in secretariat. Evening he will send me to secretariat. And the pricks we got from others is so much. We have not given it up. He has not given it up, sir. I hope you will remember that. Even professors of medicine have written against us. Even in mortality meeting, they used to scold us. But I used to fight with them. Why you are always pinpointing diabetes? The most important quality is how to treat your assistants. He has never treated us as assistants. And he allowed us to criticize his slides. That is how we were all developed. No one gives you, project the slide for and against. You used to ask us to project this, criticize the slides, criticize the topics. I used to wonder, he always sent me to OP. Others were sitting and writing in the room, in his room. But he will always include my name. And once I told him, because you have sent me to this, I have written a book called Diabetic Time. with the 300 questions answered. He made it to be published with the health secretary and health minister. And Lalita Kameswaran, the vice chancellor who came. He was a human. What you are mentioning, Dr. Das, he was a human. And one by one, he chose his assistants. So you grow with your assistants. And in fact, in one meeting, I asked him, we are also a very important part in your development. For Paneer, you only made me to talk like this because you said he has done everything outside after his retirement. It's not like that. 10 years, I have carried more than 10,000 samples from Institute of Obstetrics to MMC with a Ganesan, one technician. And he used to appreciate, you only should go. Then Dr. Anjalachi joined. See how he gave place to obstetrician in those days. Maybe in 85, he brought her in. And that's how his interest grew among people who stood against us, from dean to principal, professors to principals. But the secretary was very firm. And whatever Professor Moses wrote, he has agreed. And it is his perseverance. That is what I have learned. Everyone should learn. All thrones are not got in one day because of lot of pricks and thorns. Thorns only, if you undergo hardships only, you will come up in your life. That's why I requested obstetrician and others, respect our own criteria, follow our own criteria. Thank you. I cannot give more than this to my professor. Thank you, sir.
Thank you, sir. And the greatest message was be Indian. Indian problem has Indian solution. Indian problem, Indian solution. Don't blindly follow the West. That was the greatest message, sir, which we'll remember throughout our life.
Thank you, sir.
Paneer sir, half a minute, sir. Paneer sir, we are planning to celebrate Dr. Sesha's birthday, 10th March, in a grand way, along with the Institute of Diabetology at IOG, sir.
Oh. Even after retirement, sir is continuously doing the job, sir.
Neersamam sir, 1 minute. Can I talk? As Dr. Vidya told, March 10th from Foxy throughout India, we are conducting a diabetology summit under Dr. Hema Divakar artist, and this has to be given importance from adolescent. So we are conducting a quiz program on that day from afternoon session completely, almost 10 teams from Tamil Nadu, 3 girls and girls or boys, whatever it is. 10 teams we are conducting defeat diabetes. That is on March 10th from Foxy. Thank you, sir.
Very good, ma. Very good. Congratulations, madam.
Of the day, sir. Thank you.
And again, I just want to add, as our Pradhamar Modi always used to say, things to be made in India.
Yeah.
Made in India, the single step criteria.
Make in India.
Yeah. And our professor is also vice chairman of International Association.
Babadarini, madam, audio not clear.
Madam, sir is the chairman, executive board, international.
The audio is not clear.
IADPSG also.
Yeah, he's the vice president. He's the vice president.
Has developed the single step procedure for Indians. And now we'll move on to the main thing, that the speech by our legend, living legend, Professor Godfather Sesha, who is the Pidamagar Bhishmar, who took us note on the impact of diabetes and pregnancy and diabetes. Over to you, Anna.
So wonderful. Thank you all very much for your kind words and affectionate words. I have no word how to reply that, but nevertheless my heart is always generous. As Sundaram was telling, I may scold, but at the same time it's only scolding not for the sake of hanging it to more increase or work more. Because I was the army, I am a taskmaster there also, because army without taskmaster, you can't serve the army for 4 years. I worked in the, as Ashok told, only in Himalayas. I was not put anywhere in the peace area. That is called field areas. You would have read in the paper a few years ago, Yuri Puch, that Palakot firing. There only I was working. Imagine that type of place I survived, and I came here. It's God's grace. I'm back here. So now I want to share with you. I'm not a good speaker like Ashok. I will. They said, so wonderfully they spoke now about me. Now I would like to share with you. Everybody has got through trumps and turbulations. I won't talk about turbulations. I would like to speak only on triumphs. What I did now is not possible. Now, now I want to share with you my heart. Why, what I've done, and what most of you have told us now. I would like to share with you what had happened in the development of diabetology or diabetic pregnancy. As Vidya has told, I'm very happy. She's doing extremely well in this institute director. I wish every director comes like that. Now, all of us should know this important message, which I also wrote. In this GDM is an important problem at all levels of economic development, but immediate and pragmatic considerations may limit the resource development of this issue developing. That is a problem which I am always crying. What to do in this country? I cannot spend money in this country. People can't afford even one meal. What test we can do? Now best we can take care of them. That was my aim. Now, 1970s, in the year of 80s, those years, none of us know much about diabetes and pregnancy, not very much known. So when I was the IDF conference in Vienna, myself and my mentor, Professor Moss, we were having one dinner. I didn't show the photo, it is there. In a dinner, we discussed about this problem. I don't know, wherever you go, the discussion will come. When we maybe conference or dinner, still we discuss. Then he suggested, why not we go to this Aberdeen Royal Infirmary, the largest hospital in NHS Grampian, located on the Forest Hill, St. Aberdeen. Here is a teaching hospital with around 900 inpatient beds, the biggest hospital, offering tertiary care for population of over 6 lakhs across the north of this colony. The importance of this particular center, why I want to ask to visit is this one, a unique diabetes and pregnancy service where diabetologists, that is Stovers, and obstetrician Professor Sutherland sit together and decide the management. That is very unique. So that I went there to see what they are doing there. And after that, Professor Stovers visited India also to see our place, how we are working here. Then when I came back from the Aberdeen, we started the feto-placental maternal unit, which was I was guided by Professor Moses, and then I hope those days the director, I don't know, director post or superintendent post, Dr. E.S. Phillips and myself, we started the feto-placental unit in this institute here, which Vijay was telling, almost 200 years old institute. Fortunately, this building is maintained. Hope they retain. This is such a beautiful architecture to see this place. Then what happened, those days I was telling you, none of us knew very much about the pregnancy and the diabetes. And most of the time what happened was, people thought the fetal wastage due to VDR, the venereal diseases. So any fetal wastage, they say, okay, give her periodic injection. I don't know how many senior officers knows about that. I'm telling my age group those days, mainly periodic. So PDRL, orphan anemia, glucose, all these things are considered a problem of pregnancy lost. But when what happened, in that time, we found out in our statistics in the hospital that glucose abnormality seems to be a very important cause for the fetal. First time in India, we found out this is the cause for the fetal wastage in the pregnant woman. So this paper was presented in the idea of Nairobi, 1982, where Aryan, who listened to him, was chairperson, and Dr. Sundaram was very effective speaker. He was also one of the author of this paper. Srinivasan and myself, we published. No, those days we don't have much money. We got what is Xerox book. This, I don't know how many book I took it to Nairobi and circulated. This book, such a simple book, impressed so many people. many people visited our center to see what we are doing in this country. So this is a message in this book. Abnormal glucose tolerance appears to be the most common attributable cause to bad obstetricity. So imagine those were more concerned only on the child. We didn't bother about how GDM going to become a problem in the future. Any deviation of glucose tolerance from normal during pregnancy is associated with increased fetal risk. So this is what we are concerned more and more on the babies. So this was the message. Because that is the first time Western world came to know our data in the Asian country, particularly in India. So those days the criteria of diagnosis was very difficult. Underground oral glucose. Imagine they used to do fasting 1 hour, 2 hour, 3 hour, and the value I told you 90, 165, 145. The problem is those days, something somebody was telling at the Southern told, the birth rate in the hospital institute was almost 16,000 delivery in that hospital those days. So how can I do GTT in all the people? Not possible. So we wanted to develop some other test which can be utilized for the diagnosis. This is one of the important work. I am telling this is one of the biggest trump for us. Journal of Obstetrics Gynaecology, important journal for the obstetricians, where we published spot test for blood glucose in pregnancy. As far as those days, this is called Sasha spot test. So this was published in 86. So as early as so many years, 86, 82, 86. So this spot test very, very important. Even now, I think this one Shashank Joshi told me, sir, this spot test is still good. Why I am telling here, this is what happened in the study. So we found those days was whole blood glucose, not the plasma glucose. If the patient is fasting, it would be 82 plus or minus 5. Then we did for half an hour, 1 hour, 1.5, 2, 2.5 hours, 3 hours. So we did like, suppose a woman comes to the clinic there, said I have taken some food 1 hour before, then we do the test. Then she says I have taken 2 hours before, again do the test. And then when you put the graph, it was so surprising that peak goes around 2 hours here, and then comes down, 3 hours, 3rd hour comes down. So when she says I have come after 3 hours after food, whatever result comes, we'll call it as fasting. So this is a simple message what we got and gave it 1986. Then then they are progressing here. Then in another publication, the same journal of Gynaecology, you will be surprised to know that the first time we published in this country that what is the prevalence of GDM in the country is, the study reveals that even minor abnormalities of glucose intolerance are as much associated with the increased fetal loss as GDM. So there is again an important milestone study done here. Then after that, progressing what are we did those days. So those considered 120 milligram is considered abnormal during pregnancy. Actually 90, then 125. So any woman whose blood sugar more than 120, we don't leave them at all. We consider abnormal. It's not 140 those days. 140, 120, you don't worry about that. We will try to manage with meal plan. Now we don't call them diabetes, abnormal glucose tolerance. That is how we are progressing. Now I'll say what happened. Next to us, then the Western world started looking at us, what you are doing in India and Chennai. So Professor Jeremy Walsh was the chairman or the president of the International Diabetes Study Group, IDPG. Then he came to India. He inaugurated that time in DIPSI, inauguration of DIPSI in 2004 during the first International Colloquium of Diabetes Pregnancy. That he only inaugurated. That's the continuing now. That time, then what happened? That we call the governor those days as Barnala. You see Ashok Das standing next to me because he was the first president of the DIPSI. And the Balaji is there, and then Albert Levy, who came from Spain. That is how we are slowly from local fellows, we become little more internationally known in other countries. So, and another thing was here, another study what we did was, this is another important study. The total number of pregnant women is 3,000 and all screened. Out of them, 16.55% found to have GDM. This is the first publication from India. 16.55. We are a little worried about that. I think this was done initially in RSRM, First study was RSRM, then we followed in our Institute of Obstetrics and Gynaecology. But at the same time, I think if I remember correctly, that Anjalachi also was doing similar study in KGH, what I call Consumer Medical College. She came, her finding was almost similar to our data. So I was convinced that definitely there is increased prevalence of GDM in the population. Though we are poor, even Rayapuram area is so poor, but almost 20% of them at GDM. I was really shocked and surprised what to do with that. Then we did, as Ashok told, and pioneering effort for the first time in the country, diabetes pregnancy awareness and prevention project supported by the government of Tamil Nadu and the World Diabetes Fund. It's great. They supported us at that time. I don't know. I was fortunate. I had a good secretary. One secretary was not that good. That time, it's a good secretary was there. I just don't remember the name. And
Subraj sir.
Yeah, good. He's a very good fan. He's also a very trim fellow. Sundarvadanama.
Subraj.
Not Subraj. Sundarvadan was there.
Sundardevan sir.
Sundardevan was the secretary at that time. The previous secretary was not willing to give a study in the state. Then Sundardevan signed the study, and then Professor Leo Bray was the president of the IDF, and I was there. Then of course it was again supported by WDF, Dr. Anil Kabur, and Professor Balaji was an important person in this particular study. This study, task force people were all. Anjalachi was involved in that, Pandit Sarnam again, Bhavadharani and Madhibala. They are all involved in this task force study. Then we published the data, which is frightening that time was, this one was what happened. I think Dr. Balaji also showed this slide. In this study, what happened, we found that risk factors for this, almost 17.8% in the urban area, semi-urban 13.8%, rural 9.99%. Age 25 years, BMI 25, these are risk factors for diabetes. So average prevalence of GDM was so much, almost 30%. So this was the paper published 2009, International Journal of Gynaecology Obstetrics. So after publication of this, we went to the government. That time, as somebody was telling, Mr. V.K. Subramanian was the secretary. He was so upset and impressed with the study. He said, we will make the screening of glucose tolerance during pregnancy made mandatory. The order was issued. So you imagine, some secretaries were good, some people were not good. They were not impressed. That's what I would say. This man is so impressed. All the time he was impressed with the study. Then he gave the instructions to screen. The only problem is the secretary has given. What other people following, I don't know. That's what happened in the state. The follow-up probably is a little difficult unless secretary shows interest. Now, the next study was, we found again this interesting study, what Balaji also was telling you, gestational diabetes mellitus in all trimester of pregnancy. This is again first time in this part of the world, where we found not 24th, 25th, which you are all talking in the class, it is only within the 24th, not that. Even the first trimester we find, I think Anjalachi was telling it's maybe having a problem. So in this article, we also found very high, this slide again shows you almost 16% diagnosed in the first trimester, 22% second trimester, and third trimester. So that means almost 38% of the women have got glucose tolerance in the less than 24 weeks. That shows we have to screen blood sugar for this in the early weeks of pregnancy. So we published the article, GDM managed all trimester of pregnancy in the DRCP journal. Timing in this is journal which was published. The Pandit Sarnam is one of the author here. Then it was published in the Diabetes Research and Clinical Practice. Then came this, I suggested Anjalachi what to do now. Spot test. So see, the spot test doesn't have that, it is possible, but you want a G test. So I suggested you will do this test, give the woman fasting and not fasting. I start, Balaji was telling. Then the single test procedure, diagnosed GDM came in 2009. It was published in the Acta Diabetes. Very important journal because these fellows were not publishing this paper long time. It took 1 year to publish that. So Make in India guidelines. This study was done in the Institute of Obstetrics and Gynaecology, government Madras. So I'm happy Navja can say this study was done in the Inner Institute where she is now director. About this, then from that we went to the government of India. Now we are moving from Tamil Nadu government, we are moving to the government of India. Sanjay Gupte, all these things gone there. The government of India accepted, and they would like to involve GDM, what do you call in the public. So they kill one-step procedure is feasible. The routine testing ANC for all pregnant women. So this is another step which from state went to center. So now, as Arshak was telling, national guidelines, diagnosis and management of research diabetes, as he correctly said, this book, this introduction they written, we are following the Tamil Nadu models data, because no data is available in the country. So they showed the data which I showed in the earlier. Then they started giving all the guidelines. These two people were responsible, Himanshu Bhushan and Dinesh Baswal. So these guidelines has come out in 2004, again it came again in 2018 also. So we suggested at that time that the guidelines and diagnostic criteria which are simple and feasible on the ground or in this part. 2017 is published in the BMC journal. We have gone the international publication number of times. Now finally, government again realized what is happening in 2018. They published another copy of that. In that, everything is settled. Now, what happened this time, people, the Sanil Kapoor, Hemant Javakar and Balaji and all, they said, we must have an awareness day for gestation diabetes maintenance, appeal to request, declared 10th March as a National GDM Awareness Day. It was sent to the government on May 27, 2016. Note the date. In spite of that, 2016 was sent to the government, all the associations joined together. You see this lady here, Bhavdharani and Rajesh Jain. You don't know how this Bhavdharani's capacity. She was sitting in Delhi for almost weekend she will go there and convince them the importance of this national guidelines awareness. And Raj Jain from Delhi, and then the order was issued on which date? The order was issued. I don't know which date. 18th
March.
2016 took 2 years for them to decide, because very difficult to convince them that this is an important problem. And Dinesh Baswal was the second Minister of Health, and that was given. Another story is there. How it happened, I don't know, it's another big story. But somehow this order was got on 28th of 10th March by the Minister of Health, Government of India. So now, friends, I'm very happy that DIPSI has been accepted in the International Diabetes Federation 2014, and the science of diagnostic criteria of 7.8 million 140 milligrams, just like NICE guidelines 1.2. That means we have achieved our aim of putting our guidelines in the international forum. Now, medical management, metformin, insulin, Minister of Health has approved the use of metformin, and now there is no doubt about it, we can use it freely, there is no problem. So finally, the growing fetus should not know that his mother has glucose intolerance. The glycemic target should be that tough. Now, these are 2 point messages that are very, very important. If we follow that, probably we can avoid India becoming diabetic capital of the world. Hope it is possible. It hope. Then finally, I suggested, I've been saying that any disease in the world, any disease, either diabetes, hepatitis, any disease, all start with the fetal arthritis, starts there only. Fetal arthritis, David Barker said, that is why I coined that as Charles was telling him, what we should do, focus on the fetus for the future. If we can focus on this, we can avoid our country become dead. The world also can avoid it. But instead of quarreling, discussing, you do that, and do that, nothing is necessary. Just follow what is normal. It will be outcome very, very good. So what is this? My final slide, my message is what is needed. Public-private partnership, which were done and succeeded. Now I wish Dr. Vijaya and Dr. Dharmaraj take this message to this health secretary. I wish he was there. Tell him, sir, unless you take part in that, none of us can do. We are also see, there's a problem. Unless child wants, mother can't feed. We need to work, but government should support us. I will take to the government and see that again another study is done in this country. Thank you very much for your passionate. Wish you all the best, my friends and gentlemen who listen to the talk. You can spread this message to everybody. I'm very happy that you are all here. My blessings.
Thank you, sir. Thank you so much, sir.
Thank you, sir. We assure you that Dr. Vijaya, HOD, IOG, and also our enthusiastic Professor Dr. Dharmarajan will take up.
Yeah, they should do that.
Definitely, sir. Definitely will do, sir.
Thank you.
Yes, sir.
Now I request the Director of Diabetology, Rajiv Gandhi Medical College, to give the vote of thanks. And also giving an
Assurance.
Thank you. Thank you, Dr. Bhavatani. Respected teacher of all teachers and our guru and Professor Sesha sir and Professor Ekeda sir, Professor our teachers, Professor R.S. Hariharan, Professor Sundaram, Professor N. Rajendran, all our senior professors, Director and Superintendent, Institute of Obstetrics and Gynaecology, past and present professors, colleagues and other dignitaries. Before starting, we'd like to convey our best wishes and pranams to Professor V. Sesha on his birthday. Malta Vaidillai sir, Mananguguram. On behalf of the faculty of the Institute of Diabetology and the Institute of Obstetrics and Gynaecology, it's indeed a great privilege and pleasure to propose a vote of thanks on the occasion of this CME program on diabetes in pregnancy. On this occasion, first, I would like to thank our dynamic and beloved Principal Secretary, Dr. J. Radhakrishnan sir. Though he was not able to attend the conference in person, he has responded through a message wishing all success. And we would like to thank him for committing for attending this program. Thank you, sir. I would like to thank our mentor and guru, Professor V. Sesha, for having guided us to conduct this CME and creating an interaction between diabetologists and physicians, and thus paving a platform for improved GDM care in our country. Of course, at the same light, I would like to assure you, sir, that along with our Director, Professor Vijaya, we would like to take your message to the Health Secretary and to convince him about the importance of this public and private partnership, public-private partnership, if we want to achieve success in the same lines in future. I sincerely thank the Director and Superintendent of IOG for all the arrangements, cooperation, and help for making this program a grand success. Thank you, madam. I sincerely appreciate the efforts taken by Dr. Anjalakshi, Dr. Periyandavar, Dr. Pannirselvam, Dr. Bhavatarani, Dr. Anand Moses, Dr. Shanmugam, Dr. Balaji, and others for conducting this CME in a smooth manner. Yes. I thank all the faculties, chairpersons, and speakers for their sincere preparation and enlightening us on diabetes in pregnancy with their rich experience and knowledge. I sincerely thank all the delegates, students, and other colleagues who have logged in for the CME. My sincere thanks goes to all the faculties of the Institute of Diabetology and Institute of OBG for having told to make a grand success. Our thanks to all the pharma companies and the sponsors, Mrs. Vocards, who have provided the virtual platform assistance for conducting the CME and function in a grand manner. Our thanks are due to each and everyone who have been responsible for the grand success of the CME and who have been missed out inadvertently. Thank one and all for logging in and making this CME a grand success. Thank you all, sir. Thank you.
Another two sponsors, Sun Pharma and Novo.
I wish to thank Mrs. Sun Pharma and Mrs. Novo also for their financial support for this CME. Thank you, sir.
Thank you, Dr. Dharmarajan. Pushpa, we'll move on to the next session.
Yes. Yeah, already the session was running, so we can just switch over to the session which was going on. So request Professor A.K. Das.
Anand Moses.
This is
we were already going into the session 3. So we request Professor Anand Moses and Madam Sampath Kumari to kindly take over the session and continue.
I think Pushpa, you were introducing Dr. Sampath Kumari. You didn't finish it.
Yeah, actually,
Bhavatarani Madam was introducing.
Bhavatarani Madam, it's over. We will start the program. No problem.
We will start the program, Madam. Speaker. Yes.
Dr. Paneerselvam.
It is Paneerselvam, the first speaker. It's my, first of all, I should thank the organizers, particularly Dr. Paneerselvam, Bavdarani, and others for giving me the opportunity to chair one of the sessions here. I've been listening right from morning. Beautiful and interesting session. And the next session, talk is also going to be quite an interesting topic by Dr. Paneerselvam. The topic is on, wait 1 minute. The topic is on how to break the vicious cycle of intergenerational transmission of hyperglycemia and obesity. To introduce Dr. Paneerselvam, he is one of the pillars of Diabetes Association of India. I would say one of the architects, and man with keen interest in patient education, and who has been responsible for many of the government projects which is there in many of the government hospitals. And I request him to start his talk, which is going to be for 20 minutes. Dr. Paneerselvam.
Thank you, Dr. Anand Moses, and my respects and wishes to Professor Seshaya, Dr. Ashok Kumar Das, and my teachers, Dr. Sundaram Hariharan, and my senior colleagues like Dr. Rajendran Sir and Dharmaraj, and the gynecologist side, and Vijaya Madam, all others. So this topic given to me by my professor is intergenerational transmission. Since morning we are keep on listening how the intergenerational transmission is happening of hyperglycemia and obesity via in utero exposure. So how to break the vicious cycle? So to break the vicious cycle, only our professor is breaking his head for more than 20 years. Now our world, the transmission is being confirmed by so many studies, and it is happening also. And every day the GDM as well as pre-GDM is keep on raising. So how to break the vicious cycle? Only luckily our central government has accepted its birthday as the National GDM Day. So every year we have to sensitize everybody, general public, patients, caregivers, professionals, including health policymakers, planners, etc. So unless otherwise we sensitize. For example, COVID virus, within 1 year, the entire world got sensitized. But of course, diabetes, we keep on struggling, suffering, and we make many people to struggle and suffer. So we have to break the vicious cycle. How are we going to break the vicious cycle? Before that, how the intergenerational transmission is happening, we'll see. So while all environmental and genetic factors contribute to the epidemic of diabetes, we all know sedentary lifestyle, consuming more of energy-dense diet, stress, etc., is contributing for more number of diabetics. On top of it, hereditary, parents are diabetic, grandparents are diabetic. So I have developed diabetes. This let us know. The intrauterine exposure, gestational diabetes are emerging as a potential risk factors. Gestational programming is a process where stimuli or stressors that occur at critical or sensitive period of fetal development permanently change physiology and metabolism, which predispose individual to the disease in the adult life. So if stimulus happens to be the hyperglycemia or gestational diabetes, it predisposes the offspring for increased risk of developing glucose intolerance in future, which we are seeing this morning. So 2 generations are at risk, mother as well as her offspring. So that means the follow-up, postnatal follow-up of mothers as well as the children is essential. So that we have suggested the government along with immunization chart. So while they are coming for immunization, all GDM mothers to be screened for diabetes at least annually. We should give prevention advice. Similarly, after the age of 5, all children born to GDM mothers must be followed. These are the suggestions we are giving to central government as well as state government. Unless otherwise they incorporate in the MCH, unless otherwise we suggest them. And because COVID also, all politicians and IAS officers, unless otherwise we suggest how the disease is getting transmitted, how, what is the treatment. So we have to suggest to them, then only they will take it up. So 17 years of age, 1/3 of offspring of diabetic mother have had evidence of IGT. See, at the age of 17, adolescent itself, they are developing. Once they are girls, before their marriage, they are become pre-gestational. Again, they are giving birth to the same child. This is the vicious cycle we have to break. So type 2 diabetes, genetic or intrauterine. Of course, genetic role also there, but in human PMI Indian, from that study only, entire world started realizing children born to GDM mothers were followed up. By the age of 35 of the age, more than 50% of them developed glucose intolerance. At the age of 50, remaining 50%. Otherwise, children born to GDM mothers are developing diabetes at the later age. So earlier, the sibling born to before the mother developed. Otherwise, the offspring of Pima Indians who are in utero when their mother had diabetes have a greater risk of diabetes than earlier sibling born before the mother developed diabetes. So we did the study with the help of Professor Sheshaya in 2007. 33% of the women who developed gestational diabetes had their mothers had diabetes, 1/3. So exposure to diabetic environment in utero is associated with increased occurrence of impaired glucose tolerance and a defective insulin secretory response in adult offspring, independent of genetic predisposition to type 2 diabetes. So effect of maternal fuel on fetal and offspring development. Even though the genetic factor is playing, so the and your exposure to diabetic environment, that is hyperglycemia, hyperaminoacidemia, and the free fatty acid, they also contribute. So metabolic culprits in utero, big babies, big picture, mother. So your increased glucose, increased amino acid, increased free fatty acid, they freely transfer to child. Then the genetics, beta cell response, appetite regulation, mitochondrial function, stem cell differentiation, energy balance, microbiome. Then triglyceride, hepatic triglyceride also getting increased, postnatal overfeeding, then childhood obesity. If the girl is, the child is girl, daughter becomes mother. So this is the metabolic research cycle, beyond doubt proved by so many studies. So the abnormal mixture of maternal nutrients gain access to the developing fetus and modify phenotype gene expression in the newly forming cells, and thereby causing permanent short and long-term effect in the offspring. So this picture all of us are aware. So this also we have seen from Dr. Balaji's slide and the SAR slide also. If you go by even now till this minute, the ADA recommends after 24 weeks. If you go by screening after 24 weeks, you will be missing the 42% in India. So that only Ashok Madras also told, be Indian, practice Indian, and let us learn globally, act locally. If you go by after 24 weeks, if you screen, you will be missing this 42%. Here also in 17%, few of them are pre-GDM. Now the pre-GDM is keep on rising because of lack of physical activity, sitting in the front of TV, computer, etc. Pre-GDM percentage is also for the past 5 or 6 years keep on rising. So better to screen early and detect diabetes very early instead of going by 24-week screening as per the ADA. So this early programming, Barker's hypothesis, fetal origin of adult disease, all of us are aware. And popularized Barker hypothesis of fetal origin of adult disease may be a single most important observation of the 20th century related to origin of complex disorders. NCD origin is the fetal origin of adult disease. If you don't control metabolic parameters, so NCDs will become more in future. And again, Peterson hypothesis also, we can speculate the classic Peterson hypothesis may be extended into later life by hypothesizing the maternal hyperglycemia is not only fetal hyperinsulinemia and macrosomia, but also obesity and insulin resistance in the adolescents, again 54. So your Barker is 80, this is 54, almost more than 60 years, we keep on knowing this vicious cycle. And prevalence of impaired glucose tolerance are the mother of or the offspring of OG GDM mothers at the age of 5 to 9, at the age of 9 to 6, when compared to control. So in the adolescents, the more amount of IGT, the children born to GDM mothers. Prevalence of impaired glucose tolerance in offspring of diabetic mother in the 3 age group. Otherwise, we have to screen while the mother is coming for type 2 diabetes management. It is better to ask the children to come and screen and advise them. So to prevent obesity, to prevent IGT, or to prevent future type 2 diabetes in them. Prevalence of overweight, 11 years of age, offspring for GDM mothers in relation to maternal BMI. If maternal BMI is more, so 8 years, 11 years, the prevalence of overweight in the children is also more in another study. And offspring of GDM mothers, type 1 diabetes, offspring for non-GDM mothers, See, in obstetrics of GDM mothers only, the prevalence of overweight is keep on rising. In 11 years, the overweight. In practice also, we started coming across a lot of obese children, the mother who has given birth to child while they are gestational diabetes mellitus. So this is a vicious cycle, all of us are aware. So intervention to prevent perpetuation of this vicious cycle, a pregnant woman will be an ambassador for diabetes awareness. So, and prevention and this control, not only for her family, but also for the community. During pregnancy, if you advise any antenatal woman, she also will listen, the entire family also will listen. You can talk to them about diabetes, you can talk to them about prevention of diabetes, even though if they don't have diabetes, the other family members will benefit out of it. So how to break the vicious cycle? The concept of vicious cycle born in 1980 only, about 40 years before. Nobel Franklin, in his Banting lecture in 1980, was among the first to introduce the concept of diabetes vicious cycle by describing evidence and hypothesis on the how excess pregnancy fuel substrates resulting from altered glucose in insulin homeostasis and the potential to lead to adverse effect on the fetus by affecting organogenesis, behavior, and adiposity. Franklin hypothesis that among women with gestational diabetes mellitus, the effect of pregnancy hyperglycemia on fetal beta cell may have intergenerational effect. So this hypothesis postulated 40 years before. Of course, unfortunately, before the discovery of insulin itself, Elliot Jocelyn started telling about the prevention of diabetes. It got published in the JAMA in 2021. So before the discovery of drug itself, of the entire world, Jocelyn started about it, talking about the prevention of diabetes. So a plea for early diagnosis of diabetes. So this is JAMA 1921 got republished in the 2021. Otherwise, the prevention of diabetes is a century-year-old, but unfortunately, in this century, we have eradicated smallpox with the help of vaccine. We have eradicated polio. Without vaccine, we have controlled effectively cholera. Without vaccine, we have controlled effectively leprosy by way of education, awareness, and we have effectively controlled the population by family planning. Unfortunately, for one decade or 1 century, we allow the disease to grow. They are struggling and suffering with complications, even though the prevention concept is 100 years old. So the GDM and pre-GDM, 1991, so the level of GDM was very much low. In red diamond is Asian country, Hispanic country, African American, non-Hispanic. Similarly here, black squares, blue circles, and red, this is type 1 diabetes. This one GDM, this one type 2 diabetes. So this is the age-adjusted prevalence GDM and gestational diabetes will be adapted from these references. Otherwise, GDM as well as pre-GDM, type 1 and type 2 diabetes are keep on increasing. Prevalence and changes in the pre-existing diabetes and gestational diabetes among women who had live birth in the United States. So more the age, more the GDM. So that only it is better before the age of 30, if they complete the delivery or pregnancy, the percentage is 5.1. If they come for another 1 decade, almost more than double. Pre-existing diabetes also up to the age of 30.7, if they come here, 2.1, almost 3 times higher. Similarly, more the obese, the class 3 obesity, the GDM percentage is high. If the normal weight, the percentage is very much less, 3.3, and pre-GDM also 0.4. Otherwise, the importance of weight we have highlighted before consuming. So this sort of weight gain, not only we are seeing in UK, USA, in our country also we started seeing this young adolescent girls are more obese nowadays. The consequence of being overweight or obese during pregnancy and diabetes in offspring, a recorded case study in Aberdeen, Scotland, which has shown reduced obesity among women of reproductive age, and that might reduce the incidence of diabetes in their offspring are urgently required. We are happy that Shantakumari and Dr. Vijaya is there. So they opened this pre-conceptional counseling and even adolescent counseling for young girls about the importance of maintaining the normal weight before their marriage or before they become pregnant. Nutritional approaches to break intergenerational cycle of obesity. So there is the link between the poor maternal nutrition and the increased burden of disease in subsequent generation has been widely demonstrated in both human and animal studies. Historically, the nutritional challenges experienced by the pregnant and lactating women were largely those of insufficient calorie, severe micronutrient deficiency. Of course, more recently, however, Western countries have been confronted with a new nutritional challenge. Not only Western country, our country also, that of maternal obesity, excessive maternal intake of calorie, fat, and sugar expose the developing fetus and infant to this obesogenic environment. See, obesogenic environment results in the increased risk of obesity and metabolic diseases later in the life. So we have to identify and intervene. Facing non-communicable diseases, global epidemic, the battle of prevention starts in utero. The figures, all these could motivate substantial reduction in the risk of NCD. So the current and future health challenge demand new and changing competency that should form from basis of education, training, and workforce planning. The International Federation of Gynaecology and Obstetrics is aware that the responsibility of the joint hands with the other agencies and organizations that make considerable effort to providing appropriate prenatal care and programs to prevent and treat diabetes mellitus. So that really such a OG plus the diabetologist conference or combined conference by the GDM to translate whatever we do, the research studies here, trials, everything should get translated to patient benefit. Obesity management in the woman hereditary age group, the prevalence of obesity, nearly 25% of the women in the US who become pregnant have obesity. There is also evidence suggesting that pre-pregnancy and inter-pregnancy weight loss can significantly reduce the risk of incident of recurrent adverse pregnancy outcome. Important consideration for clinical management, lifestyle intervention remain the mainstay of therapy. This all of us are aware. The medication for treatment of obesity should be stopped. So whatever drug they are consuming, we should stop. And if they are adopting some contraception also, they should stop before conceiving. Intergenerational diabetes, obesity, a cycle to break. Recent trials have highlighted that intervention initiated in the pregnancy, such as increasing physical activity in overweight mothers, are likely to be too late to have an impact on pregnancy. Hence, there is a need to initiate intervention on dietary and physical activity changes in young women of reproductive age. See, after conceiving, no point in doing before they conceive. We have to take initiatives to reduce the weight, adopt the physical activity, improve the insulin sensitivity, etc., etc. Ongoing efforts to reduce the pervasive obesogenic environment, including but not limited reducing the intake of sugar sweetened beverages, now and soft drink consumption and energy dense diet consumption is more, especially in COVID season. Many people are consuming more of energy dense diet, sitting simply in the house watching the TV or computer. They are all becoming obese recently. Prevention of fetal programming of diabetes will need to concentrate on the health of young girls. Definition of critical period in fetal programming will guide us to window of opportunity, which may be pre and periconceptional, gestational, and even lactation. So we have to concentrate in this area. Translating research on diabetes and obesity in pregnancy into prevention. The 2000 Norbert Franklin Award lecture. How do we break this vicious cycle and implement upstream prevention of strategies? He quotes 3 points. Identifying diagnostic criteria of gestational diabetes mellitus, practicable in clinical settings, and implement it in the prevention. So the practical is very much simple for our DIPSI guideline. Examining the trends in the prevalence of diabetes in pregnancy and related complications across racial and ethnic groups to plan prevention efforts. Developing and evaluating scalable upstream diabetes and obesity prevention intervention. So 3 strategies to break the vicious cycle. So for that purpose only, as Professor pointed out, so universal screening in Tamil Nadu got introduced on 14/3/2007, 14 years before. And again from Tamil Nadu, there are 3 types of screening. So first trimester screening, second trimester, 3 trimester screening. Not only that, now that your preconceptional diabetes or pre-pregnancy diabetes is quite common increasing, better pre-pregnancy screening for diabetes, hypertension, lipids also essential. And that Professor Sheshaya, that Anjalashi's single test procedure, which we have highlighted, giving 75 gram glucose, fasting or non-fasting, less than 140 is normal, more than 140. In all 3 times, it is better to do and rule out or the presence of diabetes, GDM. So this also already shown. So 75 gram glucose, our central government also endorsed it. So this also already shown by professor. So ultimately, while monitoring or follow-up, diagnosis only 2 hours after 75 gram glucose 140. So follow-up less than 90 fasting or at least postprandial less than 120, we have to follow up and maintain to prevent the future obesity in the children. So this also already shown 2.5 to 3.5 is the ideal birth weight. If it is less than 2.5, more than 1.5, the prevalence of diabetes in the young girls will be more. So life course approach to DM prevention. During pregnancy, we have to control effectively. Then postnatal also we have to follow. Infants and childhood, we have to avoid obesity and promote exercise. Adolescent young girls before their marriage, encourage healthy lifestyle, culturally sensitive community education, health school and work environment, screening in the high school individuals, regulatory physical, and to improve the educated importance of pregnancy initiatives, etc. Otherwise, interdepartmental approach, I used to say, like sensitizing the muscle, adipose tissue, and liver with the help of metformin and thiazolidinedione. We have to sensitize the healthy policymakers, planners, administrators, etc. Through them, we have to involve, like see, COVID is a public health problem and medical problem, but we involved revenue people, we involved the police, we involved the general public, we involved everybody. So then only within 1 year, not only we have effectively controlled, we have given vaccine to the entire world also. Even though China has given the virus to the entire world, India has given vaccine to the entire world. Likewise, we have to involve agriculture department to promote a lot of fiber-rich diet, food department to promote or to avoid, de-promote energy-dense diet, information and communication department to give correct information about diabetes and gestational diabetes, education department to educate the school children, college students, etc. Local administration department. Otherwise, totally the entire Indian population should be sensitized on part immunization, family planning, AIDS, including COVID recently. So an important public health priority in the primordial prevention of diabetes is to address maternal health both during ante and postpartum period or even preconceptional period. Preventive measures against type 2 diabetes should start before pregnancy itself, during intrauterine period, and continue throughout the life from early childhood. Unless otherwise you do this, very difficult to cope up the NCD problems, including cancer. Now the cancer death is more than that of the vascular death. Recent articles started saying. The timely action taken now in screening all pregnant women for glucose intolerance, achieving euglycemia in them, and ensuring adequate nutrition may prevent, in all probability, the epidemic of diabetes. Statement by our professor. Because of him only, we are all talking all these things. We have to profusely thank you, sir, for making all of us sensitive. In turn, we will make continuously the sensitization in the community throughout our lives. So this is the topic on intergenerational transfer and how to break the vicious cycle. Without education, we cannot break the vicious cycle. Thank you very much for your patient listening and care. Thank you.
Thank you, sir. Fantastic talk. Sir, as you told, this vicious cycle.
I request Madam to introduce the next speaker. This discussion is going to be at the end of the next session.
Next to talk is on pre-pregnancy diabetes and gestational diabetes and spectrum of congenital anomalies by Dr.
V. Prakash.
V. Prakash. I want the CV. Dr. V. Prakash. He is the assistant professor in neonatologist IOG, and he leads neonatologist division of neonatology, Prashant Super Speciality Hospital. So we will, Dr. Prakash, stage is yours. You can take over.
Thanks, ma'am. In the first outer skirt, I would like to thank the organizers for giving me this opportunity to speak in front of this elite group of obstetricians and diabetologists. The topic for me is maternal pre-pregnancy diabetes, gestational diabetes, the spectrum of the congenital anomalies in the newborn. First, I'd like to thank the babies who are delivered at IOG for the past 14 years, where I'm associated with, who taught me neonatology, as well as the babies who are delivered at All India Institute of Medical Science during my DM residency program for 3 years. I always start my talk with my thanks to my teachers, especially like to mention Dr. Kumuda, who was a former professor as well as HOD of neonatology at ICH, Professor Vinod K. Paul, who was a former HOD of pediatrics and neonatology at AIMS. Now sir is in Niti Ayog. And the current professor HOD, Professor Ashok Dure sir, and Arasar Sirar sir, who was my teacher, was a director at ICH, and Ratna Kumari madam and Vijay Kumar sir, who are my professors at ICH. First, I'd like to classify those birth defects. Birth defects are basically classified into 3 types. The first classification is based on the severity. We either do it as a major, minor, or the common variants. We say it's major if the structural abnormalities have some medical or social consequences, like a congenital heart disease, which has some medical consequences. A minor anomaly is something which has no direct health or social significance. For example, a single transverse palmar crease, which can be present in 1 to 2% of a normal population. It can be seen also in a Down syndrome baby. So it can be seen as a minor thing. If there are 2 or more 2 minor abnormalities, the chances of multiple anomalies are going to be around 10%. If there are more than 3 minor anomalies, the chances increases to 15 to 20% of any major anomalies being present in the baby, which has not been diagnosed. Another one is the common variant structural changes that are present at one end of the narrow normal spectrum that do not amount to any abnormal development. For example, we see a sacral dimple. It's a common variant. We don't need to worry about it. It's not going to cause any problem in the baby. The other classification is based on the clinical presentation. It's a single system defect or a multiple system defect. Single system defect, for example, isolated congenital heart disease, or could be a cleft lip or cleft palate. A multiple system disease system defect could be either a syndrome or association or a sequence. A sequence is nothing but a constellation of anomalies that are often seen together due to a single underlying cause. For example, Down syndrome, the problem is in 21 chromosome, trisomy, that causes a constellation of anomalies. In association, the cluster of malformations that occur together more frequently than occurs sporadically. So it is seen commonly associated. There might not be a cause relationship in this association. Sequence is a single known cause, but embryologically unrelated defects. For example, Potter sequence, where we have the renal agenesis, we have oligodermias, renal agenesis, but you'll have facial abnormalities secondary to the decreased there is a sequence. And finally, based on the pathogenic mechanisms, we say it's malformations, where there's inadequate completion or failure for the embryonic process to develop. For example, neural tube defects. Disruption is something like an external event. One of the most common examples is atresia, dural atresia, intestinal atresia, where a vascular event happening in the later part of the trimester can cause a disruption in the normal growth. A deformation is a physical force acts on previously formed structures, like a club foot. Abnormal position, uterus is not accommodating the space, or the liquor is less, can cause a club foot. A dysplasia is a abnormal cellular organization or function within a specific tissue type. For example, a skeletal dysplasias, where can be abnormalities in your collagen, the entire body. So I'll not read the entire thing in this slide. I just want to emphasize that the system organ development starts by the 3rd week. Embryogenesis starts by your 3rd week. The major systems are brains, heart, blood vessels, circulating system starts by 3rd week. It continues developing by 5th week and 6th week as well. But some organs like hair follicles, nipples, eyelids, and 6 organs starts developing by 7th week. So this is the most important phase in the embryogenesis. By 3rd week to 8th week, where almost all the structure development starts happening. Why it's important? Next slide is not moving. Yeah. So the red line indicates if the insult, the teratogen, or the exposure happens in that particular phase, you get a major congenital malformation. By 3rd, 4th, 5th, 6th, 7th, and 8th week, and sometimes extending up to the 9th week, you can see the major anomalies happening in the central nervous system, heart, upper limbs, eyes, lower limbs, teeth, palate, and ears, and etc. So major catastrophe or major problems are going to happen if the exposure is going to happen during the embryogenesis period, between the 3 to 8 weeks. There are some anomalies which can happen, which can cause a major anomalies even after 8 weeks, but majority of the anomalies are going to be happening in the first 8 weeks, 3 to 8 weeks period. So what are the problems which can happen? If the insult happens in the first 3rd to 6th week, you can get a neural tube defects as well as your mental retardation secondary to your microcephaly. In a cardiac condition, you get a truncus arteriosus VST. The upper limb and lower limb, you get amelia, absence of development of your limbs. And minor deformities like cleft lip palate, malformed ears, microophthalmia, glaucoma, and cleft palate are the things which can be seen, or the defects which can happen if the exposure or the tetragen is going to be occurring, insulting the fetus during the, going to insult the embryo during the 3rd to 8 weeks period. Next, so what is more important? In contrast to women with pre-gestation diabetes, women with the true gestation diabetes mellitus are not at increased risk of having an infant with congenital malformations, because the onset of the disorder is after your organogenesis. So true gestational diabetes mellitus, if the onset is after your organogenesis, though the damage, the embryopathy is not going to happen in case of a true GDM. However, it is important to note that some women diagnosed with gestational diabetes mellitus may have had an unrecognized pre-existing diabetes if they are not screened prior to or early in pregnancy. So what happens in this diabetic embryopathy? So high glucose induces membrane alterations via the yolk sac changes, premature aging happens, abnormal morphology of the endoplasmic reticulum, and it prevents a neurative closure. The excess of maternal glucose leads to excessive oxidative phosphorylation in the mitochondria, which can damage the cell wall, causing a membrane phospholipid signaling pathways. Increased free radical reactive oxygen species can be produced, which causes a damage, DNA damage as well as membrane damage. This also enhances your pro-apoptotic proteins. In the endoplasmic reticulum, what happens? The pro-apoptotic proteins are activated, which increase apoptosis. There is a programmed cell death destruction happening in the embryo, resulting in your diabetic embryopathy. Besides these conditions, there are some epigenetic environmental modifications also happening. So the penetrance is not a complete penetrance in case of diabetic embryopathy. We say something called as a partial penetrance, suggests that because all the mothers who are having a diabetes mellitus are not going to have a congenital anomalies. It varies. The sugar levels are going to be the same, higher level in 2 mothers. Both the mothers might not have a congenital babies delivering a baby with a congenital anomaly. One might not. There could be a variability. The severity of defects can vary among the affected individuals, highlighting the non-genetic differences between individuals with the same genetic background and the same exposure. Partial penetrance suggests that even when exposed individuals are genetically identical, non-genetic factors determines whether a given individual manifests a birth defects. Maternal diet is an important non-genetic risk factor for diabetes in pregnancies, underscoring the role of nutrition as a modulator. Transcriptional profiles are altered in the mouse embryos. Variations between the transcriptomic profiles is greater between the exposed individuals, indicating the gene regulatory mechanisms are moderated by exposure, and chromatin modifications, which is a subgroup of epigenetic marker, are altered by maternal diabetes and maternal obesity. So this is a paper published in JAMA. It's a recent publication published in 2020 December. So this deals with the association of the periconception HbA1c with pregnancy outcomes in women with diabetes. Or 3,500 births were included with the mean standard deviation of maternal age of about 32 plus or minus 5 years of conception at the time of conception. The overall mean HbA1c was 7.2 plus or minus 1.6 standard deviation of the preconception to 6.4 in the early pregnancy to mid-pregnancy. They have taken in the early pregnancy means 3 months before the conception LMP period, the values are taken. And early pregnancy and mid-pregnancy, they're taken up to 21 weeks of gestation. Why they're taken 21 weeks? They give an explanation that that's a time period where the HbA1c level varies very less. It's hardly changes by 0.2% in the period. Normal variation of 0.2% can happen in normal deliveries. There were approximately about a 14.4% with a congenital anomaly. This paper. The overall participants percentage of incidence of HbA1c is more than 6.4% is 37.5%. Between 5.8 to 6.4 is 34.3%. So what they have seen, the risk of adverse maternal perinatal outcomes per 0.5% absolute net decline in the maternal hemoglobin between the preconception and the early to mid pregnancy period among the women with pre-pregnancy diabetes. So 3 months before the delivery up to 20 weeks up to the period of gestation, if there is a decrease of 0.4% decrease in the HbA1c, they have seen that any anomaly as well as cardiac anomaly, there was a decrease, relative risk was decreased in the case of any anomaly as well as cardiac anomaly. They are adjusted for some confounding factors like maternal age and maternal hemoglobin level. There also, it was lesser. If the HbA1c level is decreased during the period, there was a decrease in the relative risk. Adjusted absolute risk difference, it comes in minus. So definitely, if there is a decrease in HbA1c level, it is a protective effect in the development of a congenital anomalies as well as any anomalies in a baby. So this is the model, statistical model they postulated, where the x-axis shows the HbA1c level as well as the y-axis shows the adjusted estimated probability of congenital anomalies. Where you can see, as there is a rise in the pre-conception HbA1c level, the adjusted probability of congenital anomalies gradually starts increasing. The dark line shows the absolute risk and the light line shows the 90% confidence interval. You can see as the HbA1c level increases from 4 to 5 to 6 to 6.5 to 7, and after 9, it's as a steep increase, right? The probability of developing a congenital anomaly rises. This is another model, mathematical model, where they have shown the x-axis, the preconception HbA1c minus the pregnancy level HbA1c level, and the y-axis estimated probability of congenital anomalies. If there is a decrease in your pregnancy level, so for example, if the preconception HbA1c happens to be 6.5 and the pregnancy level is going to be around 5, so value comes in minus, it's decreased HbA1c. So the negative value there shows that the the probability is going to be, congenital anomaly is going to be lesser. So 2/3 of anomalies in infants of women with diabetes involves either the cardiovascular system. That is, majority is going to be a cardiovascular followed by your central nervous system. So cardiovascular is 8.5 per under live births and central nervous system is 5.3 per under live births. And anencephaly and spina bifida occurs 13 to 20 times more frequent. And when it comes to your caudal regression syndrome, it approximately is about 200 times more frequently in infants with diabetes than in other infants. So what are the neurological abnormalities seen? So anencephaly, arenencephaly, microcephaly, holoprosencephaly, and neural tube defects. There are approximately about 150 defects can be associated with the diabetes mellitus. I have just highlighted the most common or most important conditions. When discussing with the neurological, I've divided into the conditions which have a bad prognosis as well as the one which has a good prognosis. So anencephaly, microcephaly, and holoprosencephaly, as well as the neural tube defects, open neural tube defects have a poor prognosis, whereas meningocele and arenencephaly have a good prognosis. What are these? Arenencephaly, as every obstetricians are aware of it, the development of your brain is going to be less, your brainstem is going to be good, as well as a skull vault is also not going to be developed. The picture on the right shows that arenencephaly, where it's usually associated with the midline defect. There is a defect in development of your olfactory lobe. There will be a symptoms of anosmia in the kids. Next comes your holoprosencephaly. So holoprosencephaly is a development defect of the embryonic forebrain or prosencephalon that is commonly associated with the mid-facial defects. What is lobar holoprosencephaly? It's a mild form of the disease, distinct right and left ventricle forms, but cerebral continuity across the frontal lobe is there. So you can't see the interhemispheric division in the frontal cortex. Next one is the semilobar holoprosencephaly is distinguished by a partial separation of your brain. The forebrain is completely separated from your rest of the brain. Alobar, where there's a complete failure of the forebrain to divide into right and left hemispheres. As a whole, there'll be right and left hemispheres are fused. It's a more severe form of the holoprosencephaly, presenting with the refractory seizures and microcephaly, as well as a development delay. An MAH variant, where a posterior frontal and parietal areas have midline community through the basal forebrain. The anterior lobes and the occipital regions separated. The anterior part and posterior part are separated, but the remaining parts are fused. So how they externally present? So they present with the median cleft and palate. Other one is the sebocephaly. Sebocephaly means absence or defective single nostril and a closely set ears. The nostril is going to be a single opening, and the closed eyes are going to be very, very close. Hypo, the space between the intake canthus is very less. And ethmocephaly. Ethmocephaly is characterized by a small, narrow set of ears, hypothalamism, as well as small eyes, separated by a primitive, non-functioning nasal structure. This is the nose, upwards proboscis. And cyclopia, there is a central single eye. So it's a single central orbital fossa and proboscis. The globe can be absent and develop at apparent normal. The neural defects, anomalies of neural development with a spectrum of clinical manifestations can affect the cranium or spine. The cranial defects can either be an anencephaly or encephalocele. Encephalocele is going to be a protrusion of your of your brain outside your cranium. The open spinal dystrophism is characterized by a cleft in the spinal column with the herniation of meninges, or it could be containing your spinal cord element, spinal elements as well, as where you call as a myelomeningocele, where the prognosis is going to be poor. Whereas meningocele, the prognosis is going to be good. A closed spinal dystrophism, we can't see any external structures, but there could be a defects with your vertebral bodies. There can be fusion with your vertebral bodies. Posterior vertebral arches could be fused. That can have some markers in the external skin. This is an example. This is a photo of an encephalocele. This is an open neural tube defect. So what are the markers? You can have a pit. You can see the pit here, or you can have an hemangioma, or you can have a sinus. You can see a sinus, or you can have a tuft of hair. You can have a lipoma mass. There could be hyperpigmentation in the area, or some excessive hair, hypertrichosis can be seen. These are some markers showing that, which gives us a clue that the baby can have a occult spinal dystrophism. So what is the cardiovascular abnormalities which are seen? The transposition of great vessels, which is with or without an intraventricular septum, is the most common condition seen with gestation diabetes mellitus. Seen with the diabetes mellitus, babies born with diabetes mellitus, VSD, coarctation of aorta, ASD, single ventricle, hypoplastic left ventricle, as well as double outer right ventricle. So this chart is taken from birth defects research in 2018. The same three hypotheses. One is damage to the membrane, oxidative stress, production of your reactive oxygen species, decreased nitric oxide, causing apoptosis, endothelial factors release are the mechanisms for causing your cardiac changes. As well as you have some transcription changes secondary to your decrease in your antioxidants, as well as abnormality in your cardiac development genes. Besides, epigenetic modification also contributes to it. So in the cardiovascular conditions having a good prognosis and conditions having a guarded prognosis. The prognosis which are good are transmission of great vessels. Isolated transmission of great vessels has an excellent prognosis. Just a jetin arterial switch, the baby has a good survival rate. VSD, as all of know, it's a simple procedure. Coarctation of aorta is easily correctable. Pulmonary stenosis doesn't even require a surgery, just require a follow-up. A transmission of great vessels, what happens? The aorta starts arising from this is a normal vessel. The right side pulmonary artery arises, left side your aorta arises. Here what happens is aorta starts from the right side and the pulmonary artery goes from the left side. So it just requires a switch surgery. Next is the coarctation of aorta, where you can see the constriction after the origin of the three vessels, brachiocephalic on the left side, carotid artery, and the subclavian artery. What happens? There is a constriction. This requires a surgery which can be easily correctable, and it has a good prognosis. So poor prognosis is a single hypoplastic left ventricle, HLHS. It's a spectrum of disorder where you will have the aortic arch hyplasia, mitral valve hyplasia, as well as left ventricle is hyplastic, where surgeries are available, but long-term outcome is very poor. You can start for a Fontan's procedure where SVC is drained into the pulmonary artery, then can go for a Norwood procedure. But all these things last for 5 to 6 years and ultimately lands up in a heart transplant. So heart transplant, they can live for another 10 years. So maximum survival rate is going to be 20 years. That's the reason hyplastic left ventricle, we don't encourage surgery in India. Same thing holds good for single ventricle physiology. The same procedures are done for single ventricle physiology. Next comes your truncus arteriosus. In truncus arteriosus, it's a various types where the pulmonary artery and aorta arises from a common root. You can see the aorta and pulmonary artery arises from the single ventricle, and from there it divides. Both are bloods are mixed and you get a cyanotic congenital heart disease. The various classification of truncus arteriosus, but the overall the prognosis goes very poor for your truncus arteriosus as well as a double outlet right ventricle. The caudal regression syndrome consists of a spectrum of structural defects of the caudal region, including incomplete development of the sacrum and sometimes the lumbar vertebra. Why it's more important is it is also associated with abnormalities in the neural system where you can have a neurogenic bladder later on and the limbs can't be collected. The disorders may be associated with the open or a closed type of spinal dystrophism as well as tether cord. It is not a correctable condition. ME vertebra results from failure of one of the lateral centers to develop. The defective vertebra causes a scoliosis in the kid. Some other anomalies which are seen are duodenal atricias, which just requires a corrective surgery. It's very simple procedure. Imperforate anus as well as anal-rectal atresia. These are two things: imperforate anus and anal atresia. The anal-rectal atresia can have a fistula. If there is a fistula opening in the females, it's most common. There could be a vesicovestibular fistula opening the vestibular region where it doesn't require immediate surgery. We can go for elective surgery. And in case of there's no fistula, it requires an immediate colostomy for the survival of the baby. And small left colon syndrome is a very trivial condition. It's because of the poor contractility of the colon, which correct by itself with itself. Situs inversus, there's rotation of the entire bowel as well as all the organs. Isolated situs inversus is a benign condition, not need to worry and doesn't require any treatment. Genitourinary duplication, which results in the recurrent urinary tract infections later on going for renal failure. Renal agenesis is incompatible with life. Hydronephrosis, if identified antenatally, can go for antenatal interventions. As per Pluto trial, they have seen that the antenatal interventions of hydronephrosis in utero have prolonged the duration of your survival rate, but ultimately they land up in your chronic kidney disease 2 to 2.5 years later if you're not given an antenatal intervention. So overall outcome is going to be a poor in case of a grade 4 or grade 5 hydronephrosis in a baby. So this paper deals with is a systematic review taken in done in 2017 from maternal and child health to pre-pregnancy obesity as a modifier of gestation diabetes and birth defect associations. 24 articles were included in the systematic review. There was no evidence of consistent association of gestation diabetes mellitus with birth defects, with the exception of a weak association between the GDM and congenital heart defects. So GDM, there was only a weak association between GDM and heart defects. When stratified by the maternal pre-pregnancy body mass index, an association between GDM and congenital heart defects, and when we are association between the GDM and urinary defects was evident only in women with both GDM and pre-pregnancy obesity. So association between GDM and birth defects may be due in part to the undiagnosed metabolic disorders associated with obesity, such as pre-gestation diabetes mellitus, rather than the gestation diabetes mellitus. So inference on the systematic review is that GDM isolated is not going to cause a major anomaly in a baby until otherwise the mother has an underlying metabolic issues like obesity, pre-obesity, or undiagnosed diabetes mellitus. So this is a cohort from the prevention study published in American Journal of Obstetrics and Gynaecology from a period of 1997 to 2000 level cohort. The pre-gestation diabetes was reported in 0.6% of mothers in the control group of the 11,400 control population, and 2.5% of the mothers of case infants out of the 31,000 population. The gestation diabetes during the index pregnancy was 4.7% of mothers of control infants and 5.3% of babies of case infants. So you can see, we'll just see this odds ratio alone. So more than 10 times odds ratio is more common with holoprosencephaly, it's 13.1, as well as your longitudinal limb deficiency, which is 10.1, and sacral agenesis is 80 times odds, the higher odds of developing this abnormality in case of your pre-gestation diabetes. When it comes to your cardiac anomalies, you can see heterotraxia, truncus arteriosus, atrioventricular septal defects, as well as your single ventricular complex are more than 10 times odds of developing in case of a diabetes mellitus in diabetes mother. Whereas in gestation diabetes mellitus, if the incidence of odds was 12.3 for a case with the mother with diabetes mellitus, whereas gestation, the odds is lesser, 0.3, non-significant. The confidence interval crosses the 1, so it is non-statistically significant. It's in fact lesser odds in case with the gestation diabetes mellitus. The same thing holds good in the other conditions where your odds reach more than 10, like a single ventricle complex, where in the diabetes mellitus mother, the odds was 14.7, whereas the odds is 1.1. Not much of change within the gestation diabetes mellitus. When they compare with the single defect and multiple defects, the multiple defects here also you can see heterotaxia with other anomalies, the odds ratio was 12.7. For truncus arteriosus with other anomalies is 40.8 times more in pre-gestation diabetes, as well as the odds of pulmonary atresia 65% more. There are multiple decisions along with pulmonary atresia in case of pre-gestation diabetes, where it's very lesser in case of gestation diabetes mellitus. So greater than 10-fold increase in the odds was seen in holoprosencephaly, longitudinal limb deficiency, heterotraxia, truncus arteriosus, atrioventricular septal defect, single ventricle complex in pre-gestation diabetes rather than for your gestation diabetes. For gestation diabetes, the statistically significant odds ratio was fewer conditions and of very small magnitude, between 1.3 to 2 was a thing. Whereas we get a higher odds ratio in case of your pre-gestation diabetes mellitus. This article is a different one. It's a phenome-wide association study done in genetic epidemiology, published in 2020 August. Published in 2020 August. So where they have seen a prevalence rate ratio, where they have seen the prevalence rate ratio for the individual diseases. Here we can see the triangle ones are the gestation hypertension and the round ones are pre-gestation. The x-axis represents prevalence rate ratio. The prevalence ratio 1 means no difference between the control group and the patients with the pre-gestation or your gestation diabetes mellitus. So the triangle 1 is a gestation 1 and the rounds 1 is your pre-gestation diabetes mellitus. So for example, let us see the red mark. It's a cardiovascular system where the pre-gestation is close to your 1. Not much difference in your prevalence rate ratio. Whereas in case of a pre-gestation diabetes mellitus, the prevalence rate ratio is pretty high for all your cardiac defects. Next comes your nervous system, the blue one. Let us see the blue one. Blue one is also close to your 1. Not much difference between your control group as well as your gestation diabetes mellitus. Whereas when you go to your pre-gestation, the prevalence rate ratio is pretty high with a narrow confidence interval. It almost holds good for almost all the system like musculoskeletal system, face, everything. Your pre-gestational diabetes are a higher incidence of your prevalence rate ratio when compared to your gestational diabetes mellitus. So in this study, its sample size was about 65 lakhs. With the birth defects of about 2,90,000 population. All these are Western studies from US. The diabetes was due to the prevalence of any defect with the prevalence ratio of 1.4 times. Multiple defects, the rate was 1.86 times. For 60 specific phenotypes, which is normal phenotype, which I've seen like hypospadias metastenosis, and established phenotypes like renal dysgenesis and spinal anomalies, which are associated with diabetes mellitus. Pre-gestation diabetes was a strong risk factor for any defect. The PRR was 2. Multiple defects PRR was 3.27. Gestation diabetes associated with any defect was 1.21. Very less, not very significant. So the pre-gestation diabetes associated with the broader range of phenotype than previously reported because diabetes diagnosed in 1% of women prior to pregnancy and 6 to 9% during pregnancy. So it is mostly missed. You could have missed a pre-gestation diabetes mellitus. So coming to the final quoting article, this paper deals with the prevalence of congenital malformation is still higher in pregnant women with pre-gestation diabetes despite your near normal HbA1c. That's a literature review published in 2017. 9 papers, 6,225 women, type 1 diabetes, and 2,000 odd women with type 2 diabetes included. The prevalence of congenital malformations was 6.4% in type 1 and 4.3% in women with type 2 diabetes mellitus. And for the combined group of women with pre-gestation diabetes mellitus, type 1 and type 2, the rate of risk compared to the background population was 3.2 times higher chance of your malformations. When they looked into HbA1c less than 7 in early pregnancy or HbA1c of 7 to 8, the prevalence of congenital malformations was 4.3 and 3.7, pretty high even with your values less than 7. The prevalence was 4.3%, even if HbA1c 11 was less than 7. And the relative risk was 2.2 in groups less than 7, HbA1c less than 2.2 in HbA1c less than 7, and 1.9 in the HbA1c is between 7 to 8. So the conclusions paper is that in pregnant women with the pre-gestation diabetes mellitus, the prevalence of congenital malformations was 3 times higher in women with pre-gestation diabetes compared to the background population. However, HbA1c below 7 in early pregnancy was also associated with the 2 times increased risk of congenital malformation compared to your background population. So any value less than 7 was also associated with your higher incidence of your congenital malformations. Thank you.
Thank you, Dr. Prakash. Fantastic talk covering all the anomalies. Only one thing I want to ask you, Dr. Prakash. Now you have put many evidences and journals. And what is your opinion with the anomalies may be delivered at your institute, IOG? I think now there is the anomalous incidence is very much decreased. Do you accept this?
Ma'am, basically our group is a elite population, ma'am. We have most of the referral events. So what happens is we can't just exactly extrapolate our data of IOG to a general population because most of the cardiac anomalies are referred to us, ma'am. If it's a structural cardiac anomaly, for example, hypoplastic left heart syndrome or diaphragmatic hernia, they are just sent to IOG. So our data can't be said because being a tertiary institute, we can't just say the prevalence of our of the anomalies based upon only our data, ma'am.
No. What I want to tell, because of the universal screening everywhere, nowadays the anomalous incidences, as far as concerned practically, it is reduced. That is the point I want to.
Thing is, based on our institute, we can't say. For example, when you say the last paper, this paper was published from India. There is a review article published in 2017. There is a review article, systematic review, saying the prevalence of your anomalies in India. They have shown that last 10 years, the prevalence of your anomalies varies between 1.5 to 2. Not much of change.
Madam Sampathkumari, madam, definitely the incidence is coming down compared to previously because of the increased awareness and improved management.
Yes, that is the point I want to tell. Because of the screening, what Dr. Fadi
Improved
said,
antenatal care in general.
Only one point. Generally, it is reduced, and the transmission in utero, I think it is also completely reduced. Only thing now we have to focus, as far as I am saying, I retired from IOG only the last 10 months back. Now this mainly we have to focus on adolescent. Only during the reproductive period, we are talking about juvenile and reproductive periods. We have to focus on the community programs with the colleges. And next year, I think this association during our Seshaya's doctor's birthday, we should have a competition, posters for all colleges. That it can be done only through the government. That has to be done. Then only we can reduce the pre-GDM, GDM and everything. Thank you, sir.
I have one question, madam, to Dr. Binay. Dr. Prakasham, I want to ask you that I was a little depressed to see that in the pre-gestational diabetes, even though HbA1c is below 7 or around 7, the congenital malformation is 2 times. I just wanted to know what would you suggest, like mothers receiving high-dose pregnancy, high-dose aspirin, etc. We have some action plan. So if somebody is pre-GDM and the HbA1c is 7.5 or something, what would you suggest as the action plan? To 2 times or 3 times congenital malformation, it may not be acceptable, no? Professor Prakash?
Not professor, sir. I'm assistant professor, first and foremost.
Okay.
So the highlight of this paper is that we are after diagnosed before pregnancy itself. Because once a mother is diagnosed pregnancy, the damage has already happened. That's the inference of the paper. The thing is, before we diagnose them to be having a diabetes, all the damage which has happened.
Okay. Okay, I get your point.
The highlight of the paper is that before they plan for a pregnancy, they has to be identified, treated, sugar has to be brought under control. That is the basic of the paper, saying that the 3 months prior to your LMP, the sugar levels has to be monitored. That is the impact of the paper.
Absolutely. And that's also the motto of the early pregnancy screening for the not wait 28 weeks, first trimester, every trimester screening, at the point of first contact screening. The second question, I'm sorry, madam, for taking time, but very important, is the rubella vaccine and the other programs of vaccination is as effective in the diabetic, pre-gestational diabetic mother or just GDM mothers as in normal pregnancy, sir, Binay? The vaccination preventing the congenital anomalies in the normal mothers to service the pre-gestational DM or GDM. Preventing the complications, the role of vaccination.
Rubella, definitely, sir. I'm at IOG for the past 14 years. So we used to get umpty number of rubella patients. For example, per year, we get around 6 to 7 rubella patients per year. Hardly we get any rubella patients. We have not seen in the past 4-5 years, we have not seen any rubella babies.
I got my answer. Thank you.
Last question from Dr. Sundaram. Last, please.
Dr. Prakash, I really appreciate you for quoting your professors and paying namaskarams to them. That is the first beginning you have made. What as diabetologists we are interested is the development of pancreas is between 9 to 11th weeks of intrauterine gestation. So you cannot be blamed for that, but all the problem starts only in that period. So a correlation between you and the obstetrician might help us, the diabetologist or the obstetrician, to plan for future. You have quoted all the anomalies we have understood. But one thing, double ureter on one side, and the other side also ureter is present. That means 3 ureter. So double ureter is a forerunner of future diabetes. I have seen 2 cases in my life. Then your department statistics, I request you to project every time. Whenever you see, after birth only fetus or infant are referred to you. Before that, if there is a correlation between obstetrician and you, I think your study will expand. That's what we spoke to the first man, Professor Gopal, about it. But because of workload, they are unable to do that. If we want to do even anything above normal is abnormal, as far as diabetologists are concerned with blood sugar. It is not 7 HbA1c, it should be below. That's why we never concentrate on pre-gestational diabetes. But of course, we will have to reduce it to 6. Then only we will be able to prevent other complications. So before, as Madam said, we'll have to follow that. But please concentrate statistics. How many pre-gestational diabetes, how many diabetes or gestational diabetes women delivered in OG or referred to your department or have an interaction with them, and give a good paper next time to us. I wish you all the best, doctor.
Thanks, sir.
Don't worry, sir. I'll take Prakash into task. Don't worry. He is under me
It is
only.
not task, madam. We always require cooperation.
No. All the babies are going for immunization. So I have to catch the postpartum GDM mothers through him only. So that is my plan, sir. Yes, sir.
Only one point. See, as Prakash sir was not having, because of the workload, as Dr. Sundaram told, we don't have the evidence to tell whatever is happening. That is the question in the chat box. Dr. Sunita Sarmal has asked that if they are going to publish in the article, they are asking for the fasting blood sugar. Because one of our professor used to tell, whoever is working will not put articles. Whoever is putting article, it is understood. So we have to create our Indian standard journals and we should publish. Then only others will follow those. That is the answer for Dr. Sunita, I think. Thank you.
Thank you, madam. Thank you, sir.
I think thank you. We'll end this session with that. Over to Pushpa.
Thank you, sir. Anand, sir. We'll move on to the next session. I call upon Dr. Periyandavar, the Associated Professor, Institute of Diabetology, Madras Medical College, and he is the consultant diabetologist at various hospitals since 92. He is the organizing secretary for National Diabetology Conference, DICON 2011, and treasurer DICON 2013, chairman Board of Studies for MBBS, and also member Ethics Committee, Tamil Nadu MGR University. Above all, he is the silent person behind all the success of Department of Diabetology, wherever it is. And next coming, our young, energetic, active Dr. A. Shanmugam, who is the Associate Professor, Institute of Diabetology, Government Stanley Medical College, Consultant Diabetologist, Sindhu Diabetes Specialty Center, and he has received fellowship from American College of Endocrinology and more than 10 years of teaching experience in the field of diabetes. And also he also published several papers, and academically, sir is very strong. Over to you, both of you, to take the next session.
Thank you very much, madam, for your nice introduction. And I am very much pleased to be the chairperson for this next session. And most respected, our guru, mentor, Professor Sheshaya sir, our respected senior professors, and my dear senior and junior colleagues, dear co-chair, Dr. Shanmugam, it's my pleasure in chairing this session of free paper presentation. And the first paper will be presented by Dr. A. Geeta Lakshmi. She has graduated from Madras Medical College. She is Senior Assistant Professor, Government Kasturba Gandhi Hospital and Madras Medical College. And she has 20 years of experience for UG and PG students, and Executive Committee member of OXI. She has been trained in laparoscopy and colposcopy. She has presented many papers in various national and international conferences. She is involved in adolescent health awareness in schools and colleges. And Dr. Geeta Lakshmi will be talking about gestational glucose intolerance, her original work. I welcome Dr. Geeta Lakshmi.
Thank you, sir, for the kind words, and I'll share my presentation, sir. A very good afternoon to Professor Dr. Seshaya, to all the faculty and the delegates present here. I guess all my good deeds are bearing fruits, giving me the opportunity to present in this renowned forum presided by the legends in the field of diabetology and obstetrics and gynecology. It is even more enlightening as I'm asked to present a paper on the urgently gaining new attention, the topic gestational glucose intolerance. As you all know, that diabetes is a major public health problem in India, with the prevalence rates reported to be between 4.6% and 14%. Not surprisingly, in parallel with the increase in diabetes prevalence, there seems to be an increasing prevalence of gestational diabetes, that is diabetes diagnosed during pregnancy. It is estimated that about 4 million women are affected by GDM in India at any given time point. Impaired fasting glucose was seen in 14.5% and impaired glucose tolerance in 4.8%, and 8% had both IFG and IGT, and 6.4% had overt type 2 diabetes. So as you all know, diabetes is a disease continuum ranging from gestational glucose intolerance to GDM to overt diabetes. However, the apple of our eye today is gestational glucose intolerance, defined according to DIPSI as a 2-hour plasma glucose between 6.7 millimoles per liter to 7.8 millimoles per liter. So the study was on the analysis of the perinatal and maternal outcomes in antenatal women who had 2-hour plasma glucose between 6.7 millimoles per liter and 7.8 millimoles per liter with a 75-gram OGCT following the DIPSI procedure. GDM is defined as a carbohydrate intolerance of variable severity with its onset of first recognition during pregnancy. In most of the cases, the carbohydrate intolerance will revert to normal by the end of puerperium. GDM is an important public health issue because of future sequelae for both the mother and the neonate. Since South Asian ethnicity is at a high risk of diabetes, all pregnant women should ideally undergo screening at the first visit, 24 to 28 weeks, and between 32 to 34 weeks of gestation. As you all know that the DIPSI procedure, everybody since morning were quoting that is a single test procedure, simple and feasible, and GDM is diagnosed if the 2-hour plasma glucose is more than or equal to 7.8 millimoles with a 75 grams of oral glucose given to a pregnant woman in the fasting or the non-fasting state, irrespective of the last meal timing. And it has been recommended by the Ministry of Health and Family Welfare, Government of India, as approved by WHO, FIGO, and the International Diabetic Federation. The objective of the study is that to study the maternal and fetal outcome in women with gestational impaired glucose intolerance by DIPSI criteria. The outcomes studied include polyhydramnios, which is defined as amniotic fluid index more than or equal to 25, macrosomia defined as birth weight of more than or equal to 3.5 kg. The inclusion criteria was that all women who have done a 75-gram OGCT by DIPSI procedure in all the 3 trimesters were included. The exclusion criteria: women with overt diabetes, previous history of renal disease, hypertension, heart disease, bleeding disorders, and multiple gestation. The methodology included that it was a retrospective cohort study. The study period was for 1 year, from December 2018 to November 2019, And the place of the study was Institute of Social Obstetrics and Government Kasturba Gandhi Hospital. The study population were all antenatal women with a 2-hour 75 grams of oral glucose test by DIPSI procedure in all the 3 trimesters. The study population was divided on 3 cohorts based on the glucose values as 6.7 millimoles per liter as group 1, 6.7 to 7.8 millimole per liter as group 2, and 7.8 millimole, that is equal to or more than that, as group 3. The 3 cohorts were matched for age, parity, and pre-pregnancy. The results of the study was that a total number of 1,902 antenatal women were followed up in all the 3 trimesters, and their outcomes were analyzed. And among the group 2, which I mentioned as 6.7 to 7.8, 604 antenatal women, and the group 1, that is less than 6.7, the total number of women were 1,098 in group 1, were compared for the incidence of polyhydramnios and macrosomia, and the above both group were compared with the third group, that is more than or equal to 7.8, and they were 200 in number, who were on treatment with medical nutrition therapy and or drug interventions, and the outcomes were compared. So these are the results of the studies. So the study, in this study, you see the highlight of group 2, 6.7 to 7.8, where you see the incidence of polyhydramnios is 28% in group 2 as compared to 31.8% in group 1. And you see in macrosomia, it is again increased from 6%, where you see in group 1, it is 1.8 and 5%. And polyhydramnios, 28% as compared to 13.6 to 17.5. So it is increased in group 2. So this is the graphical representation of the result, which I have put here. This is the incidence of polyhydramnios, and this is the incidence of macrosomia. So the interpretation of the study is that the incidence of polyhydramnios and macrosomia was found to be significantly higher in group 2 when compared with both group 1 and group 3. The outcome data showed that perinatal and maternal adverse outcomes are high in group 2 when compared to 1 and 3, and the p-values were statistically significant. Neonates born to group 2 mothers had a birth weight of more than 3.5 kg, since the category is not considered as abnormal at present and it is not being treated. Birth weight is given importance in the study because it is strongly associated with mortality risk during the first year, developmental problems in childhood, and the risks of various diseases in adulthood. So to conclude, the adverse perinatal outcome and maternal outcome occurs not only in group 3, GDM group 3, where this group is being treated, but also in group 2, that is, which falls between 6.7 to 7.8 women, and the incidence is more in group 2 than group 3, because you see in group 3, they are being treated either by medical nutrition therapy or by OHA or by insulin. Antenatal counseling, early testing, and initiating the intensive management of hyperglycemia will significantly decrease the risk of polyhydramnios and macrosomia. Early detection of glucose intolerance during pregnancy and the care given results in a good fetal outcome similar to that of a non-diabetic pregnancy. This study establishes a single test diagnostic procedure of DIPSI with 75 grams of oral glucose value between 6.7 to 7.8 millimoles per liter in any of the 3 trimesters had adverse outcome. Hence, it is necessary to start a medical nutrition and a drug therapy if necessary to achieve target values of fasting should be less than 5 millimoles per liter and a 2-hour plasma glucose value of less than 6.7 millimoles per liter, and to follow up these persons to avoid maternal and perinatal adverse outcome. It is probably time to think classifying the glucose intolerance in pregnancy as GDM 2R plasma glucose equal to or more than 7.8, gestational glucose intolerance 2R plasma glucose between 6.7 and 7.8 millimole, and the normal glucose tolerance for a 2R plasma glucose should be less than 6.7 millimole in pregnancy. So now it is absolutely essential to recognize the gestational glucose intolerance as a separate entity and to initiate the treatment early to reduce the maternal and perinatal morbidity. So these are my references. And I'm really proud, and I feel, and I extend my sincere thanks to Professor Dr. Seshaya for guiding me, and to Professor Dr. Anjalakshmi Madam also in helping us. And they published it in the journal, World Journal of Advanced Healthcare Research. And I am really proud to share at this juncture in front of the august audience. Thank you so much to the organizers for giving me the opportunity to be here and to highlight on the gestational glucose intolerance. Thank you so much.
Thank you, madam. Thank you for the wonderful research topic you have presented. It is really interesting to see that this glucose, the gestational glucose intolerance, has to be addressed with lifestyle modification as early as possible. And this is a retrospective study. We are also going for a prospective study, the same group of looking into glucose intolerance in RSRM hospital, along with Professor Anandi from Stanley Medical College Institute of Diabetology. We are also doing the same study. We will get the results within another 3 or 4 months. We can able to conceal with the prospective data what is going to happen in glucose, gestational glucose intolerance group. I really appreciate your study, and really interesting to see that these people have to be addressed as early as our Professor Sesha used to say, that it is a specific entity. Glucose, gestational glucose intolerance is a specific entity than GDM. They have to be addressed. Usually, most of the time, when they say that people blood sugar of post 75 grams of glucose less than 140, they just ignore. Don't hereafter. The people should not ignore. We should concentrate on this group also to avoid perinatal and maternal complications. Thank you, madam. Thank you for the wonderful topic. And next,
Dr. Shanmugam.
Yes, sir.
We request a comment from Dr. Sundaram, sir. Sir, Professor Sundaram, sir.
I'm very happy to listen to this madam's lecture.
Yes, sir. Sir, you remember, sir, you taught us single abnormality of glucose tolerance.
Yes, that's days. What I'm going to talk.
Yeah, we have found out a lot of this polyhydramnios and this fetal wastage in the first trimester. We have seen it with the single abnormality in glucose tolerance, sir.
Madam, Madam Presenter, I was posted first to Kasturiba Gandhi Hospital as assistant surgeon and tutor in diabetology, Madras Medical College. At that time, Kantamani and Madam Ramani were there.
Okay, sir.
Okay, thank you. You have come from the same institute.
Yes,
and
sir.
This is what we wanted. It has come from, it is like coming from the horse's mouth. So you've done the work. You should be proud of it. Carry on your work. And it is very well presented. And it has been guided by our professor and Professor Anjalakshi. I think you should do more work on this and involve your pediatrician and try to do neonatal work. What we are concerned is you should have presented one more suggestion.
Yes, sir.
Fetal wastage and miscarriages are very common in people with glucose intolerance. Okay, that is there in the yellow book. Professor Seshia might give it to you. And yes, single abnormalities, we have found that with the GTT, whatever we were doing fasting half an hour, 1 hour, 2 hours, and 3 hour GTTs also we have done. And we have found even if there is one glucose abnormality above normal is associated with a fetal outcome, which is a morbidity or mortality to the mother as well as to the fetus. I think there also you should concentrate. Not only birth weight, the cesarean sections that you have undertaken in this term. If the control is very good, they do not go in for otherwise. unless obstetrically you have indications, that also comes down. So thanks for presenting from my institute. Thank you.
Thank you, sir. Probably
one
I'll
more,
take
one more thanks to Dr. Geeta Lakshmi. And many people will have doubt why this group, more number of polyhydramnias, more number of this macrosemia. You have nicely explained. That's because of that already established GDM group. They have been treated with either diet or tablets or insulin like that. So only the incidence is coming down. So many people will have doubt. So you have nicely explained. Congrats, madam.
Thank you.
Dr.
Thank you.
Shanmugam.
Thank you so much,
Congratulations.
sir.
Congratulations, madam.
Thank you for the opportunity, sir.
Congratulations, man. And next we have to go for the next speaker of today's. We're not a new person. It's a well-known professor, Dr. Bavadarani Madam. She was a honorary professor of diabetology in state IME. She's a state coordinator for diabetes and IME course. She's a faculty of diabetes training program in DPH in Tamil Nadu side. She received a best teacher award in state IME. She's a World Diabetes Federation regional coordinator for gestation diabetes. She is a faculty in Dr. MGR Medical University. She has written many chapters in diabetes. She is a well-known speaker in all over India. She is an international. She published international papers too, and she is a known figure, particularly in diabetes forum and in gestational diabetes forum too. Over to you, madam.
Please let
Madam, you
me
can share. You can share, madam.
You can share your slides, madam.
Thank you. Respected Professor Dr.
Sir.
Seshwar, Godfather and the living legend, Pidamagar Bhishmar, and respected chairpersons and my school colleagues. Today I'm going to talk about the difficulties what we have even in doing this single test procedure in non-metro areas. You know, heard about all these congenital anomalies, recurrent hypoglycemia, IUGR, big babies, and hydramnias during pregnancy, hypertension, obesity, heart attack, all these. For all this, we know very well today you would have come to a conclusion that GDM is the mother of all these communicable diseases. And if we catch this GDM as early as possible, it's like hitting two mangoes in a single shot that we can prevent diabetes, not only diabetes, but the non-communicable diseases, both in the mother as well as the offspring. We know that in the low and middle income countries, according to IDF, 85% of the annual global deliveries and 80% of the global diabetes burden and 90% of all cases of maternal and perinatal deaths and poor pregnancy outcomes. So let us step down from ivory towers to ground reality. That's what our professor wants. We need something very easy which can be applied to the majority of population, not about the one who are living in the cities. If anybody takes pains to go and see what is really happening in the non-metro areas, there is inadequacy from A to Z. In a recent survey done in about 10 non-metro government hospitals in my place, there's more than 90% of the pregnant women are not able to come in fasting. All these places I have surveyed and seen about 5,000 cases, out of which only 369 came in fasting. When we inquired why they have come in fasting, they were asked to come in fasting for some reasons. Otherwise, they don't come in fasting. In our place or anywhere, the ANC OP is only on Tuesdays every week, and there's an overwhelming crowd with limited facilities. See the crowd over here. If you want to do the regular GTT, either 2 hour or 3 hour, whatever you see, you need 3-4 samples. There's not adequate strips, reagents, syringes, lab technicians, paramedics. Even drinking water is not available. There's a scarcity of electricity. Drinking water is donated somebody, and every PHC has to see at least 100 to 150 cases on this antenatal day. And the PHC is usually open by 8 for a regular GTT in fasting. Even if it takes just 5 minutes for each case, for about 50 cases, it takes more than 2 hours minimum, by which time few cases would have reached or passed their 1 hour and few even the 2 hours after the glucose flow. And they have to undergo the other tests also. It is not only the blood sugar which they have to see, they have so many other investigations to be done. So if both the medical officer and others can finish their routine in a single visit, it will be easy for all the patients, staffs, attenders, medical officers, and to the nation as such. The second visit becomes unnecessary. And the proportion of obstetricians to the patients is very low, and there's no medical officer at all in some PHCs, and they are deputed from elsewhere. And in Tamil Nadu government, they give about 18,000 rupees to all antenatal cases. So even the affordable class come only to the government hospitals to get this free money. Naturally, the crowd gets built up. And if you take in the villages, she's not a thing, she's free. She has to finish all the routine work to take care of her house members, non-house members like goats, cows, hens, dogs, etc. And all these takes extra time. For such a long time, the pregnant ladies cannot withstand fasting. And they are in the interior of the villages where there is no transport facilities. They have to walk for at least 1 to 2 kilometers to reach the main road for the bus stop and from their house. Sorry. So the walking for 30 minutes to reach the stop and traveling in the bus for another 20 to 30 minutes to reach the PHC and get that token takes almost 1 to 2 hours. And bus facility and frequency is available only at particular time of the day, and also the government hospital is not open round the clock to see these patients. So all the patients gather in the same time, that is in the morning, so it is crowded too much at the PHCs. After this, to see the medical officers, it takes another 1 hour. So without GTT itself, for a normal visit, it takes roughly 3 to 4 hours. He has to do their other investigation also. All these are very difficult in the fasting state for a pregnant female. They may easily faint. So elders in the house, they don't allow them without eating something in the morning. They strongly believe that pregnant women should not fast. And the pregnant ladies are not allowed to go alone. They are also daily wages. They are accompanied by another wager. So 2 earning is gone when they come for the visit. For a single visit, 2 earning is gone. If she is asked to come again because she is not in fasting, she may not turn out, or there are dropouts, more of dropouts. In these dropouts, if they happen to be GDM, the delay can increase the fetal mortality and morbidity further. See this lady, she is working on May 1st, the laborers' day. It happened to be on Sunday. Even on that day, she is working because she is the breadwinner of the family. The whole family will be deprived of food if she is not working. So again, other thing is in pregnancy, the fasting is always low because of the high insulin sensitivity. Muscle takes up more glucose. The neoglucogenesis comes down, and there is less static glucose output. So fasting is always low. Remember, if somebody is going and doing, at least see for 100 cases, if you really go to the field and see the fasting, it's below 80 in majority, more than 95% of the cases. So you cannot rely on fasting. Fasting will not help in diagnosing GDM. The pregnant ladies are more prone to ketosis because of the accelerated starvation. And you know that fetus is a continuously eating parasite in an intermittently eating host. She has to eat for 2. She feels more hungry and early also. And the pregnant ladies, they have hyperemesis also. The hyperosmolarity of the GTT solution frequently leads to GI intolerance with nausea and vomiting. And if they come in fasting, all the efforts to do the test in fasting goes to waste. So the pregnant refuse to undergo the GTT in fasting, and they tolerate glucose better in a non-fasting state, since vomiting is low and they can tolerate the solution also well. And we know that the deliveries have increased on one hand, and GDM is also on the rise. You heard from all the previous speakers that GTT, IGT, everything is increasing. And because of the sedentary lifestyle, PCOS, ethnicity, strong family history, overeating, late marriage, late child, and early age of occurrence of the diabetes, now we are coming across more pre-GDM than when we started our practice 30 years before, where we had more of GDM. Now the pre-GDM is more, so it is definitely very important to screen the ladies in their first visit. If you miss, you will not be able to diagnose late. And we have to focus on the pregnant mother. This will prevent diabetes in both the mother and child by a single shot. For this, early diagnosis with simple screening is very much needed. And everybody in the PHC or GH are overburdened, and they always want and welcome whichever is easier, simple, and at the same time it should be useful for the community and prevent the mortality and morbidity. And we know that Indians are 11 times more prone to diabetes than Caucasians, genetic predisposition and other causes. It necessitates universal screening. Don't wait for BOH to happen, then go for screening. You need to screen all pregnant women. This is Tamil Nadu model. And what is the solution for all these problems? It's very simple. All these problems can make the pregnant ladies unable to come in fasting. Our DIPSI, the single step procedure, solves these problems, that saying that this glucose challenge test can be done either in the fasting or non-fasting state. You would have heard about the advantages from my previous speakers that the pregnant lady need not be in fasting. Non-fasting simplifies the procedure and causes least disturbances in the pregnant woman's routine activities and serves both a screening and diagnostic procedure. And of course, this fulfills the expectations of TIGO, IDF, and WHO, what it says in lower socio-economic countries like us to do something in pregnant women, whatever they can, depending on the resources available, and to screen every pregnant woman for glucose abnormality at the earliest for diabetes-free generation in future. And DIPSI was started with a motive to prevent diabetes in the community, and it is for our Indian problems. It has been made as a single step procedure by catching early as possible as many GDMs with a simple screening test in a single shot. And if we analyze the medical officers, paramedical staffs, and the public by analyzing the thing, we did a survey and put 3 questions, leading questions, that whom to screen for GDM, when to screen for GDM, and how to screen for GDM. They were all very much confused, and doctors even said it's very difficult to convince the patient to come for 2 days and to take 4 samples, and the facilities are not available for such a long procedure, and they need to wait for a long time, and also they cannot wait in fasting for such a long time. In contrast, after imprinting this simple DIPSI single step procedure, they are very much satisfied. This is called as I said, Tamil Nadu model throughout India, and this has been accepted by the government of India also, and is in the national guidelines, WHO, PIGO, and IDF. And the response is very good because of its simplicity, validity, and we can screen a large number of patients. And also, this is very much applicable in the major population, that is in the rural areas. Women being the ambassador of the whole family, the awareness about diabetes also increases. You all know that women are appreciated only during 2 times, that is during attaining menarche and also during childbirth, pregnancy, where they are fed more and more. Not only the ladies, the whole family eats. Once you just do this test itself, they are aware there is an entity called blood sugar and they should not take more. All this happens and the whole family is protected from getting diabetes. This we have evaluated from traveling to various PHCs, district headquarters, hospitals, and government medical colleges. Along with the increased training and follow-up, our aim is also coming through by reducing the bad outcomes, what all you had so far, by doing this simple test as early as possible. And also we can prevent the congenital anomalies, macrosomia, preterm, PIH, IUCR. And now when you see the babies, they are unadjustable and hyperactive. This is also a form of cerebral palsy, not only dumb dolls, although this is a feature of behavioral abnormality which comes because of the undiagnosed diabetes. Most complicated problems in this universe have a simple solution by Albert Einstein. This professor always used to quote, and he says, we have a simple solution for all this, that is a single test with 75 grams of glucose in fasting or non-fasting state, and single value to diagnose, that is 2 hours more than or equal to 140, and for follow-up, just a single target, fasting less than 90 and 2 hours less than 120. The dream of DIPSI is to break diabetes, begetting diabetes. But remember, do it as early as possible. Otherwise, the fetal handling will come into field, and once the blood sugar at any time of the day, if it crosses 110, which is the threshold for fetus, it will have problems of secreting more and more insulin. And when you screen beyond first trimester, the mother's blood sugar will be normal, but the fetus will have all the problems. This we are coming across very commonly in the practice. Please do screen as early as possible, or else later you will land up in fetal handling, but getting all the problems in spite of the mother's blood sugar being normal. Then I want to say that Psalm of Life, lives of great men all remind us we can make our lives sublime, and departing leave behind us footprints on the sands of time. Pranams to our godfather, Professor Seshia. Thank you. Thank you.
Excellent, madam. Congratulations to you for your nice work, and you have your studies have confirmed our Professor Seshia's experience, his papers, previous papers, and his vision, everything. And the real problem which you are facing in the rural areas. We are living in metro areas, so whenever we advise GTT, they will come for next day. They have all vehicles, transport everywhere. So in the real problem comes in rural areas. You have nicely covered, and congratulations to you, madam. Sir, yes, sir.
Dr. Sundaram, only one sentence, madam. We are all touching the diagnostic criteria, non-diabetic criteria. Okay. I would like to ask you to include in the simple test procedure between 120 to below 113, 140. Should be called as impaired gestational glucose tolerance. They should also be followed, particularly if the woman is more than 25 years, BMI more than 25, family history of diabetes, or previous fetal wastage. So please include that also. Then we will not miss a single case. Thank you. Good luck. Nice presentation.
Thank you, sir. Sir, thank you very much, sir. So let us go to the next topic. The next paper will be Association of PAPPA with Development of GDM, a prospective observational study. This presentation will be done by Dr. Kartika Prabhu. Dr. Kartika Prabhu she got MD OG from JIPMER. She is now currently a professor, SRM Medical College Hospital and Research Center, Potheri. She has got special interest in high-risk pregnancy, GDM, gynec endoscopy, and she has got many awards, many medals. Dr. A.V. Umachikui Memorial Gold Medal, Asha Baxi Award in the RCOG, and prize in paper presentation UA Foxy South Zone, and Gold Medal Research Day SRM 2020, AL Mudaliar Traveling Fellowship. So many other credits goes to Dr. Kartika Prabhu. Over to Dr. Kartika Prabhu.
Thank you, sir, for your kind introduction.
You can share your screen, madam.
Yes, sir. First of all, I would like to thank all the organizers, Dr. Anjalakshmi Madam and Dr. Paneerselvam sir, for giving me an opportunity to present in this forum. I'm going to present my study, Association of PAPPA with Development of Gestational Diabetes Mellitus, a prospective observational study. So as we all know, first trimester biochemical markers, PAPPA, along with free beta HCG, is used to assess the risk of Down syndrome. But reduced levels of pregnancy-associated plasma protein A has been associated with increased risk of stillbirth, intrauterine growth restriction, preterm birth, preeclampsia in chromosomally normal fetuses.
Kartika, please put on slideshow.
You can double click, madam. In that slide 3, you can double click.
Near to that 72, left hand side, ma'am. That icon.
Double click.
Ma'am, and that comments is there, no, ma'am? Comments?
Right side bottom.
right side bottom. Down.
Yes, sir.
Down.
Little bit.
Right side. You can go right side.
After that, ma'am. 1, 2, 3, 4. Fourth one. That.
Next to yours, fourth. Yes,
Yes, ma'am.
Yes.
Yeah.
I'm going to present my study, Association of APA with Development of Gestational Diabetes Mellitus as Prospective Observational Study. So as I told you, first I was initially used for screening for Down syndrome, but reduced level has been associated with other obstetric adverse outcomes like stillbirth, IUGA, preterm birth, and preeclampsia. So what is PAPA? It is a large glycoprotein which is produced by the syncytial trophoblast. It is a zinc-binding matrix metalloproteinase which cleaves insulin growth factor binding protein and thereby releases bioactive insulin growth factor close to the receptor. So this bioactive insulin growth factor enhances cell proliferation, it decreases apoptosis, it increases glucose uptake and facilitates trophoblastic invasion. So the insulin-like growth factor system plays an important role in placental growth and development. Low concentration of PAPA in blood in first trimester of pregnancy has been correlated with placental dysfunction. The pathophysiology of GDM still under investigation. Recently, inflammation and increased oxidative stress has been considered to play a main role in pathophysiology. So placental diabetic pregnancies have various histological findings like villus immaturity, villus fibrinonecrosis, and chorangioses. Reduced number and diameter of villus capillaries can lead to reduced pregnancy-associated plasma protein A. This reduced pregnancy-associated plasma protein A in turn may cause decrease in insulin growth factor, and this lower levels of insulin-like growth factor may lead to increased insulin level, abnormal glucose clearance, and thereby insulin resistance is increased. Thus, PAPA plays a main role in placental development and carbohydrate homeostasis. PAPA is affected by a variety of maternal and pregnancy factors like age, weight, ethnicity, smoking status, and conception methods. So it is usually expressed in terms of multiples of median. So the objective of my study is to determine the association between first trimester maternal serum PAPA levels and the development of GDM, and to determine whether the first trimester PAPA levels differ depending on time of GDM diagnosis, and to determine whether first trimester PAPA values differ between those on medical nutrition therapy and those requiring insulin. So this is a prospective observational study. It's still an ongoing study. So pregnant women with singleton fetus between 11 and 13 plus 6 weeks of gestation are included. Pregnant women with chromosomal abnormalities, pre-gestational diabetes, multiple pregnancy, chronic hypertension, renal disorders, autoimmune disorders, and who develop hypertension or IUGR during the present pregnancy are also excluded. At the time of inclusion, maternal age, parity, previous history of GDM, family history of diabetes, BMI are noted. The maternal serum marker, PAPA, is measured in terms of multiples of median. GDM is diagnosed as per DIPSI guideline. 75 gram GCT is done at the first visit. If found negative, it is repeated at 24 to 28 weeks and then again at 32 to 34 weeks. PAPA MOM values were compared between women with GDM and non-GDM. And PAPA MOM was also compared in women who developed GDM before 28 weeks and after 28 weeks. It is also compared between women who required medical nutrition therapy alone and those requiring pharmacotherapy. So the marker levels were compared using students unpaired t-test. Mann-Whitney U-test was used for analyzing continuous data and chi-square test for categorical data. The relationship was analyzed using Pearson's correlation. The total number of cases screened during the study period was 142, of which 44 were GDM and 98 were control. Among GDM, 26 were diagnosed before 28 weeks and 18 was diagnosed after 28 weeks. And 27 patients required medical nutrition therapy alone and 17 required pharmacotherapy. So on comparing, there was no significant difference in age, parity, and BMI between the two groups. Family history of diabetes and previous history of GDM was significantly more in GDM when compared to control. So on comparing PAPA values between GDM and normal, in GDM patients, the PAPA level was 1.09 MOM compared to 1.37 MOM in control, which was found to be statistically significant. So there was a negative correlation between the PAPA values and the OGTT, the oral glucose challenge test, which was again found to be statistically significant. PAPA less than 0.5 MOM is considered as low PAPA. So in GDM patients, 18.18% had low PAPA when compared to 2% in the control group. This was found to be statistically significant. So on comparing the PAPA values between GDM diagnosed less than 28 weeks and after 28 weeks, patients diagnosed before 28 weeks, the PAPA was 0.9 when compared to 1.17 in the control group, but this was not found to be statistically significant. Low PAPA, that is less than 0.5 MOM, was present in 30.7% in patients diagnosed before 28 weeks, in contrast to 5.5% diagnosed after 28 weeks, and this was again found to be statistically significant. So PAPA value was significantly low in patients who required pharmacotherapy, that is insulin, 0.8 MOM when compared to 1.13 MOM in those requiring medical nutrition therapy. This was found to be statistically significant. Again, low PAPA was significantly more in patients requiring pharmacotherapy when compared to those on medical nutrition therapy. So on logistic regression analysis, PAPA was found to be a risk factor for low PAPA was found to be a risk factor for development of GDM. So various studies have shown that serum PAPA levels decreased by 5.1 to 30.8% among patients who eventually developed a GDM. In our study, the PAPA level was decreased by 20% in the GDM group. So in comparing with the other studies, most of the studies have shown that the PAPA value was around 0.7 to 0.9 in the GDM group. In our study, the PAPA value was 1.09 MOM. Results from meta-analysis have also shown that first trimester PAPA levels were significantly lower in women who developed GDM compared to women who remain normoglycemic. Studies have also shown that the reduction in PAPA proportional severity of maternal hyperglycemia. In a study by Wells et al., PAPA MOM was 41.3% lower in type 2 diabetes when compared to 22.6% in early GDM and 8.6% in late GDM. In our study also, PAPA level was less in early onset GDM and compared to late onset, but this was not significant. Lovati et al. Has shown that patients who require insulin therapy, they have a significantly low PAPA, and this was again confirmed by our study. So Zio et al. Has shown that older maternal age, higher pre-pregnancy DMI, in vitro fertilization, alpha thalassemia triad, and low serum PAPA level were independent risk factors for GDM development. In our study too, low PAPA is found to be an independent risk factor. To conclude, women diagnosed with GDM, they have low level of PAPA than women who remain normoglycemic. So this biomarker can help serve as an indicator for the presence of abnormal glucose metabolism at the start of pregnancy. So it can help in identification of women who are at risk for developing GDM later. So in those patients, lifestyle interventions like increased physical activity and diet modification may be effective in lessening the severity, delaying or preventing the onset of GDM, and thereby improving the maternal and fetal outcome. These are my references. Thank you.
Thank you, madam. Thank you for the wonderful study. One of the biomarkers of gestational diabetes with the Indian data, particularly with PAPA. We congratulate you for the wonderful study and congratulate the entire team involved in this study. And any questions?
Thank you, sir. So far, no study is there in Indian setup, sir.
Yes, that's what I said. Very good. The first Indian study in PAPA markers.
So we have to professionally congratulate them.
Yes.
Can I ask her?
Yes, sir. Yes, sir. Professor.
Doctor, congratulations for the work, an excellent work. What is the cost of this test? How early it could be detected before the...
Sir, actually, it is cost around 1,500. Actually, okay. No way we are doing this first trimester screening for down screening for everybody. It's recommended to do this down screening with the biochemical markers plus with NT scan.
It is done freely.
No, sir. Actually, patient has to pay.
Okay.
No patient is affording.
Sir,
They are not affordable, no, to pay that much for screening. Yes, sir.
Anybody is sponsoring or anybody is sponsoring?
Madam, what she's saying is
paying, so we are actually counseling them because actually it is recommended first trimester screening with the biochemical markers. So we counsel them. So only few patients who are not willing to pay, we are doing that NT scan alone to look for the chromosomal detections, chromosomal abnormalities.
Okay, madam.
Normally, it is routinely being done during first trimester for every pregnant patient for the Down syndrome. So she has taken that parameter and correlated with the occurrence of the GDM. So for every, it is universally being done if they can afford. If they cannot afford, only the NT scan is being done.
In IOG, they won't accept.
Okay, it's all right. It's all right. She has found it in this study. Okay, madam, what is the duration or the interval between the observation of your PAP is low and when the pregnant woman develops gestational diabetes? Any observation in that?
So that's what I have few patients who have developed before 28 weeks. I have taken as one group, and who have developed after 28 weeks also. We are doing like a routine screening only. So
no, at what period you do it, doctor? At what period you do it?
So initially at the first visit we are doing.
First visit. Okay.
We are not taking her into the study because we are doing the scan investigation between 11 to 13 plus 6.
Yes. Okay.
So afterwards we'll repeat at 24 to 28 weeks and then again at.
Okay. Did you find out at all the 3 times? Did you do blood sugar?
Yes, sir.
Single test.
Yes, she did.
We are doing, sir. For all the patients who are coming for us from the beginning, we are doing this as a routine.
No. In this study, did you do that?
Challenge test. GCT.
Yes, sir. Only those cases we have included who have come for us.
Very good, madam. Very good. It is a nice study. Okay, nice study.
Right. So now we are at 3 o'clock, sir.
Okay.
Sir, one last question. Is there any association between the lowest level of your PAP-A along with the GDM, madam?
Yeah, that's what I asked.
I have seen one case with the 0.37, sir. That's the lowest, sir.
Like, is there values also correlating with that within the low range? Is there values are correlating with the severity of GDM in terms of patient needs medications for that?
Yes, sir. That is found to be, I don't know, sir. PAP-A less than 0.5 MOM is considered as low PAP-A. So that value is coming significant. Those requiring pharmacotherapy and who have been diagnosed before 28 weeks, the PAP-A, low PAP-A, they have less than 0.5 MOM, sir.
I have one comment. You mentioned that, first of all, thanks to Kirtika for keeping the JIPMER flag high. Thank you, Kirtika. And number 2 is the fact that and investigations become cheaper, Dr. Vijay madam, by more people doing it. So everything will be costly if it is used less. But I have seen over the years in the ministry, we wanted to do birth screening for everybody. It was not possible that time. Today, screening for some of the birth markers are possible because the charges are coming down. So I feel that the cost is a deterrent factor, but by doing it, whoever can afford, slowly the price will come down. The second point I want to make is that I think today the time has come that we have to take this one-step procedure to the doorstep. That's what I understood from the 2 talks, one by Bhavtarini, other by Panir. You see, Bhavtarini, that is one of our motto today in the ministry, to see whether we can deliver this service at the doorstep. You said about the paramedics. By the ASA workers, we are training them. I'll not take much time, and it is finding to very successful. That is also the factor which Panir referred to in the latest editorial. Paul Gibbet writes in Lancet Endocrinology that the genetic factors, the lifestyle factors, the behavioral factors are not as important as the epigenetic factor, which is the diabetes hyperglycemia. So if you have to prevent transgenerational transmission, which Professor Panir referred to, the rule is to deliver the service at the doorsteps. And you have beautifully touched upon, Bhavtarini, as usual, that it is to be taken doorstep. Otherwise, we cannot touch majority of the rural population and cannot touch also many of the urban slums, etc., etc. And for that matter, Our motto today is to carry healthcare to the doorsteps. Let us begin by the GDM. And Professor Sundaram, thank you very much for very energetic comments. Thank you so much. Does it come from Mysore? From where does it come from? I don't know. Beautiful comments. Thank you. I'm delighted to be here. Thank you for the invitation. I enjoyed the entire proceedings.
Always welcome.
Actually, this Downs test is done in all the private hospitals. We all will follow those cases, and we'll also again add to this points.
Yeah.
All the obstetrician in their association, please do this, and then collaborate. Then it will be a good thing. Now, I think Professor Das, you will agree with me. RSSDA has gone to the districts.
Yes, exactly.
Like that, OGG association and research projects should go to the districts, and from there you can spread this. This is a simple suggestion to you people.
Yeah. I think
that combinedly obstetrician and diabetologists can do together good things.
Yeah, 100%.
Sundaram sir, we have got a Tamil Nadu Federation now for the OG societies, and we have a research committee. We have subcommittees. In that, one is the research committee also. So
no, you have this at the district level. That's what I want.
Yeah,
have it at the district level. Conduct meetings.
Madam, what sir is saying?
OGCT is there. The single step DIPSI is there in PHC and the district hospitals. The only thing is the data is lacking. They are not submitting the data. That is why we are not able to analyze.
That's why research committee.
About this. Yes,
all private practitioners should do that.
They have to sensitize a medical officer to submit the proper data. That is the thing. We need at least one data after 28 weeks, if not in all 3 trimesters. That also we are not getting properly. So that is why we are not exactly find out the prevalence of GDM in Tamil Nadu.
Madam, that's what sir is saying. We have to, from OG, you have to put some coordinators in every district.
We have the NHM, ma'am. NHM is the main key role. Yeah.
Madam, your association, what I mean is, just like Diabetologists Association have research society in districts, now they conduct meetings, they contact each other within the district. So you can start OGG branches in various districts and through them carry out the research activity, collect some funds and show them the way. We are sitting in city, but when we go and meet them, this is what I think it's a simple suggestion.
Yes, sir.
I think we can wind up the mouth your talk.
Thank you, Ashok sir.
Madarani?
Thank
you, sir.
We can wind up.
Madarani, are you wind up or shall I?
Dr. Panneerselvam has to give the concluding remarks.
Right. So, all good things should
everyone
come to an
promised
end.
my leave, sir.
All right, madam. Thank you, madam.
Thank you, madam.
So, we have very purposefully and usefully spent this day to celebrate our beloved Professor Dr. Seshaya's birthday. So, we have discussed in elaborate depth with all GDM and its plus and minuses, how to implement all those things. I have to, as an organizing secretary, I have to profusely congratulate all our chairpersons and speakers who have prepared well and presented. Especially
and all the talks were very good. All the talks were class.
Thank you, sir. Thank you, sir. Especially our wholehearted thanks to you, sir, from all the way you have got connected and encouraged all of us and praised our professor with all of his previous backgrounds. So all youngsters who heard, especially delegates who heard, will get delighted and motivated because of your talk, sir. So we are always feel proud and happy to get associated with you and our Professor Seshaya sir, our Sundaram sir and Hariharan sir, etc. And all OG people, especially Director of OG, Dr. Vijaya and Dr. Dharmaraj, Periyandavar and Shanmugam and other Dr. Sampath Kumari and all OG who got involved. So our aim is we have to get involved continuously like this in all GDM day, not only on all GDM day, in between also we can meet and discuss and implement the program. So that is the purpose of our professor. So he told us that I have done my work, still I want to guide you, help you, but you people should get involved. Like that he should keep on motivating all of us. Of course, to an extent we are doing and we will continue to do. So my profuse thanks to all of you to participate in this event. And over to Dr. Periyandavar to say a few words and end the session.
Yes, sir. Thank you, sir, for coordinating well from the beginning, sir. And our regards and advanced birthday wishes to our professor, mentor, Professor Shesaya, sir. And moreover, the response is phenomenal from all our delegates. So more than 800 delegates has logged in. It's a very, even if it is a person to person, only maybe 100 or 150 would have been benefited. But now more than 800 people have logged in, and until the end, around 100 people they were on the line. So thanks for the program and guidance from Professor Shesaya.
The humble request to see the starting of the year. That is, we will start new things. What are to be done in GDM in the coming year, forthcoming year.
Now, thanks to the WOCARD SP gave this platform free of cost, and Novo supported this program, and Sunfarm also supported this program. On behalf of all of us, we thank these three major sponsors for this event. And I thank one and again for all of you for getting participated. I think we can wind up.
Thank you. Thank you very much.
Thank you. All the best.
Thank you, sir.
Happy birthday, Sesha, sir.
Thank you.
Yes, thank you, sir. Thank you. Sorry, still.
Bye-bye. Thank
Doctor,
you.
congratulations, doctor.
Thank you.
Very nice presentation. Congratulations.
Thank you, sir.
Okay.
Thank you for your energetic talk, sir.
Marcel,
Yes, sir.
Right. Hello, Das.
Yes, sir.
Bye.
Thank you very much. Thank you. Thank you. Thank you.
Right, sir.
Clean.
Thank you.
Right.
Right, sir.
Thank you.
Thank you.
Marshall is the man behind, sir.
Yes, we saw he's behind.
Marcel is the
Thank you,
master.
Dr.
Literally
Pushpa
also he's
also.
behind.
Pushpa, despite your ill health, you have helped us to organize. Thank you.
All right now.
Thank
Yes,
you,
sir. Thank you.
Thank you.
Sir Bhavadharni ma'am, congratulations for your award you're going to receive next.
Thank you, Pushpa.
என்ன அவார்டுமா சொல்லுங்க.
அது என்னமோ நான் சொல்றேன் சார், மெடிக்கல் எக்ஸலன்ஸ், சோஷியல் சர்வீஸ் அண்ட் விமென்ஸ் டே ப்ரோக்ராம் சார்.
Okay.
Teaching program and all is there. Evening after receiving, I'll let you know, sir. Thank you.
We are proud of you, madam.
Thank you, sir.
Not as a student, as a colleague. Now you are flourishing.
Sir, ure kallala naal manga.
ஆமா. Correct. And
madam இப்ப ஒரு கல்லுல நால் மாங்கா.
Okay, good. Professor Shesha used to tell this day of birth, his birthday has come because Bhavadharani was always at Delhi. He told me that. Yes, sir. So thank you very much for that.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you. Thank you.
We pray for your life
Thank you, sir.
and guidance.
Thank you, sir. Thank you so much.
Thank you. Thank you.
Sundaram sir, I'm ending the meeting. Sir, you are in mute. You are in mute, sir.